All right, so we are going to see this marathon series of today, starting with ophthalmology today. Visible and audible, please let me know. Okay, so see this in this all right, yeah, I think it's all okay. Okay, so what are we going to do in this 1 hour session of this ophthalmology? There are 15 questions in FMG. So let's see what are the 15 probable questions and revise the subsequent PYQs and PYTs related to those questions. All right. Good afternoon, everyone. First session for today. So as you attended the class में मैंने बताया था कि एक question is expected to come on this photo transduction, photo regeneration, photo transmission regarding the visual pathway. That when we want to see any object, that light is coming and converted to nerve impulse. Where at the retina, rods and cones. Because वहाँ पे there are pigments known as rhodopsin and rhodopsin. That is known as phototransduction. Remember this point, phototransduction. And here rods and cones are containing what? Rhodopsin, iodopsin. They split. See, rhodopsin, iodopsin contain which pigment? Vitamin A and opsin. So rhodopsin means a photopigment converts to vitamin A in phototransduction. Reverse happens in photo regeneration. That happens in dark. So dark, you tell me, vitamin A will regenerate to photopigments. Wait a minute. Audio is okay. I think audio is okay. But still, okay, I'll increase. Alright. Okay, now vitamin A is converted to photopigments. That happens in dark. That is photo regeneration. So phototransduction, photo regeneration. And third thing is photo transmission. So photo transmission means what? How the impulse in the retina goes into occipital cortex. That is 124 milliseconds. That is photo transmission. Alright. So what happens in rods and cones? They have photopigments. From here the impulse goes to bipolar, to ganglion, to nerve fiber axons, which forms the optic nerve, which cross at optic chiasma. And after optic chiasma, they go to optic tract, then lateral genital body, then visual cortex and occipital cortex in 124 milliseconds. That is photo transmission time. So one question is expected on this photo transduction, regeneration and transmission. That is a visual pathway. Hi. Okay. Then one question, see straight away let us revise the main questions. One question I think of course it will come that if there is a visual pathway lesion, what is the visual field defects? There is a favorite question of any exam. So let us see this visual field defects in the visual pathway, which we discuss in neuro-ophthalmology. So let's straight away discuss like this. That for example, it is a right side, this is straight away taken from DFX. Right side optic nerve lesion. What happens? Right side total blindness. That is right anopia. Hi Mukul, कैसे हो तुम? पंक्ता याद आ गया मुझे. Okay. Then second, if there is a optic chiasma lesion. So optic chiasma, nasal fibers are crossing. So what happens? There is a bitemporal hemianopia, means bilateral defect, और इसको heteronymous कहा जाता है. Heteronymous का मतलब क्या है? Opposite side effect. Now English ध्यान से सुनना. If the lesion is behind the chiasma on the left side, means retrochiasma lesions are contralateral homonymous. So third point क्या है? If there is a left optic tract lesion, it will be right homonymous hemianopia. Always visual field defect is taken as patient's view. You are the patient facing the screen. So this is your right visual field, this is the left visual field. So this is right homonymous hemianopia in left optic tract lesion. Now Vikas, dry eye wala, very good. Then temporal and parietal lobe are causing quadrant defect. temporal lobe affects inferior fibers, so superior quadrant nopia like this. तो इस क्वेश्चन में क्या है, ध्यान से देखना, दिस इज राइट साइड होमोनाइमस सुपीरियर क्वाड्रेंट नोपिया. तो राइट होमोनाइमस है तो लेजन इज बिहाइंड द chiasma on the left side. Temporal inferior fibers are involved, so superior quadrant like a pie in the sky. Exact opposite happens in parietal lobe lesions. Parietal lobe is this. इस पिक्चर जरा ध्यान से देखो, इसमें लेफ्ट होमोनाइमस इंफीरियर क्वाड्रेंटोनोपिया पाई इन द फ्लोर है, तो सुपीरियर विजुअल फील्ड इफेक्ट है, सुपीरियर फाइबर्स आर इन्वॉल्व, दैट इज parietal lobe fibers. और ऑप्टिक ट्रैक एंड ऑक्सीपिटल लोब में डिफरेंस क्या है, मैकुलर स्पेयरिंग का. सेंट्रल विजन इज स्पेयर्ड. So this is left homonymous. See this very carefully. Left homonymous heminopia है. So lesion is behind the chiasma on the right side. तो right optic tract नहीं है, right occipital lobe है. Why? Because central macula is spared, like a keyhole vision. Keyhole vision is seen in occipital lobe lesions. प्रिंस याद है मुझे, सब याद है. आज भी ना साइंटिस्ट की क्लास है. देखो निप्टो फाइल, तुम्हारे नाम सुन के ना, उस दिन भी तुम्हें बोला था नाम अच्छा रखो, तुम खुद का नाम रखना तो अच्छा नाम रखो ना. चलो ये है विजुअल पाथवे. तो एक क्वेश्चन ऑन विजुअल फील्ड डिफेक्ट्स. अब नाउ टेल मी डिफरेंस बिटवीन ऑप्टिक ट्रैक्ट एंड ऑक्सीपिटल लोब लीजन. वन इज मैकुलर स्पेयरिंग इज सीन इन ऑक्सीपिटल लोब लीजन. वन मोर पॉइंट, टेल मी प्यूपिल पाथवे, बिकॉज एक क्वेश्चन प्यूपिल पाथवे का भी आता है. तो आर प्यूपिल फाइबर्स अफेक्टेड इन ऑक्सीपिटल लोब लीजन? आंसर इज नो. व्हाई? बिकॉज जो प्यूपिल फाइबर्स हैं जो प्यूपिल कंस्ट्रिक्ट करते हैं, दे गो इनटू मिड ब्रेन, दे डोंट गो इनटू ऑक्सीपिटल लोब. सो ऑक्सीपिटल लोब लीजन हैज नॉर्मल प्यूपिल रिएक्शंस, व्हाइल ऑप्टिक ट्रैक में प्यूपिल का नाम क्या होता है? इफ देयर इज ऑप्टिक ट्रैक लीजन, प्यूपिल नेम इज नोन एज वर्निकेज प्यूपिल. ऑप्टिक नर्व लीजन होता है तो प्यूपिल नेम इज एमारोटिक प्यूपिल. कंप्लीट लीजन मीन्स नो रिएक्शन एट ऑल. बट पार्शियल होता है तो क्या कहते हैं उसको? स्विंगिंग फ्लैश लाइट, मार्कस गन प्यूपिल. तो अगेन कंप्लीट लीजन एमेरोटिक प्यूपिल, पार्शियल लीजन मार्कस गन प्यूपिल, ऑप्टिक ट्रैक वर्निकेज प्यूपिल. FMGE 2025 क्वेश्चन, आर्गल रॉबर्टसन प्यूपिल लीजन इन प्रीटेक्टल. नाउ प्रीटेक्टल इज इन्वॉल्व ओनली इन नियर पाथवे और लाइट पाथवे. सो आर्गल रॉबर्टसन प्यूपिल में क्या है? Light reflex is absent, near reflex is present. Most common cause is neurosyphilis. Okay, so amerotic, Marcus gun seen in optic nerve lesion, Wernicke's optic tract lesion, Argall Robertson accommodation reflex present, light reflex absent, pretectal lesion. ये afferent है pupil pathway के. Efferent कौन है? Efferent are third nerve and ciliary ganglion. और efferent lesion में ही तो होता है क्या? अनाइसोकोरिया. क्या डिफरेंस है अनाइसोकोरिया? मतलब डिफरेंस इन प्यूपिल साइज. सो थर्ड नर्व पाल्सी प्यूपिल इज डायलेटेड प्यूपिल. एडीज प्यूपिल व्हेन द लीजन इज सिलियरी गैंग्लियन इज डायलेटेड प्यूपिल. बट क्या डिफरेंस है थर्ड नर्व पाल्सी एंड एडीज में? दोनों में प्यूपिल फाइबर्स आर प्यूपिल इफरेंट फाइबर्स आर अफेक्टेड, सो प्यूपिल इज डायलेटेड लाइक यू सी इन दिस पिक्चर. डार्क में पेशेंट इज लुकिंग लाइक दिस. यू थ्रो द लाइट, राइट इज नॉट कंस्ट्रिक्टिंग, मीन्स राइट आई पैथोलॉजी इज देयर. नियर से कंस्ट्रिक्ट हो रहा है तो थर्ड नर्व पाल्सी नहीं हो सकता, क्योंकि थर्ड नर्व पाल्सी हैज अ प्रॉब्लम इन नियर रिफ्लेक्स ऑल्सो. और देयर इज अ डायग्नोस्टिक टेस्ट नोन एज डाइल्यूटेड पाइलोकार्पिन. इन द एंटायर वर्ल्ड डाइल्यूटेड पाइलोकार्पिन कैन कंस्ट्रिक्ट ओनली विच प्यूपिल? एडीज प्यूपिल. तो एडीज प्यूपिल में सिलियरी गैंग लीजन में डाइल्यूटेड पाइलोकार्पिन if put, pupil will constrict because of super sensitivity. एफरेंट कौन है? प्रिंस. एफरेंट मतलब कि प्रीटेक्टल लीजन तक. तो ऑप्टिक नर्व, ऑप्टिक ट्रैक्ट, ऑप्टिक chiasma, प्रीटेक्टल और एफरेंट. एफरेंट में कोई एनाइसोकोरिया मीन्स डिफरेंस प्यूपिल नहीं होता. ईफ्रेंट मतलब दो ही है सिर्फ, थर्ड नर्व पाल्सी, थर्ड नर्व एंड सिलियरी गैंग्लियन. उसमें एनाइसोकोरिया होगा, डिफरेंस इन प्यूपिल होगा, और दोनों डायलेटेड प्यूपिल हैं. तो डायल्यूटेड पाइलोकार्पिन इज अ टेस्ट फॉर एडीज प्यूपिल. ठीक है. अब एक और में एनाइसोकोरिया मिलता है, हॉर्नर सिंड्रोम. बट दैट्स द प्रॉब्लम इन विच पाथवे? सिंपैथेटिक पाथवे. अब सिंपैथेटिक पाथवे में क्या है? प्यूपिल डायलेट होता है. तो हॉर्नर्स प्यूपिल क्या है? व्हेन द प्रॉब्लम इन सिंपैथेटिक पाथवे प्यूपिल इज स्मॉलर. तो सी दिस पिक्चर भी आ सकती है. अब थ्योरेटिकल क्वेश्चन तो आया, पिक्चर भी आ सकती है. तो सी दिस पिक्चर इन शोइंग व्हाट इज हैपनिंग हियर. लेफ्ट प्यूपिल इज स्लाइटली स्मॉलर, दैट इज मायोटिक प्यूपिल. इसमें भी एनाइसोकोरिया है. टोसिस होगा पार्शियल बिकॉज ऑफ मुलर मसल ऑल्सो एलिवेट्स द आईलिड्स, सो पार्शियल टोसिस. डिफरेंस इन प्यूपिल साइजेस, डिफरेंस इन आइरिस कलर इज हेट्रोक्रोमिया, सिर्फ कंजेनाइटल हॉर्नर्स में मिल सकता है. स्वेटिंग भी लॉस्ट हो जाती है, बट स्वेटिंग लॉस को कहते हैं एनहाइड्रोसिस. पोस्ट गैंग्लियोनिक हॉर्नर सिंड्रोम में नहीं मिलेगा. पोस्ट गैंग्लियोनिक मतलब या तो आईसी एनोरिज्म या कैवर्नस साइनस सिंड्रोम, क्योंकि जो स्वेटिंग फाइबर्स हैं वो पोस्ट गैंग्लियोनिक में जाते नहीं हैं. और आपका एफएमजी का सवाल था कि अगर हॉर्नर सिंड्रोम है साथ में स्मोकिंग ब्रेथलेसनेस है तो क्या सिंड्रोम है. ट्यूमर का नाम पैनकोस ट्यूमर है. उसमें स्वेटिंग क्या रहेगी, लॉस्ट या नॉर्मल. स्वेटिंग उसमें लॉस्ट होगी. स्वेटिंग नॉर्मल पोस्ट गैंग्लियोनिक हॉर्नर सिंड्रोम में मिल सकता है, जैसे कैवर्नस साइनस सिंड्रोम, जैसे कि आईसी एनोरिज्म. ठीक है, तो ये एक प्यूपिल पे फटाफट से एमेरोटिक प्यूपिल, पार्कसगन प्यूपिल, ऑप्टिक नर्व लीजन कंप्लीट एंड पार्शियल, वर्निकेज ऑप्टिक ट्रैक लीजन, आर्गल रिवर्सल सिफिलिस प्रीटेक्टल लीजन, थर्ड नर्व पाल्सी एडीज आर इफरेंट प्यूपिल डायलेटेड है, पाइलोकार्पिन डायल्यूटेड पाइलोकार्पिन टेस्ट फॉर एडीज प्यूपिल, और हॉर्नर सिंड्रोम प्रॉब्लम इन सिंपैथेटिक पाथवे. तो हॉर्नर्स, एडीज और थर्ड नर्व पाल्सी में ही अनाइसोकोरिया मिलता है, डिफरेंस इन प्यूपिल साइज मिलता है. ठीक है, तो वन विजुअल फील्ड क्वेश्चन, वन प्यूपिल क्वेश्चन, वन फोटो ट्रांजैक्शन, फोटो रीजनरेशन. ठीक, अब एक सवाल तो जो आता है वो है क्या, अच्छा विजुअल फील्ड पे एक और सवाल आ सकता है, ये वाला विजुअल फील्ड, ये भी तो हो सकते हैं. विजुअल फील्ड ऑप्टिक नर्व डिसऑर्डर्स में भी हो सकते हैं, जैसे कि ग्लॉकोमा या नॉन ग्लॉकोमा. तो नॉन ग्लॉकोमा अगर मैं रिवाइज करूं लाइक ऑप्टिक न्यूराइटिस, तो ये मुझे लग रहा है आपको सवाल आएगा मल्टीपल स्क्लेरोसिस पे. ध्यान दो, मल्टीपल स्क्लेरोसिस में ऑल द सेंसेस आर डिक्रीज्ड. क्या सेंसेस, लाइट, कलर, कॉन्ट्रास्ट, एवरीथिंग. ऑप्टिक न्यूराइटिस में सेंट्रल फाइबर्स ऑफ द रेटिना आर अफेक्टेड. किसको याद है सेंट्रल फाइबर्स आर व्हाट, पैपिलोमैक्युलोबंडल फाइबर्स. तो सेंट्रल एंड सेंट्रोसिकल स्कोटोमा आर सीन इन ऑप्टिक न्यूराइटिस. अगर यंग पेशेंट है और पेनफुल आई मूवमेंट्स आ गया, फीमेल है साथ में, फीमेल है, पेनफुल आई मूवमेंट है, साथ में लिखा है कि ऑप्टिक डिस्क मार्जिन नॉर्मल है, तो आंसर होगा मल्टीपल स्क्लेरोसिस रेट्रोबल्बर न्यूराइटिस. पीछे की नर्व इन्वॉल्व होती है, जिसका रेडियोलॉजी में सवाल आता है, वो क्या होता है, डॉसन फिंगर वगैरह होता है. तो इंट्राविनस स्टेरॉइड फॉर 3 days, ओरल फॉर 11 days, दैट इज मल्टीपल स्क्लेरोसिस. तो मुझे लग रहा है कि मल्टीपल स्क्लेरोसिस पे एक सवाल आने वाला है, यही रेट्रोबल्बर होगा. उसमें ऑप्शन में लिखा होगा डिस्क मार्जिन नॉर्मल है, फिर भी आंसर रेट्रोबल्बर न्यूराइटिस है, क्योंकि इन्फ्लेमेशन इज बिहाइंड द ऑप्टिक डिस्क. ऑलराइट, so central and centrosical scotomas are seen in optic neuritis. Retrobulbar neuritis will be multiple sclerosis. Painful eye movement कीवर्ड है, रेट्रोबल्बर कीवर्ड है, ऑप्टिक डिस्क मार्जिन नॉर्मल हो सकते हैं. ठीक है, अब ग्लॉकोमा में, या फिर तो ये सवाल तो आपका फेवरेट सवाल है, ड्रग हिस्ट्री. दैट एंटी ट्यूबरकुलर ड्रग्स, टोबैको, अल्कोहल कैन कॉज सेंट्रल फाइबर्स अफेक्टिंग सेंट्रल स्कोटोमा, सेंट्रोसिकल स्कोटोमा. ठीक है, एनलार्जमेंट ऑफ ब्लाइंड स्पॉट की पिक्चर नीट एग्जाम में आई थी, नीट पीजी में. तो आपको एक्सपेक्टेड है, जरा ध्यान से देखो, एनलार्जमेंट ऑफ ब्लाइंड स्पॉट में क्या हो सकता है, हाई मायोपिया में हो सकता है, पैपिलेडीमा में हो सकता है, पैपिलेडीमा में ट्रांजिएंट ब्लाइंडनेस, जिसको एमरोसिस फिगॉक कहते हैं. तो हाई सीएसए प्रेशर है, बायलैटरल एनलार्ज ब्लाइंड स्पॉट है, तो आंसर हो जाएगा उसका पैपिलेडीमा. तो ये पिक्चर आ सकती है, क्या विजुअल फील्ड इफेक्ट दिखा रहे हैं, एनलार्ज ब्लाइंड स्पॉट, क्योंकि ब्लाइंड स्पॉट ऑप्टिक डिस्क की वजह से होता है. ऑप्टिक डिस्क का ब्लरिंग मार्जिन है या एनलार्ज है, तो एनलार्ज ब्लाइंड स्पॉट भी होगा. तो ये पिक्चर आ सकती है एनलार्ज ब्लाइंड स्पॉट की. और फिर लास्ट में अगर विजुअल फील्ड में सवाल आएगा तो वो आएगा ग्लॉकोमा के ऊपर. तो ग्लॉकोमा की डेफिनेशन क्या है, ऑप्टिक न्यूरोपैथी है, ओपन एंगल हो सकता है, क्लोज एंगल. ओपन का बोलते हैं जब व्हेन आइरिस इज ब्लॉकिंग द मेशवर्क, ट्रबैकुलर मेशवर्क, तो उसको ओपन एंगल ग्लॉकोमा कहा जाता है. ठीक है, और प्रेशर बढ़ने के कारण, प्रेशर कैसे चेक करते हैं, टोनोमेट्री से. ये पिक्चर आएगी गोल्डमैन एप्लानेशन टोनोमीटर, फ्लोरोसिन डाई, कोबाल्ट फिल्टर, इम्बर्ट फिक लॉ, दैट इज गोल्डमैन एप्लानेशन टोनोमीटर. तो ऑप्टिक डिस्क में चेंजेस, व्हाट आर द चेंजेस इन द ऑप्टिक डिस्क, व्हाट आर द चेंजेस इन द ऑप्टिक डिस्क, क्योंकि मैं DFX वहाँ से रिवाइज कर रहा हूँ ना। चलो ये लो, मैं जूम कर देता हूँ, सी दिस। इंक्रीज कप डिस्क रेशियो होता है ग्लॉकोमा में, थिनिंग ऑफ द न्यूरल रिम होता है। ये जो नर्व फाइबर एक्सॉन्स हैं दे फॉर्म द न्यूरल रिम, सो देयर इज अ थिनिंग ऑफ द न्यूरल रिम फॉर्मिंग इंक्रीज इन द कप डिस्क रेशियो। वेसल्स आर शिफ्टेड टुवर्ड्स द नेजल साइड, नेजलाइजेशन ऑफ वेसल्स, बेंड करके आते हैं, बेंडिंग ऑफ वेसल्स। ऑल दीज आर साइंस इन ऑप्टिक डिस्क एंड ग्लॉकोमा। नाउ इन ग्लॉकोमा व्हाट आर द विजुअल फील्ड इफेक्ट्स, व्हाट आर द विजुअल फील्ड इफेक्ट्स इन ग्लॉकोमा, ये भी सवाल इंपॉर्टेंट है। तो पहला जो चेंज है वो क्या होता है, आइसोप्टर कॉन्ट्रैक्शन, पैरासेंट्रल स्कोटोमा, फिर सीडल स्कोटोमा, फिर आर्कुएट, फिर डबल आर्कुएट लाइक अ रिंग स्कोटोमा। तो पैरासेंट्रल स्कोटोमा इज अ फर्स्ट डिफेक्ट इन ग्लॉकोमा। जब वो ज्वाइन करेगा ब्लाइंड स्पॉट उसको सीडल स्कोटोमा कहेंगे। बिकॉज विच फाइबर्स ऑफ द रेटिना आर मोस्ट कॉमनली इन्वॉल्व इन ग्लॉकोमा, सबसे पहले इन्वॉल्व कौन से होते हैं, 3 बताए थे, आर्कुएट, पैपिलोमैक्युलर बंडल, रेडिएटिंग में सबसे पहले कौन, आर्कुएट। तो आर्कुएट की वजह से पैरासेंट्रल स्कोटोमा इज द फर्स्ट डिफेक्ट। उसके बाद ज्वाइन करेगा ब्लाइंड स्पॉट को सीडल स्कोटोमा, फिर आर्कुएट स्कोटोमा, फिर डबल आर्कुएट स्कोटोमा, फिर उसके बाद लास्ट अफेक्ट इज टेम्पोरल, क्योंकि रेडिएटिंग फाइबर्स आर मोस्ट रेजिस्टेंट टू ग्लॉकोमा, दैट्स व्हाई टेम्पोरल विजन इज द लास्ट टू बी अफेक्टेड। तो विजुअल फील्ड पे सवाल मैं स्ट्रेस करके बता रहा हूँ, चाहे ऑप्टिक न्यूराइटिस वाला आए या ग्लॉकोमा वाला आए, या तो अगर पूरा का पूरा ऑप्टिक नर्व डैमेज है तो अनोपिया हो जाएगा, फिर ऑप्टिक क्याज्मा, ऑप्टिक ट्रैक, ऑक्सफोर्ड लोब, ये सारे विजुअल फील्ड इफेक्ट्स ही हैं जिस पे एक सवाल आपको ज़रूर आता है। तो अभी तक मैंने 3 सवाल डिस्कस करे हैं, प्यूपिल, विजुअल फील्ड, जो ग्लॉकोमा नॉन ग्लॉकोमा, और एक फोटो ट्रांसडक्शन रीजनरेशन। अब 4 जो हम डिस्कस करूंगा, अच्छा इसके साथ मैं ग्लॉकोमा का एक सिनेरियो बता देता हूँ, जो मैंने कहा था आपको 2 बताऊंगा सिनेरियो, सारे तो डिस्कस नहीं कर सकते मैराथन में। तो अगर बच्चा है बड़ी बड़ी बिग ब्लू आइज विद वाटरिंग, फोटोफोबिया, ब्लेफरोस्पैज्म, उसका आंसर होगा प्राइमरी कंजेनिटल ग्लॉकोमा, जिसमें एक्सियल मायोपिया होता है, हैब स्ट्राया मतलब कॉर्निया में स्ट्राइएशन मिलते हैं, गोनियोटॉमी करते हैं, उसमें एक बार्कन मेम्ब्रेन है विच इज ब्लॉकिंग द ट्रैक। अच्छा ब्लॉकिंग द मेशवर्क होगा तो ओपन एंगल मैकेनिज्म होगा वो। तो पूरा सिनेरियो है प्राइमरी कंजेनिटल ग्लॉकोमा का। और एक सिनेरियो जो मैंने क्लास में स्ट्रेस करके बताया था, ये एक्सपेक्टेड इस बारी बताना आंसर, ये यंग मायोपिक मेल है, एक्सरसाइज करने के बाद आता है, प्रेशर बढ़ जाता है। अ यंग मायोपिक मेल कम्स आफ्टर एक्सरसाइज विद वेरी हाई प्रेशर, व्हाट सेकेंडरी ग्लॉकोमा इज दिस, क्या नाम है, सूडो एक्सफोलिएशन या पिगमेंट डिस्पर्शन? आंसर इज पिगमेंट डिस्पर्शन, पिगमेंटरी ग्लॉकोमा। पिगमेंटरी ग्लॉकोमा इज रिवर्स ग्लॉकोमा। आफ्टर एक्सरसाइज iris pigments are very close to zonules, they rub, और iris pigments are stick to the posterior part of cornea, उसे कहते हैं, INICET क्वेश्चन आया था इसलिए बता रहा हूँ, क्रुकेनबर्ग स्पिंडल्स इसे कहा जाता है, दैट इज सीन इन पिगमेंटरी ग्लॉकोमा। तो क्रुकेनबर्ग स्पिंडल्स आर पिगमेंट्स ऑन द पोस्टीरियर सरफेस ऑफ द कॉर्निया, सीन इन विच ग्लॉकोमा, अगेन पिगमेंटरी ग्लॉकोमा। फिर क्रुकेनबर्ग स्पिंडल सीन इन पिगमेंटरी ग्लॉकोमा, यंग मेल आफ्टर एक्सरसाइज हाई प्रेशर, पिगमेंटरी ग्लॉकोमा। और पिक्चर आती है बार बार, नीट एग्जाम में भी आती है। एक तो हाइफीमा की पिक्चर आपको इजी पिक्चर आई थी अभी जनवरी में, ब्लड इन एंट्री चेंबर, ये ट्रैबेकुलर मेस्ट्रो को ब्लॉक करेगा तो ओपन एंगल करेगा। फिर सिलिकॉन ऑयल जो डिस्कस करेंगे हम एक सर्जरी में, रेटिना की सर्जरी में, वो इन्वर्टेड हाइपोपियन होता है। हाइपोपियन तो येलो होता है ना, अगर ऊपर चले जाए तो सिलिकॉन हाइपोपियन, ये दोनों ओपन करेंगे। ये सूडो एक्सफोलिएशन की पिक्चर आती है बार बार, मोस्ट कॉमन सेकेंडरी ग्लॉकोमा इज सूडो एक्सफोलिएशन। डैंड्रफ मटेरियल है, क्लोज डिफरेंशियल इज वॉशियस रिंग। ये वॉशियस रिंग क्यों नहीं है, क्योंकि वो ब्राउन पिगमेंट होता है, डैंड्रफ तो वाइट होता है ना, तो डैंड्रफ इज वाइट मटेरियल, दैट इज सूडो एक्सफोलिएशन ग्लॉकोमा, मोस्ट कॉमन सेकेंडरी ग्लॉकोमा। इसकी पिक्चर एग्जाम में आपको आएगी, आ सकती है, क्योंकि नीट एग्जाम में INICET में आ चुकी है सिर्फ पिक्चर। डैंड्रफ मटेरियल अगेन सूडो एक्सफोलिएशन ग्लॉकोमा। और अगर आइरिस में वेसल्स दिखें, दैट इज न्यू वास्कुलर ग्लॉकोमा। ये मैं अब डिस्कस करूंगा, क्योंकि ये मेरा 5th क्वेश्चन है आपके लिए, जो होगा डायबिटिक रेटिनोपैथी या रेटिना से। तो कौन सा स्टेज ऑफ डायबिटीज में न्यू वेसल्स मिलते हैं आइरिस में या रेटिना में, प्रोलिफरेटिव या नॉन प्रोलिफरेटिव? प्रोलिफरेटिव है। अगर एक पेशेंट है डायबिटीज़ का और उसके आ गया कि न्यू वेसल्स आर देयर, न्यू वेसल्स अगर आ गया तो इसका मतलब वो क्या होगा, प्रोलिफरेटिव स्टेज होने वाला है। और उसमें क्या क्या आएगा, न्यू वेसल शब्द कहीं पे भी आए, चाहे आइरिस पे आए, एंगल पे आए, या रेटिना में आए, या डिस्क में आए, तो प्रोलिफरेटिव स्टेज है। उसके लिए पैन रेटिनल फोटोकोगुलेशन करा जाता है टू डिस्ट्रॉय द हाइपोक्सिक रेटिना। बट अगर न्यू वेसल रेटिना में रेटिना को ऊपर खींचते हैं तो आपका 6 सवाल आ जाएगा, रेटिना डिटैचमेंट कौन सा होगा। डायबिटीज़ में रेटिना डिटैचमेंट होगा, नाम याद रखो ट्रैक्शनल, रेटिना पुल हो रहा है ऊपर, तो ट्रैक्शनल डिटैचमेंट भी प्रोलिफरेटिव स्टेज में आता है। और विट्रस हेमरेज, डायबिटीज़ में एक ही कंडीशन है जो सडन डिक्रीज विजन करेगी, वो है विट्रस हेमरेज, क्योंकि न्यू वेसल्स एबनॉर्मल हैं, वो लीक करेंगे ब्लड, द ब्लड विल गो इनटू विट्रस कैविटी। और कभी भी विट्रस जेल होता है, उसमें कोई भी पिगमेंट आए, ब्लड आए, तो पेशेंट को फ्लोटर्स आएगा। तो ध्यान दो, फ्लोटर्स अगर आपके एग्जाम में आया, यू हैव टू सस्पेक्ट पैथोलॉजीज इन विट्रियस। तो विट्रियस में फ्लोटर्स हैं, विट्रस हेमरेज है, सडन डिक्रीज विजन है, डार्क ग्लो है, तो आंसर विट्रस हेमरेज है, वो भी प्रोलिफरेटिव स्टेज में आएगा। तो न्यू वेसल शब्द दिख गया डायबिटीज में, तो आंसर इज पैन रेटिनल फोटोकोगुलेशन। ठीक है। बट अगर ऐसा आया आपको पिक्चर, ये एक एंजियोग्राफी होती है, एंजियोग्राफी में डायबिटीज में फर्स्ट साइन इज लॉस ऑफ पेरिसाइट के कारण हाइपर फ्लोरेसेंट डॉट्स, क्या कहते हैं इसको, माइक्रो एनोरिज्म्स कहा जाता है, दैट इज हाइपर फ्लोरेसेंट डॉट्स ऑन एंजियोग्राफी। और फिर ये पिक्चर आइडेंटिफाई करने आ सकती है डायबिटीज में या किसी कंडीशन में, फ्लेम हेमरेजेस, डॉट एंड ब्लॉट हेमरेजेस, ये लार्ज फ्लफी आपके घर में कॉटन वूल होता है, कॉटन वूल स्पॉट किसको कहते हैं, सॉफ्ट एक्सुडेट को कहते हैं। और स्मॉल शाइनी येलो जो होते हैं वो हार्ड एक्सुडेट होते हैं। तो ये नॉन प्रोलिफरेटिव स्टेज में आते हैं, एनपीडीआर में आते हैं। कॉटन वूल स्पॉट इज नर्व फाइबर लेयर इन्फेक्शन, दैट इज सॉफ्ट एक्सुडेट। तो अब मुझे बताओ कि अगर ये हेमरेजेस रेटिना में और ये कॉटन वूल स्पॉट रेटिना के चारों तरफ ऑल द क्वाड्रेंट्स में मिलेंगे, साथ में टॉर्चुअस डायलेटेड वेन मिलेगा, तो आंसर क्या हो जाएगा, टोमेटो स्प्लैश अपीयरेंस जिसको कहते हैं। 100 दिन में ग्लॉकोमा होता है, उसको CRVO कहा जाएगा, जिसमें आर्टेरियोवेनस रेशियो 1:4 होगा। नॉर्मल बताओ, कौन बताएगा, नॉर्मल आर्टेरियोवेनस रेशियो इज 1 नॉर्मल रेशियो 2:3, आर्टरी ल्यूमेन इज नैरो देन द वेन। हाइपरटेंशन में 1:3, आर्टरी बिकम थिक कंप्रेसिंग द वेन, और वेन को कंप्रेस कर दिया तो वेन टॉर्चुअस हो जाएगी 1:4। तो अगेन नॉर्मल आर्टेरियोवेनस रेशियो 2:3, हाइपरटेंशन 1:3, वेनस ऑक्लूजन 1:4। तो इस CRVO में टोमेटो स्प्लैश अपीयरेंस, CRAO में आर्टरी ऑक्लूजन एम्बुलस की वजह से होती है, जिसमें पेशेंट को वो एम्ब्रोसिस फिगॉक्स होगा। ध्यान दो, पैपिलोडीमा में भी था, यहाँ पे भी, बट यहाँ पे हिस्ट्री होगी रोमैटिक हार्ट डिजीज की, एरिथमिया की, क्योंकि एम्बुलस ब्लॉक करेगा आर्टरी को, तो ये भी सडन डिक्रीज करेगा। और चेरी रेड स्पॉट का डिफरेंशियल है CRAO। चेरी रेड स्पॉट तो बहुत फेवरेट सवाल है, लास्ट टाइम FMGE में 2023, 24, इवन 2026 में जनवरी में आया था। चेरी रेड स्पॉट के डिफरेंशियल में CRAO आएगा। गैंग्लियोनिक्लेयर रेटिना की इफेक्ट होती है, रेड नॉर्मल है या रेड इन्वॉल्व है, रेड नॉर्मल है, फोबिया स्पेयर्ड है, फोबिया स्पेड है, गैंग्लियोनिक्लेयर फोबिया पे होती नहीं है। इसके डिफरेंशियल याद करने हैं, चेरी ट्रीज नेवर ग्रो टॉल। तो दो ही कंडीशन है आइज में, CRAO जिसमें हिस्ट्री होगी एरिथमिया, रोमैटिक हार्ट डिजीज, और या तो ब्लंट, किसी ने मुक्का मारा, ब्लंट ट्रॉमा, बर्लिन एडीमा। बाकी नीमैन पिक, GM ग्लैंग्लोसाइट, टेसैक, सैंड ऑफ, नीमैन पिक में ऑर्गेनोमेगैली मिलेगी, टेसैक में नहीं मिलेगी, इसमें गैंग्लियोनिक्लेयर इन्वॉल्व होती है। तो चेरी रेड स्पॉट के डिफरेंशियल बड़े इंपॉर्टेंट है। फिर एक पिगमेंटोजा, रेटिनाइटिस पिगमेंटोजा की पिक्चर आपको ध्यान से पूछ सकते हैं कि पेरिफेरी रेटिना में ये रॉड्स एंड कोन्स की प्रॉब्लम है, तो बताओ इसमें कौन सा टाइम बढ़ जाएगा, रॉड ज़्यादा इफेक्ट होते हैं कौन से, तो ये डिलेड डार्क अडेप्टेशन मतलब फोटो रीजनरेशन टाइम बढ़ जाएगा। बोनी स्पेक्यूल्स होते हैं, आर्टिकुलर एटेन्युएशन, वैक्सी पैलर, ये है ट्राइड ऑफ पिगमेंटोजा। रॉड ज़्यादा इफेक्ट होते हैं, इलेक्ट्रोरेटिनोग्राम इज द इन्वेस्टिगेशन ऑफ चॉइस, ये याद रखना है, A वे पहला, B वे बाद में, दैट इज अ ट्रायड ऑफ रेटिनाइटिस पिगमेंटोसा, पिक्चर भी आ सकती है, ब्लैक पिगमेंट्स पेरिफेरी में, तो टनल विजन रिंग स्कोटोमा हो सकता है। कितना स्कोटोमा होना चाहिए रिंग स्कोटोमा, किसको ब्लाइंड कहते हैं हम? ब्लाइंडनेस की डेफिनेशन याद है? लेस देन 3/16 बेटर आई, इंडिया कहते हैं अवेलेबल करेक्शन, WHO कहते हैं बेस्ट करेक्शन, और सेंट्रल रेटिना, सेंट्रल विजुअल फील्ड लेस देन 10 डिग्रीज, दैट इज ऑल द डेफिनेशन ऑफ ब्लाइंडनेस। ये 10 डिग्रीज वाला एक्सेप्टेड बाय इंडियन WHO। ठीक है, तो डायबिटीज में कौन सा रेटिना डिटैचमेंट? ट्रैक्शनल। मैंने प्रेडिक्टेड सीरीज में बताया था, प्रेग्नेंट लेडी में रेटिना डिटैचमेंट होगा तो आंसर होगा एक्सुडेटिव। और हाई मायोपिया में फ्लोटर्स हैं, फ्लैशेस हैं, कर्टेन साइन है, फील्ड इफेक्ट है और रेगमेटोजेनस, जिसके लिए वो विट्रो रेटिनल सर्जरी करते हैं, जिसमें सिलिकॉन ऑयल डालते हैं। विट्रस निकाल के सिलिकॉन ऑयल डालेंगे, सिलिकॉन ऑयल ऊपर जाएगा, और ऊपर जाएगा तो क्या करेगा वो, क्या कहेंगे उसको? इन्वर्टेड हाइपोपियन, जिसकी पिक्चर आ सकती है। और किससे रिप्लेस करेंगे? या तो एयर SF6 गैस से या सिलिकॉन ऑयल से। सिलिकॉन ऑयल ऊपर जाएगा तो ये पिक्चर आएगी, जिसको इन्वर्टेड हाइपोपियन कहेंगे, जो सेकेंडरी ओपन एंगल ग्लॉकोमा कर सकता है। तो फ्लोटर्स, फ्लैशेस, कर्टेन साइन, रेगमेटोजेनस डिटैचमेंट। अच्छा, सिर्फ फ्लोटर्स और फ्लैशेस आए, कर्टेन साइन नहीं आएगा, तो पोस्टीरियर विट्रस डिटैचमेंट होता है, जो आगे जाके रेटिना डिटैचमेंट कर सकता है। तो पोस्टीरियर विट्रस डिटैचमेंट और रेगमेटोजेनस में कर्टेन साइन, विजुअल फील्ड डिफेक्ट इज वेरी वेरी इंपॉर्टेंट साइन। तो एक तो 7th क्वेश्चन आएगा मेरा रेटिना डिटैचमेंट का भाई। फिर से, प्रेग्नेंट लेडी रेटिना डिटैचमेंट एक्सुडेटिव, डायबिटीज ट्रैक्शनल, हाई मायोपिया FFF, फ्लोटर्स, फ्लैशेस, फील्ड डिफेक्ट इज रेगमेटोजेनस। ठीक है, फिर रेटिना में एक आपका फेवरेट सवाल आता है, ये वाला, सिस्टोइड मैकुलर एडीमा, थिकनेस बढ़ जाती है सेंट्रल रेटिना में, मल्टीपल कॉज। अच्छा, डायबिटीज़ में भी हो सकता है, बट ये अगर आ गया डायबिटीज़ में तो पहले इसका ट्रीटमेंट करेंगे एंटी VEGF इंजेक्शन से। कैटरेक्ट सर्जरी, जिस पे एक सवाल आएगा, कैटरेक्ट सर्जरी उसकी कॉम्प्लिकेशन जो नेक्स्ट डिस्कस करने वाला हूँ, तो अगर कैटरेक्ट सर्जरी की कॉम्प्लिकेशन है तो इरविन गैस सिंड्रोम कहते हैं, सवाल आ चुका है। और यूवीआइटिस होगा तो भी एनसेड देना पड़ेगा, स्टीरॉयड देना पड़ेगा। ड्रग्स याद करना, कौन सी ड्रग कर सकती हैं? प्रोस्टाग्लैंडिन, पाइलोकार्पिन, पैन करके याद करेंगे। प्रोस्टाग्लैंडिन, पाइलोकार्पिन, एड्रेनलिन, हाई डोज ऑफ नियासिन याद रखना है, नियासिन ओवरडोज। और इसमें एंजियोग्राफी में कैसा अपीयरेंस मिलता है? फ्लावर के पेटल की तरह, फ्लावर पेटल अपीयरेंस इन सिस्टोइड मैकुलर एडीमा। वो ऑप्टिकल कोहेरेंस टोमोग्राफी जो रेटिना की स्ट्रक्चर बताती है, उसमें थिकनेस बढ़ जाती है रेटिना की। ठीक है, अब कैटरेक्ट सर्जरी की कॉम्प्लिकेशन हो सकती है ये, तो कैटरेक्ट सर्जरी की मोस्ट कॉमन कॉम्प्लिकेशन बताओ, जिसमें आप देखो काफ़ी टाइम से सवाल नहीं आया, अब आएगा। बहुत इजी सवाल है, मैं पूछता हूँ। पेशेंट केम आफ्टर कैटरेक्ट सर्जरी विद ग्लेयर, डिक्रीज विजन विद ग्लेयर, एंड बहुत साल बाद आया, बहुत महीने बहुत साल बाद आया, विच इज द मोस्ट कॉमन कॉम्प्लिकेशन ऑफ कैटरेक्ट सर्जरी? क्या कहते हैं उसको? ये कहते हैं पोस्टीरियर कैप्सुल ओपेसिफिकेशन, ऑल्सो नोन एज एल्शनिक पर्ल्स, ऑल्सो नोन एज आफ्टर कैटरेक्ट। पीछे पोस्टर कैप्सूल जो छोड़ दिया था वहां पे ओपेसिफिकेशन हो जाता है, एल्शनिक पर्ल्स। ND या कैप्सुलोटॉमी से उसको ठीक करते हैं। तो ऐसे ही डिक्रीज विजन विद ग्लेयर अगर कैटरेक्ट सर्जरी के पहले हुआ, मतलब कौन सा कैटरेक्ट करेगा, तो आंसर होगा पोस्टीरियर सबकैप्सुलर कैटरेक्ट होगा। कैटरेक्ट सर्जरी के बाद होगा तो आंसर होगा PCO। फ्लोरोसिन डाई कोबाल्ट फिल्टर की बड़ी पिक्चर इंपॉर्टेंट है, बट एक टेस्ट भी होता है जिसमें यूज करते हैं, जिसका नाम है सीरियल टेस्ट। सीरियल टेस्ट पॉजिटिव हुआ मतलब एक्वस इंसिजन के बाहर आ रहा है, दैट इज इंसिजन इज लीकिंग, तो इंसिजन लीक करेगा, एक्वस बाहर आएगा तो शैलो AC हो जाएगा और लो IOP हो जाएगा। नॉर्मल IOP कितना? 10 to 21। तो अगर लिखा गया है कि पेशेंट को लो IOP है 6 मिलीमीटर है, मान लो शैलो AC है, तो सीरियल टेस्ट करके कंफर्म करेंगे इंसिजन लीक। और इंसिजन लीक हुआ तो क्या करोगे? सूचर करोगे, किससे? नायलॉन से, 10-0 नायलॉन। कॉर्निया स्क्लेरा में नायलॉन सूचर्स होते हैं, नॉन एब्जॉर्बेबल होते हैं। फेको इमल्सिफिकेशन में सूचर यूज नहीं करते, कौन से में यूज करते हैं? ECC, SICS में। फिर एंडोथर्माइटिस पे सवाल देखो, एक्यूट रेड आई पे सवाल आता है। ये हाइपोपियन है, जिसकी पिक्चर आ सकती है, इजी हाइपोपियन है, बट इसके साथ साथ हाइपोपियन है, साथ में विट्रस भी इन्वॉल्व है, मतलब एक्वस भी इन्वॉल्व है, विट्रस भी इन्वॉल्व है, तो एंडोथर्माइटिस आंसर हो जाएगा। कॉर्निया स्क्लेरा इन्वॉल्व नहीं है। अगर कॉर्निया स्क्लेरा इन्वॉल्व है तो पैनऑप्थल्माइटिस हो जाएगा। इसका मोस्ट कॉमन ऑर्गेनिज्म स्टैफ एपिडर्माइटिस है। नॉर्मल कमेंसल आइलेट्स का ये सवाल आपको आ चुका है। 1 महीने के बाद आएगा तो प्रोपेरबेट एक्ने आंसर हो जाएगा। और इसका ट्रीटमेंट करेंगे इंट्राविट्रल इंजेक्शन ऑफ एंटीबायोटिक्स। ठीक है, तो ध्यान दो, एंडोप्थल्माइटिस में एक्वस और विट्रस दोनों इन्वॉल्व हैं। अगर डिक्रीज आई मूवमेंट्स होगा तो उसका आंसर हो जाएगा पैनऑप्थल्माइटिस। उसके लिए सिस्टमिक एंटीबायोटिक दिया जाएगा। एंडोप्थल्माइटिस के लिए इंट्राविट्रल इंजेक्शन ऑफ एंटीबायोटिक दिया जाएगा। अब देखो, ऐसे ही हाइपोपियन आएगा, मतलब एक्यूट रेड आई आया, हाइपोपियन आएगा, साथ में कॉर्नियल अल्सर है, तो आपका 8वां या 9th सवाल कॉर्नियल अल्सर पे है। एक कैटरेक्ट सर्जरी की कॉम्प्लिकेशन आ गया 8th। 9th आएगा केराटाइटिस। तो साथ में अगर ड्राई, रफ टेक्सचर, फेदरी मार्जिन हैं तो आंसर हो जाएगा क्या? साइंस हैं ज़्यादा, सिम्टम्स आर लेस, दैट इज फंगल केराटाइटिस। जिसमें साइंस ज़्यादा हैं, हाइपोपियन है, ड्राई रफ टेक्सचर है, सिम्टम्स कम है, नाइटामाइसिन देते हैं। बट अगर सिम्टम्स आर मोर, बहुत ज़्यादा पेन है, कॉन्टैक्ट लेंस की हिस्ट्री है, बट डर्टी वाटर से वॉश किया है, तो और रिंग इन्फिल्ट्रेट्स भी हैं, तो अकैंथमीबा है। सिर्फ कॉन्टैक्ट लेंस होगा तो सूडोमोनास मोस्ट कॉमन है। कॉन्टैक्ट लेंस के साथ नलके के पानी से धो के पहना है तो अकैंथमीबा है। रिंग इन्फिल्ट्रेट्स कीवर्ड्स हैं। और मैंने कहा था सवाल आपको आ सकता है क्योंकि INSCT में आया था। सिर्फ पूछेंगे स्टेन कौन सा है। स्टेन का नाम है कैल Q4 वाइट, कल्चर का नाम है नॉन न्यूट्रेंट इकोलाई, हो जाएगा अकैंथमीबा। साइंस आर लेस, सिम्टम्स आर मोर। और तीसरा जो बड़ा फेवरेट सवाल है जो जनवरी में भी आया था, क्या है ये? फ्लोरोसिन डाई, कोबाल्ट फिल्टर, ग्रीन अल्सर है, डेंड्राइटिक अल्सर है, हर्पी सिम्प्लेक्स, जिसमें कॉर्नियल सेंसेशन कम हो सकती है। एक ही में कम होगी, वायरल में डेंड्राइटिक है, लीनियर ब्रांचिक, तो हो जाएगा हर्पी सिम्प्लेक्स, जिसमें एसाइक्लोविर देते हैं ऑइंटमेंट 5 टाइम्स अ डे। स्टेरॉइड इज कॉन्ट्राइंडिकेटेड। और एडजुवेंट कौन सी ड्रग है? किसी भी एनी केराटाइटिस एडजुवेंट इज साइक्लोप्लेजिक्स टू डिक्रीज सिलियरी बॉडी स्पैज्म। ठीक है, और टॉपिकल स्टेरॉइड इसमें नहीं देते क्योंकि वो अल्सर को स्प्रेड करेगा, ज्योग्राफिक अल्सर करेगा। तो कॉर्नियल अल्सर केराटाइटिस पे 3 है, फंगस, अकैंथमीबा और वायरस। वायरस में भी हर्पिस सिम्प्लेक्स का डेंड्राइटिक अल्सर। बट अब अगर ऐसी हाइपोपियन आया, कॉर्निया इन्वॉल्व नहीं है, बट दिया गया है प्यूपिल छोटा है, स्मॉल प्यूपिल है, एक्यूट रेड आई है, हाइपोपियन है, स्मॉल प्यूपिल है, मान लो केरेटिक प्रेसिपिटेट दिया हुआ है, तो आंसर हो जाएगा क्या? एंटीरियर यूवीआइटिस। एक्यूट एंटीरियर यूवीआइटिस का मोस्ट कॉमन कॉज हमें नहीं पता, तो कौन सा इन्वेस्टिगेशन करना चाहिए? जनवरी का सवाल, HLA B27 टू रूल आउट एंकलोजिंग स्पॉन्डिलाइटिस। तो कीवर्ड क्या है? केरेटिक प्रेसिपिटेट, स्मॉल कंस्ट्रिक्टेड प्यूपिल, वेरी इंपॉर्टेंट, यूवीआइटिस। इसमें भी ट्रीटमेंट ऑफ चॉइस टॉपिकल स्टेरॉइड। एडजुवेंट कौन है? साइक्लोप्लेजिक। और साइक्लोप्लेजिक दोगे तो प्यूपिल का साइज क्या हो जाएगा? इंक्रीज हो जाएगा। तो ये कैसा प्यूपिल बन जाता है? ये वाला ऐसा, क्या कहते हैं इसको? यूवीआइटिस में अगर साइक्लोप्लेजिक हो, प्यूपिल बिकम लार्ज डायलेटेड फेस्ट्यून्ड प्यूपिल। तो फेस्ट्यून्ड प्यूपिल की 2 बारी पिक्चर आई थी जनवरी में। फेस्ट्यून्ड प्यूपिल दिया तो क्या ड्रग दिया होगा? एट्रोपिन दिया होगा, साइक्लोप्लेजिक दिया होगा, या कौन सा ग्लॉकोमा होगा? यूवीआइटिक ग्लॉकोमा होगा। जो प्राइमरी है, सेकेंडरी है? सेकेंडरी है। अच्छा, मटन फैट तो हो गई, ग्रेनुलोमेटस यूवीआइटिस में, वेरी गुड। अच्छा, ये बताओ मुझे सवाल कि अगर किसी पेशेंट को एक्यूट रेड आई है, हाइपोपियन है, प्रेशर बहुत ज़्यादा बढ़ा हुआ है, बट प्यूपिल लार्ज डायलेटेड है, तो आंसर क्या होगा? एक्यूट रेड आई पे 2 सवाल आएंगे। एक्यूट रेड आई है, हाइपोपियन है, प्रेशर बहुत ज़्यादा बढ़ा हुआ है, तो आंसर वॉक्ड स्ट्राइड की वजह से क्या होगा? एक्यूट एंगल क्लोजर हो जाएगा। छोटी आईबॉल में होता है, प्यूपिल ब्लॉक मैकेनिज्म होता है, आइरिस एट्रोफी की वजह से प्यूपिल डायलेटेड है। तो प्यूपिल डायलेटेड इज अ वेरी इंपॉर्टेंट कीवर्ड, दैट इज एक्यूट एंगल क्लोजर। वॉक्ड स्ट्राइड वर्ड इंपॉर्टेंट है, प्यूपिल ब्लॉक मैकेनिज्म इंपॉर्टेंट है, मैनिटॉल पहले देते हैं, ट्रीटमेंट अल्टीमेटली लेजर आइडोटोमी है। तो फिर से एक्यूट एंट्री यूवेटिस में प्यूपिल इज स्मॉल, एक्यूट एंगल क्लोजर में प्यूपिल इज वर्टिकली डायलेटेड प्यूपिल, वॉक्ड स्ट्रायड। तो एक्यूट रेड आई पे 2 सवाल आएंगे, तो 9th और 10th आपका एक्यूट रेड आई पे सवाल होगा जो मैंने आपको दिया है। अब बचे 5 सवाल। अब 5 सवाल में से एक सवाल कंजंक्टिवा में से आ सकता है। कंजंक्टिवा की सिनेरियो में एक इजी सिनेरियो आता है, बट सवाल काफ़ी है कि इफ़ द पिक्चर कम्स लाइक दिस, वाइट कलर के डॉट्स हैं, यंग बच्चा है, खुजली कर रहा है समर्स में, ऐसी पिक्चर है, इसको कॉबलस्टोन नहीं कहते, पैपिला कहते हैं, कॉबलस्टोन अपीयरेंस, तो वर्नल केरेटो कंजंक्टिवाइटिस होगा। ट्रीटमेंट क्या है उसका? टॉपिकल एंटीहिस्टामिनिक्स, क्योंकि एलर्जिक रिएक्शन है 1 और 4, समर में होता है, स्प्रिंग कहते हैं, स्प्रिंग में नहीं होता। तो हॉर्नर ट्रांटा डॉट को डिफरेंशिएट करते हैं हर्बेट पिट से। हॉर्नर ट्रांटा में वाइट डॉट्स होते हैं, एलर्जी है, टॉपिकल एंटी इन्फ्लेमेटरी एंटी एलर्जिक देते हैं। ऐसे ही किसमें मिलेगा? ये ब्लैक वाले हर्बेट पिट्स किसमें मिलेगा? ट्रैकोमा में मिलेगा। जो इन्फेक्शन है, इन्फेक्शन में फॉलिकल मिलते हैं, फिस्टो क्लासिफिकेशन, एजिथ्रोमाइसिन इज अ ड्रग ऑफ चॉइस, सेफ स्ट्रैटेजी इज अ ट्रीटमेंट। हर्बेट पिट्स आर फॉलिकल के डिप्रेशन है, पिक्चर आ सकती है, आई हुई हो कितनी बारी। तो हर्बेट पिट्स, ब्लैक डॉट्स एंड ट्रकोमा, हॉर्नर ट्रांटा, वाइट डॉट्स एंड वर्नल केरेटो कंजंक्टिवाइटिस। अच्छा, एक कंडीशन बताओ जिसमें कंजंक्टिवा कैन ग्रो ऑन टू द कॉर्निया। ये भी सवाल आया था। पेशेंट लेबरर है, बहुत सालों से काम कर रहा है, और एक ग्रोथ इज कमिंग ऑन टू द कॉर्निया फ्रॉम कंजंक्टिवा। क्या होता है वो होता है टेरिजियम। तो ये टेरिजियम जो अल्ट्रावायलेट रेज के कारण होता है, पहला सवाल। सेम पिंगेंकुला, ये कंजंक्टिवा की डीजनरेशन है। नेजल कंजंक्टिवा में ज़्यादा होता है क्योंकि यूवी रेज आर कमिंग एंड रिफ्लेक्टेड फ्रॉम द नोज एंड कमिंग टू द आईज। इसके कॉर्निया की तरफ होता है हेड, वहाँ पे स्टॉकर्स लाइन होती है, आयरन डिपोजिशन। ट्रीटमेंट इसका आया था आपको, क्या करेंगे? विजन डिक्रीज एस्टिग्मेटिज्म की वजह से, तो एक्सीजन विद ऑटो कंजंक्टिवल ग्राफ्ट या एमनियोटिक मेम्ब्रेन ग्राफ्ट। पिंगेंकुला सिर्फ पिक्चर आ सकती है, येलो कलर का फैटी डिपोजिशन, कुछ नहीं करना है इसमें। बट सेम अगर वाइट कलर का डिपोजिशन है तो बिट आउट स्पॉट तो मल्टी स्पेशलिटी क्वेश्चन है। आज बहुत सारे स्पेशलिटी आएंगे, सब बोलेंगे बिट आउट स्पॉट हमारा क्वेश्चन है। नहीं, अभी नहीं बोलेंगे, जब एग्जाम में आएगा तब बोलेंगे। कौन सी कैटेगरी में आता है? X1B स्टेज में आता है। विटामिन डेफिशिएंसी के कारण होता है बिट आउट स्पॉट, बट ये टेम्पोरल कंजंक्टिवा में ज़्यादा होता है। इसके विटामिन डोज देते हैं 0, 1, 14 डेज एज के अकॉर्डिंगली। तो पिक्चर बिट आउट स्पॉट इज़ वेरी इंपॉर्टेंट, ईजी बट वेरी इंपॉर्टेंट। कौन से स्टेज में? फिर बताओ। X1B स्टेज में। विटामिन इंपॉर्टेंट क्यों है? क्योंकि इट्स द मोस्ट कॉमन कॉज ऑफ चाइल्डहुड ब्लाइंडनेस इन इंडिया। ठीक है, तो पिंगेंकुला ट्रीटमेंट इज नॉट रिक्वायर्ड। टेरिजियम, एक्सीजन विद ऑटो कंजंक्टिवल ग्राफ्ट। सवाल है जनवरी 2026 का। सिस्टमिक ट्रीटमेंट इज गिवन फॉर विटामिन डेफिशिएंसी। अब एस्टिग्मेटिज्म की बात करें तो एस्टिग्मेटिज्म मतलब रिफ्रैक्टिव एरर। तो रिफ्रैक्टिव एरर पे सवाल क्या है? एक तो सिंपल मायोपिया का मतलब क्या है? रेज ऑफ लाइट आर फोकस इन फ्रंट ऑफ रेटिना और बिहाइंड रेटिना। रेज ऑफ लाइट आर फोकस इन फ्रंट ऑफ द रेटिना, दैट इज मायोपिया। बिहाइंड द रेटिना हाइपरमेट्रोपिया, और अलग अलग पॉइंट पे है तो एस्टिग्मेटिज्म। और किसने बताया था एस्टिग्मेटिज्म कॉन्सेप्ट? सवाल आया था, स्टूम्स ने बताया था। स्टूम्स कोनॉइड इज फॉर एस्टिग्मेटिज्म। तो सिंपल मायोपिया के लिए स्फेरिकल कॉन्केव लेंस, सिंपल हाइपरोपिया के लिए स्फेरिकल कॉन्वेक्स लेंस। और ये एस्टिग्मेटिज्म कॉन्सेप्ट गिवन बाय स्टूम्स। अलग अलग टाइप के एस्टिग्मेटिज्म है। सिंपल मायोपिक मतलब 1 रे ऑन द रेटिना, 1 बिफोर, बोथ बिफोर द रेटिना, कंपाउंड मायोपिक। 1 ऑन द रेटिना, 1 बिहाइंड, सिंपल हाइपरोपिक, बोथ बिहाइंड, कंपाउंड हाइपरोपिक, एक आगे एक पीछे, मिक्स्ड। और सिलेंड्रिकल लेंसेज आर गिवन फॉर एस्टिग्मेटिज्म। तो ये वाला एस्टिग्मेटिज्म क्यों नहीं है? मैंने डीएफसी में बताया था, क्योंकि रेज आर फोकस है सिंगल पॉइंट। ये सिंपल मायोपिया है। अब ये है आपका स्टूम्स प्रिंसिपल, ये पिक्चर आई थी, ये एस्टिग्मेटिज्म है। अब इसमें सवाल क्या आ सकता है वो मैं डिस्कस नहीं करूंगा रिफ्रैक्टिव एरर्स पे, वो सवाल अब तक आया नहीं, बट ये आ चुका है। देखो, अगर रेटिना इज एज्यूम टू बी पॉइंट नंबर ए पे, तो बोथ रेज मतलब देखो, रेड रेज फोकस एट बी पॉइंट, ब्लू हॉरिजॉन्टल एक्सिस है, फोकस एट एफ पॉइंट, तो एस्टिग्मेटिज्म हो गया। रेटिना ए पे मान लो बोथ रेज आर बिहाइंड द रेटिना, तो कंपाउंड हाइपरोपिक हो जाएगा। बी पॉइंट पे रेटिना है तो एक रेटिना पे एक रेटिना के बीच एक कंपाउंड हाइपरोपिक हो जाएगा। ठीक है, अब इसमें विद द रूल अगेंस्ट द रूल कैसे बोलेंगे? ये तो रटना है, बुरी तरह रटना है ना, BTR करना था कि वर्टिकल एक्सिस स्टीपर है तो उसको विद द रूल एस्टिग्मेटिज्म कहते हैं। और क्या मतलब है स्टीपर का? स्टीपर मतलब है कॉर्निया कन्वर्जिंग पावर ज़्यादा है। नॉर्मल कन्वर्जिंग पावर 44 डायप्टर्स होती है, तो जिसकी कॉर्निया कन्वर्जिंग पावर ज़्यादा है वो दो रेस के आपस में ज़्यादा आगे फोकस करेगी। तो कॉर्निया कन्वर्जिंग पावर इज मोर इज स्टीपर एक्सिस। इसमें खुद देखो, जो वर्टिकल है रेड है वो ब्लू से ज़्यादा आगे फोकस कर रही है, तो रेड स्टीपर हो गया और रेड वर्टिकल है, तो ये हो जाएगा पिक्चर विद द रूल एस्टिग्मेटिज्म। ठीक है, जिसके लिए सिलेंडर देना पड़ेगा, एस्टिग्मेटिज्म के लिए सिलेंडर देना पड़ता है। ठीक है, एक वो सवाल आया था अभी लैसिक रिफ्रैक्टिव सर्जरी पे। देखो सवाल क्या है, कब रिफ्रैक्टिव सर्जरी नहीं करते? 18 के पहले नहीं करते। थिन कॉर्निया में लैसिक नहीं कर सकते, सीवियर ड्राई आइज में लैसिक नहीं कर सकते। रेंज क्या है? +4 से -12। लैसिक पे सवाल आया था, तो ये सवाल ये सॉल्व हो गया था कि 18-13 साल के बच्चे में लैसिक नहीं, कोई भी रिफ्रैक्टिव सर्जरी नहीं कर सकते, 18 के पहले कर ही नहीं सकते। ठीक है, बाकी जो रिफ्रैक्टिव जो DFX में सवाल किए थे हमने, वो मैं डिस्कस नहीं करूंगा मैराथन में, क्योंकि आज तक वो PG एग्जाम में नहीं आए। बट रेटिनोस्कोपी क्या होता है? रेटिनोस्कोपी इज फॉर ऑब्जेक्टिव रिफ्रैक्शन। मैंने कहा था सब्जेक्टिव रिफ्रैक्शन पे सवाल आया था एक, क्या जैक्सन क्रॉस सिलेंडर की पिक्चर देख लेना जो आई भी थी जनवरी में। इसीलिए मैंने कहा था नियर विजन वाला जो है, नियर विजन की पिक्चर, वो रॉयल एयरफोर्स रूलर की पिक्चर देख लेना। तो नियर विजन कॉन्सेप्ट इज अकोमोडेशन। अकोमोडेशन कौन करता है? लेंस करता है। ट्रायड होता है, क्या होता है अकोमोडेशन में? प्यूपिल कंस्ट्रिक्ट होता है, कन्वर्ज होता है और आई अंदर चली आती है। और जैसे जैसे एज एडवांसेस लेंस बिकम रिजिड, अकोमोडेशन कम हो जाता है, नियर पॉइंट हमारी आंख से दूर चले आते हैं, उसको प्रेसबायोपिया कहा जाता है। तो प्रेसबायोपिया इज एज रिलेटेड कॉन्सेप्ट, दोनों आंखों में होता है, जिसके लिए बाइफोकल्स और नियर ग्लासेस दिया जाता है। या पाइलोकार्पिन ड्रग देते हैं 1.25। क्यों अप्रूव क्यों नहीं है? अप्रूव तो है बट देते क्यों नहीं है? क्योंकि पाइलोकार्पिन सिस्टोइड मैकुलर एडीमा कर सकती है। ठीक है, तो प्रेसबायोपिया इज अ नियर पॉइंट कॉन्सेप्ट। तो कौन सा रिफ्रैक्टिव एरर में अकोमोडेशन ज़्यादा होगी? हाइपरमेट्रोपिया ज़्यादा अकोमोडेट करते हैं बिकॉज रेज आर गोइंग बिहाइंड द रेटिना। तो उसको लाने के लिए हाइपरमेट्रोपिया ध्यान दो, अकोमोडेशन ज़्यादा करेंगे, और जैसे अकोमोडेशन करेंगे आंख अंदर चली आएगी, तो क्या कहेंगे उसको? स्क्विंट ईजोट्रोपिया। तो ईजो मतलब कन्वर्जेंट स्क्विंट होने के चांस किस में ज़्यादा हैं? हाइपरमेट्रोपिया में है। तो हाइपरमेट्रोपिया हैज़ मोर चांस ऑफ ईजोट्रोपिया। ईजो मतलब कन्वर्जेंट स्क्विंट। और कन्वर्जेंट कैसे बताओगे आप? कॉमिटेंट है या इनकॉमिटेंट है, या उसके पहले कितना डिग्री है? डिग्री भी आना चाहिए। ईजो में देखो ध्यान से, आई अंदर जा रही है, राइट ईजोट्रोपी है। अगर रिफ्लेक्स लिम्बस में है तो 45 डिग्रीज है। 1 डिग्री में 2 प्रिज्म डायप्टर होते हैं, तो 1 डिग्री इक्वल टू 2 प्रिज्म डायप्टर। अगर वो प्यूपिल बॉर्डर में है तो 15 डिग्री होगा, उन दोनों के बीच में तो 30 डिग्री। ये आपको सवाल FMG में आया था। तो कॉमिटेंट और इनकॉमिटेंट में फ़र्क क्या है? कॉमिटेंट में क्या है? आई मूवमेंट्स नॉर्मल रहेंगी। तो अगर आप कवर करोगे एक आंख को, फिक्सेटिंग आई को कवर करोगे, आई मूव कर जाएगी, उसे कहते हैं कॉमिटेंट स्क्विंट। और इनकॉमिटेंट में पैरालिटिक और रिस्ट्रिक्टिव होती है, वो आई मूव नहीं करेगी। तो कौन सा टेस्ट डिफरेंशिएट कॉमिटेंट फ्रॉम इनकॉमिटेंट? कवर टेस्ट, कवरिंग ऑफ द फिक्सेटिंग आई। इनकॉमिटेंट में आई मूवमेंट्स आर नॉट मूविंग। 2 कैटेगरी आती है, पैरालिटिक और रिस्ट्रिक्टिव। और पैरालिटिक में देखो एग्जाम्पल बताओ, 12th क्वेश्चन नर्व पाल्सी का। नर्व पाल्सी मतलब 3 ही है, थर्ड नर्व पाल्सी, फोर्थ नर्व पाल्सी, सिक्स नर्व पाल्सी। देखो भैया थर्ड नर्व पाल्सी में क्या है? थर्ड नर्व पाल्सी में टोसिस होगा, तो टोसिस एंड स्क्विंट हैज टू बी थर्ड नर्व पाल्सी। आई बॉल डाउन एंड आउट, डाउन बिकॉज ऑफ सुपीरियर ऑब्लिक, आउट बिकॉज ऑफ लैटरल रेक्टस, क्योंकि वही 2 मसल काम कर रही हैं। और टोसिस आ गया, प्यूपिल डायलेटेड भी आ गया, बताया था मैंने, इफरेंट पाथवे में आता है, तो दैट इज थर्ड नर्व पाल्सी। सिक्स नर्व पाल्सी में होगा क्या? सिक्स नर्व पाल्सी में होगा ये ईजोट्रोपिया। फोर्थ नर्व पाल्सी में होगा हाइपरट्रोपिया, बिकॉज फोर्थ नर्व क्या है? सप्लाइंग सुपीरियर ऑब्लिक, तो सुपर ऑब्लिक डिप्रेसर होती है। तो अगर किसी पेशेंट को, घबराने की बात नहीं है, देखो घबराना नहीं है, स्क्विंट में टोसिस है तो थर्ड नपाल्सी, स्क्विंट में ईजो है तो सिक्स नपाल्सी, और स्क्विंट में ऊपर जा रही आंख हाइपरट्रॉपी है तो फोर्थ नपाल्सी ही आंसर हो सकता है। मतलब एसोपाल्सी मतलब फोर्थ नपाल्सी। और मुझे बताओगे कि ये ईजोट्रोपिया होता है तो ईजोट्रोपिया में क्या होता है? डिप्लोपिया क्रॉस्ड अनक्रॉस्ड, एक्सो में क्रॉस्ड, ईजो में अनक्रॉस्ड। कौन से टेस्ट से पता लगा सकता है? ये एक वर्थ 4 डॉट टेस्ट का सवाल होता है, देख रहे हो। पहले ये डिस्कस करते हैं बाइनोक्लैरिटी, फिर डिस्कस कर लेंगे एम्ब्लायोपिया। तो देखो वर्थ 4 डॉट टेस्ट पे सवाल क्या है? इफ द पेशेंट 4 डॉट दिखाते हैं, एक रेड, 2 ग्रीन और एक वाइट। रेड के राइट आई हैज रेड गॉगल, लेफ्ट आई हैज ग्रीन गॉगल। बाइनोक्लैरिटी का टेस्ट है। 4 डॉट दिखे तो पेशेंट नॉर्मल है, 2 रेड डॉट दिखे मतलब कौन सी आंख काम कर रही है? राइट कर रही है, लेफ्ट सप्रेशन हो गई। ये सवाल आता है नीट एग्जाम में। 3 ग्रीन डॉट मतलब राइट आई सप्रेशन है। और ये आपका जैसे विजुअल फील्ड में इंटरप्रिटेशन है ना, ये इंटरप्रिटेशन आपकी तरह है। तो कौन बताएगा इसका आंसर? वर्थ 4 डॉट टेस्ट में ये पिक्चर दिखा दी तो क्या आंसर है? क्रॉस डिप्लोपिया अनक्रॉस्ड। आप पेशेंट हो, आपने राइट के सामने पहने रेड, लेफ्ट के सामने पहने ग्रीन, और आप स्क्रीन को देख के आप बता रहे हो रेड मेरे राइट की तरफ है, लेफ्ट ग्रीन मेरे लेफ्ट की तरफ है। तो ये हो जाएगा कौन सा डिप्लोपिया? अनक्रॉस्ड, जो किस में मिलेगा? ईजो में मिलेगा। अब ये सप्रेशन नाम की चीज क्या है? सप्रेशन मतलब है स्क्विंट में पेशेंट अपने डिप्लोपिया को अवॉइड करने के लिए बच्चा एक आई को सप्रेस कर देगा, और एक आई को सप्रेस करता रहेगा, वो लेजी बन जाएगी, और लेजी को कहा जाता है क्या? एम्ब्लायोपिया। एक सवाल जरूर आ रहा है आपका एम्ब्लायोपिया पे, अभी रिसेंट जनवरी में भी आया था। एम्ब्लियोपिया कब कहेंगे? सब लोग ध्यान से सुनो। जब बेस्ट करेक्टेड विजन, मतलब चश्मा देने के बाद भी विजन 6/6 नहीं है। चश्मा देने के बाद भी, मतलब पहला काम ही है चश्मा देना। अगर वो दोनों आंखों में रिफ्रैक्टिव एरर डिफरेंस की वजह से है तो एनाइसोमेट्रोपिक एम्ब्लियोपिया कहा जाएगा। स्क्विंट आया तो स्ट्रैबिस्मिक एम्ब्लियोपिया कहा जाएगा। सवाल भी था ये। और अगर लाइट नहीं पहुंच पा रही रेटिना पे, जैसे कि कंजेनिटल कैटरैक्ट है, टोसिस है, तो स्टिमुलस डेप्रिवेशन एम्ब्लियोपिया, उसके लिए तो एज सून एज पॉसिबल सर्जरी करो। बट एनाइसोमेट्रोपिक और स्ट्रैबिस्मिक में क्या करो? पहला काम चश्मा देना है, बड़ा इंपॉर्टेंट है। फिर ऑक्लूजन करोगे नॉर्मल आई को, और बड़ा बच्चा तो वीडियो गेम्स खिलाओ उसको टू स्टिमुलेट द लेजी आई। तो एम्ब्लियोपिया पे आपका 13th क्वेश्चन हो सकता है। 3 ही टाइप के एम्ब्लियोपिया हैं। अगर दोनों आंखों में +4 का नंबर है तो एनाइसोमेट्रोपिया हो ही नहीं सकता। यही सवाल था जनवरी में, और स्क्विंट की पिक्चर दी थी ईजो वाली, तो स्ट्रैबिस्मिक एम्ब्लियोपिया था आंसर उसका। फिर ऑर्बिट में प्रोप्टोसिस पे सवाल आपका 14th सवाल। नहीं, पहले मैं केरेटोकोनस डिस्कस कर लेता हूं। एक सवाल मुझे लग रहा है केरेटोकोनस पे आजकल जरूर आ रहा है, फिर ऑर्बिट डिस्कस करेंगे लास्ट 5 मिनट में। तो केरेटोकोनस में ग्रेजुअल डिक्रीज विजन होता है, पेनलेस यंग पेशेंट होता है, मायोपिया होता है, बार बार चश्मे नंबर बदल रहा है, रबिंग आइज हो सकती है बिकॉज ऑफ एलर्जी कंजंक्टिवाइटिस, वर्नल केरेटो कंजंक्टिवाइटिस। फेमस साइन होते हैं फ्लैशेस, रिंग, आयरन डिपोजिशन, एस्टिमेटिज्म कैसे बार बार चश्मा नंबर बदलता है। मनसन साइन की पिक्चर आई थी अभी जनवरी में। ऑयल ड्रॉपलेट रिफ्लेक्स, वॉक्ड स्ट्राया। क्या करते हैं? टोपोग्राफी करते हैं। टोपोग्राफी मतलब क्या? सरफेस देखते हैं इसमें। ट्रीटमेंट करेंगे, कॉन्टैक्ट लेंस देंगे, रिजिड गैस परमिएबल। और प्रोग्रेस हो रहा है तो C3R प्रोसीजर करते हैं, कॉर्नियल कोलेजन क्रॉस लिंकिंग बाय राइबोफ्लेविन। ये पिक्चर नोट कर लो, शायद आ सकती है केरेटोकोनस में। अब FMGE में आज तक नहीं आई, नीट एग्जाम में 2 बार आ चुकी है, अब इसका बारी आने का। ये इंट्राकॉर्नियल रिंग सेगमेंट करा जाता है केरेटोकोनस में, नॉन प्रोग्रेसिव केरेटोकोनस में। और केरेटोप्लास्टी में सूचर कौन सा यूज करेंगे? वही नायलॉन सूचर यूज करेंगे। इसमें भी एक्यूट रेड आई हो सकती है, जो INSTD में सवाल आता है, इसको एक्यूट हाइड्रॉप्स कहा जाता है, जिसमें डेस्पिन मेम्ब्रेन रप्चर करेगी, गैस डालेंगे, वही वो रेटिना वाली SF6 C3F8, जो डेस्टमेंट को प्लग कर देगा, जिसको कहते हैं एक्यूट हाई ड्रॉप्स। द ओनली कंडीशन ऑफ पेन इन केरेटोकोनस इज एक्यूट हाई ड्रॉप्स। तो एक 14th क्वेश्चन केरेटोकोनस का, और 15th क्वेश्चन देखो प्रोप्टोसिस का। प्रोप्टोसिस मोस्ट कॉमन कॉज क्या है अडल्ट्स में? थायराइड आई डिजीज। अब थायराइड आई डिजीज पहले तो मेजर कैसे करते हैं? एक्सोप्थेल्मोमीटर से मेजर करते हैं, हर्टल्स उसका नाम होता है। और थायराइड में थायरोक्सिन लेवल्स कैन बी एब्सोल्युटली नॉर्मल। ये हर्टल्स एक्सोथर्मोमीटर की पिक्चर है। नैवजिगर व्यू, हेड एंड व्यू है, वर्म व्यू, फुट एंड व्यू है। और अगर बड़ा है तो थायराइड डिजीज इज द मोस्ट इंपॉर्टेंट डिफरेंशियल। थायरोक्सिन लेवल्स उसमें कुछ भी हो सकता है, वर्नर क्लासिफिकेशन बताई थी उसने, विजन लॉस भी हो सकता है उसमें, सिस्टमिक स्टेरॉइड देते हैं ऑर्बिट और आईलिड्स में, थायरोक्सिन लेवल्स कुछ भी हो सकता है। पर अगर प्रोप्टोसिस है यंग मेल में इंटरमिटेंट हो रहा है, वेल्सेल्वा के कारण बेंड झुक रहा है तो आंख बाहर आ रही है, तो ऑर्बिटल वराइसिस आंसर है। और अगर पल्सेस में आ रहा है ट्रॉमा की हिस्ट्री के बाद, पल्सेटाइल प्रोप्टोसिस और कैरेटिको कैविनस फिस्टुला आंसर। अब इसको जरा ध्यान से देखो, नॉन एक्सियल और एक्सियल में फर्क क्या है? नॉन एक्सियल का मतलब है इट इज नॉट कमिंग द सेंटर। तो अगर ये ऐसी पिक्चर आएगी डाउन एंड नोज की तरफ, मतलब सुपरोटेम्पोरल में कौन सा ग्लैंड होता है? लैक्रिमल ग्लैंड। तो ये पिक्चर डर्मोइड क्यों नहीं है? क्योंकि डर्मोइड की भी वही सुपरोटेम्पोरल है, बट एज होगा बच्चा। तो बच्चों में प्रोप्टोसिस, ये भी इंपॉर्टेंट सवाल है, बच्चों में प्रोप्टोसिस, इसको ध्यान 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 से देख लो। एक सवाल 100% गारंटी है इस पेज से आने वाला है। बच्चों में पेनफुल प्रोप्टोसिस है, ट्रॉमा या साइनोसाइटिस की हिस्ट्री है, तो ऑर्बिटल सेल्युलाइटिस होगा। साथ में राउंड सेल ट्यूमर दिया हुआ है, अगर आई बॉल निकाली है हिस्टोपैथ के साथ, डेस्मिन है तो रैप्टोमायोसार्कोमा होगा, मसल होती है। जूम कर रहा हूं, रेटिनोब्लास्टोमा, वाइट रिफ्लेक्स है, सिनेप्टोफाइसिन है, कैल्सिफिकेशन भूलना नहीं है, ये रेटिनोब्लास्टोमा आंसर है। रोजेट्स होंगे इसमें, ठीक है, राउंड सेल ट्यूमर। और एकेमोसिस है तो न्यूरोब्लास्टोमा होगा, बाइलैटरल एकेमोसिस है तो न्यूरोब्लास्टोमा। अच्छा, ऐसा बाइलैटरल एकेमोसिस का ट्रॉमा हुआ तो कौन सा फ्रैक्चर होगा? एंटीरियर कैनल फॉसा फ्रैक्चर। उसको कौन सा साइन कहते हैं? रकून आइज, पांडा साइन। अगर पेन नहीं है और सुपरोटेम्पोरल है, देखो ये बच्चा है तो डर्मोइड है, ऑर्बिटल डर्मोइड जो नॉन एक्सियल प्रोप्टोसिस करेगा, और लिम्बस में है तो लिम्बल डर्मोइड है। डर्मोइड को एक्साइज करेंगे, बिनाइन ट्यूमर है, बट बच्चों में होता है। और अब इसको ध्यान दो क्योंकि अभी सवाल आया था आईएनएसईटी में, लीश नड्यूल हैं, कैफिलोइड स्पॉट्स हैं, ऑप्टिक ग्लायोमा है, तो न्यूरोफाइब्रोमटोसिस 1 आंसर है। ऑप्टिक ग्लायोमा भी एक्सियल प्रोप्टोसिस करेगा। लीश नड्यूल इज द मोस्ट कॉमन फीचर ऑफ NF1 इन द आईज। ठीक है। अच्छा, अब अगर आपको ये वाला, तो देखो फेवरेट सवाल है यही ऑर्बिट में कि फ्लोर फ्रैक्चर होता है तो उसको ब्लोआउट फ्रैक्चर कहते हैं। इंफीरियर रेक्टस मसल फंस जाती है, मतलब रिस्ट्रिक्टिव स्क्विंट हो जाता है। फोर्स रिडक्शन टेस्ट पॉजिटिव होता है, दैट इज अ डिफरेंशिएटिंग ऑफ रिस्ट्रिक्टिव एंड पैरेलिटिव स्क्विंट। कौन सी बोन फ्रैक्चर है? मैक्सिलर बोन फ्रैक्चर है। साइन का नाम है टीयर ड्रॉप साइन, ब्लंट ट्रॉमा के कारण होता है। तो ट्रॉमा भी इंपॉर्टेंट सवाल है। देखो अब एक दो एक्स्ट्रा तो बताऊंगा, 15 क्या 16-17 सवाल होंगे तो 15 सवाल। अब जैसे टोसिस पे सवाल, टोसिस अगर आईलिड क्रीज एब्सेंट है तो हो जाता है कंजेनाइटल सिंपल टोसिस, बट अगर टोसिस हुआ साथ साथ जॉ मूवमेंट हो रही है अप डाउन, तो उसको कहते हैं मार्कस गन जॉ विंकिंग फिनोमिना। और अगर टोसिस हो रहा है, शाम को ज़्यादा हो रहा है, न्यूस्टिग्मिन टेस्ट, दैट इज मायसीना ग्रेविस। और मार्कस गन फिनोमिना स्टोसिस लैटरल टेरेगोइड और एलपीएस के बीच में कम्युनिकेशन फिफ्थ नर्व का। तो बच्चा थम्स अप कर रहा है, ब्रेस्ट फीडिंग कर रहा है, आईलिड ऊपर जा रही है नीचे, तो दैट इज मार्कस गन जॉ विंकिंग फिनोमिना। मार्कस गन प्यूपिल क्या था? RAPD। कौन बताएगा आंसर? एक यंग पेशेंट है, फीमेल है, पेनफुल आई मूवमेंट्स है, RAPD पॉजिटिव है, डिस्क मार्जिन नॉर्मल है, पेनफुल आई मूवमेंट्स है। आंसर क्या है? क्या आंसर है? रेट्रोबल्बिनोराइटिस, मल्टीपल स्क्लेरोसिस। ठीक है, अब देखो लास्ट में आई लैशेज के बेस पे ग्लैंड है जाइस ग्लैंड, उसका इन्फेक्शन हो जाता है तो स्टाई कहते हैं एक्सटर्नल हॉड्यूलम, और टार्सस में इन्फेक्शन होते हैं मेबोबियन ग्लैंड, तो मेबोबियन ग्लैंड के इन्फेक्शन को कहा जाता है इंटरनल हॉड्यूलम। बट अगर मेबोबियन ग्लैंड का, वेरी गुड आंसर, मेबोबियन ग्लैंड का अगर ब्लॉकेज हो जाए तो उसे कहा जाता है कैलेजियन, तो इन्फेक्टेड कैलेजियन को कहा जाता है इंटरनल हॉड्यूलम। इसके लिए स्मॉल है तो इंटरलिजन स्टेरॉइड देंगे कैलेजियन में, लार्ज है तो इंसिजन एंड ड्रेनेज करेंगे, और इंटरनल एक्सटेंड हॉड्यूलम है तो सिस्टमिक एंटीबायोटिक देंगे। ध्यान देना, टॉपिकल एंटीबायोटिक इज नॉट वर्किंग इन आईलिड्स एंड ऑर्बिट। फ्रेंड्स आरएपीडी मतलब रिलेटिव एफरेंट पिपुलरी डिफेक्ट, मार्कस गन पिपल का दूसरा नाम है रिलेटिव एफरेंट पिपुलरी डिफेक्ट, भूल कैसे सकते हो ये। फिर वन लाइनर्स होते हैं ट्रिचियासिस, मिसडायरेक्टेड आईलैश, एक्स्ट्रा लेयर ऑफ आईलैश डिस्ट्रिचियासिस, ग्रेइंग ऑफ आईलैश पोलियोसिस, इनवर्ट रोलिंग एंट्रोपियन, आउटवर्ड रोलिंग एक्ट्रोपियन। और लास्ट हमारा 5 मिनट है, तो ऑक्युलर इंजरीज पे कई सवाल तो हमने कर लिए हैं, बट ऑक्युलर इंजरीज अगर ऐसा हो जाए जो मैंने कहा था आपको, क्या एंटीरियर क्रैनियल फॉसा फ्रैक्चर, इसको पांडा साइन रकूनाइज कहा जाता है। वॉशियस रिंग को सूडो एक्सफोलिएशन क्यों नहीं कहेंगे, क्योंकि सूडो एक्सफोलिएशन इज अ वाइट मटेरियल, ये ब्राउन मतलब क्या, आयरिस पिगमेंट ऑफ द लेंस कैप्सूल, उसको वॉशियस रिंग कहा जाएगा। और ये देखो आयरोडोडायलिसिस में मल्टीपल प्यूपिल को कहा जाता है पॉलीकोरिया, डी शेप प्यूपिल होता है। नहीं, बॉर्डर वाला ध्यान नहीं देना प्रिंस। एल्कलाई ज़्यादा डेंजरस है क्योंकि वो पेनिट्रेट करता है आई के अंदर। मोस्ट कॉमन लाइम है, मोस्ट कॉमन एसिड एस्ट्रोजोफोर है। सबसे पहला काम है हिस्ट्री लेने के बाद, हिस्ट्री लोगे पहले, सबसे पहले हिस्ट्री, फिर वॉश, फिर सीवियर ड्राई आइज करता है। और सीवियर ड्राई आइज में क्या होता है, एंकाइलोब्लेफरॉन या सिम्ब्लेफरॉन। देखो भैया पिक्चर मैंने आपको दी हुई है वर्कबुक में, डीएफएक्स में भी आपको पिक्चर आई थी सिम्ब्लेफ्रॉन की, मैं दे रहा हूँ एंकाइलोब्लेफरॉन। सिम्ब्लेफ्रॉन की पिक्चर भी ऑफकोर्स है आपके उसमें वर्कबुक में, वो आई थी सवाल एडिशन ऑफ बल्बर एंड पैल्पेब्रल कंजंक्टिवा। तो देखो इस बार ही पूछ लेंगे वो, एडिशन ऑफ अपर एंड द लोअर आईलिड इज एंकाइलोब्लेफरॉन, सिम्ब्लेफ्रॉन इज एडिशन ऑफ बल्बर एंड पैल्पेब्रल कंजंक्टिवा। आईलिड कोलोबोमा, ये भी एम्ब्रियो पे यूजुअली सवाल आता नहीं है, बट कौन बताएगा एम्ब्रियो आईलिड कोलोबोमा में मोस्ट कॉमन कॉम्प्लिकेशन क्या होगा। कोलोबोमा मतलब लॉस ऑफ आइरिस, लॉस ऑफ एनी टिश्यू, तो आईलिड बंद नहीं कर पाएगा तो क्या एक्सपोज हो जाएगा, कॉर्निया, तो एक्सपोजर केराटाइटिस हो सकता है। और कॉपर आंख के अंदर जाएगा तो उसको चैल्कोसिस कहते हैं, आयरन आंख के अंदर जाएगा उसको सिडरोसिस कहते हैं। कॉपर कॉजेज सनफ्लावर कैटरेक्ट एंड केसेस फ्रैक्चरिंग, जो विल्सन डिजीज में मिल सकती है। आयरन इज मोर कॉमन, सिडरोसिस, जिसमें हेटेरोक्रोमिया रेडिस हो सकता है, डिफरेंस इन कलर, ज़्यादा पिगमेंट वाला मोर कलरेशन होगा सिडरोसिस में। और लास्ट एक बताओ का सवाल, अगर एक आई में पेनिट्रेटिंग ट्रॉमा होता है, उसमें हाइपोपियन है, विट्रस इन्वॉल्वमेंट है, तो आंसर क्या करोगे। पेनिट्रेटिंग ट्रॉमा है, एक आई में हाइपोपियन है, एक्यूट रेड आई है, विट्रस इन्वॉल्व है, आंसर सिंपैथेटिक ऑप्थेल्मिया नहीं करेंगे, आंसर होगा एंडोप्थेल्माइटिस। कॉर्नियस्क्लेर इन्वॉल्व होगा तो पैनोप्थेल्माइटिस। अगर उसकी वजह से दूसरी आई में, फेलो आई में, नॉन ट्रोमेटिक आई में ग्रैनुलोमेटस पैंजुवेटिस होता है, उसको कहते हैं सिंपैथेटिक ऑप्थेल्मिया। तो सिंपैथेटिक ऑप्थेल्मिया इस सीन है नॉन ट्रोमेटिक आई, उससे सिंपैथी है आपको, तभी तो नाम है सिंपैथेटिक ऑप्थेल्मिया। टाइप 4 हाइपरसेंसिटिव रिएक्शन, ट्रीटमेंट इज इंट्रावेनस स्टेरॉइड। तो सिर्फ बाय सीइंग दैट पेनिट्रेटिंग ट्रॉमा, डोंट राइट सिंपैथेटिक ऑप्थेल्मिया। Symptomatic ophthalmia is in the non-traumatic eye. If one eye has penetrating trauma and other eye has, fellow eye has granulomatous uveitis, that is known as sympathetic ophthalmia. That is example of granulomatous uveitis. Granulomatous, which keratitis precipitates are there, mud and fat keratitis precipitates are there. So one question on trauma, ocular trauma is the last question from my side. All right. So that is 1 hour from my side. I'll just repeat the 15 questions. One question, photo transaction regeneration expected. Second question, which we discussed, visual field defects. कोई भी चाहे ग्लोकोमा, नॉन ग्लोकोमा और विजुअल फील्ड्स. Third, pupil, different pupils. Fourth, diabetic retinopathy or retina detachments. Fifth, corneal ulcer, मतलब acute red eye. Two questions on acute red eye, fifth and sixth. Acute red eye can be there in acute uveitis and acute angle closure also. Hypopia on pupil small, uveitis. Hypopia on pupil large, acute angle closure, Vox triad. Nerve palsy, seventh question, third, fourth, sixth. One on either astigmatism or refractive error or convergence, Royal Air Force ruler. Eighth question. Ninth question, keratoconus. 10th question, proptosis. Or two questions on proptosis, one in child, one in adults. Proptosis in child, that table is very, very important. 12th question, ocular injuries. Expected this time is sympathetic ophthalmia, non-traumatic eye. Then 14th question and 15th question, retinal detachment, I have told you already. Cystoid macular edema is an important one, yes. But what am I forgetting? Two questions I am forgetting. What is expected? Wait. Yeah, amblyopia. Amblyopia question is one question. And yeah, one from conjunctiva. Either a pterygium, bitot spot, pinuncula, or that vernal keratoconus. खुजली करता है, बच्चा खुजली करता आ रहा है. That's all. Okay, so that's all from my side. 15 questions. 14 questions will be easily doable. One question can be difficult. Don't worry about that. Just try to be calm in the exam. Just keep up your mind. आज marathon में just open mind and just see what are the things can be revised quickly in 1 hour or other subjects also. Alright, that's all from my side. The next faculty is waiting for the next subject. Best of luck from my side. Best wishes.
चैट को ना राइट में कीजिए, इधर लेफ्ट में कैमरा है, इसको राइट में कर दीजिए. ठीक है. Good afternoon everyone, good afternoon, welcome. All right, great. So I think Sonu ma'am is traveling, so we are going to do a very quick revision. We have 60 minutes. We had circulated this PDF. This is part of the DFX PDF which we had done previously, and we'll be going through a few pages from the main DFX document. Is the voice better now? Are you able to hear me better now? Is the voice better? Is the voice better? Can you check volume? Volume is better. Are you able to hear me? Better now? Please increase the volume. Online team, please check how to increase the volume. What to do? All well now? Better? I think I have it as close as possible to my mouth. Let me see. Is it better now? Are you able to hear me clearly? Is the voice better? Are you able to hear me? We made some adjustment to the mic. Okay, okay, great. Thank you very much. Thank you very much. So, like I said, we have 60 minutes and close to 80 pages. So, literally, we running through this. So, make ready with your pen and your notes, and quickly we'll highlight and underline the important points in the biochemistry section that you need to know for your forthcoming exam on the 28th. Okay, so we're starting with first point, that is the order of draw. Quick look. The first sample to be drawn for blood culture, second sample to be drawn blue vial for the coagulation profile, third and fourth for the serum samples biochemistry immunology, fifth is for plasma samples, sixth is for complete blood count, and the pink top same hematology samples for the blood bank, and the gray vial is the eighth one, which is for plasma glucose. We have this table here which indicates the different analytes and the different samples which have to be collected in the different tubes. Like we said, light blue has the buffered sodium citrate for coagulation study. The red top has the clot activator for serum determinations. The gold top has clot activator along with the gel for the separation of the serum. It is also for serum determination. The green top has the heparin. Heparin is there, which is for plasma determination biochemistry. You can also collect the sample for ABG analysis. All right. The lavender top has the EDTA for whole blood hematology. The pink top is same as EDTA. It has a special cross-match label. The grey top has potassium oxalate and sodium fluoride. Sodium fluoride will inhibit the glycolysis and it is for glucose determination. You can also collect the sample for blood alcohol estimation. Okay. Similarly, in the lavender top vial, you can collect the samples for ESR and the HbA1c. Okay. So these are the important vials you have to keep in mind, the sequence in which they have to be used, the different tests for the different vials, and what are the analytes within the different tubes. These are the things you should be knowing. Okay, these are the things you should be knowing. All right. Moving on to second part, which is the components related to nutrition. One is the calorific value of food. You should remember the values for carbohydrate, amino acid, and the lipids. You will not be asked about these, but you will be asked for the conversion. You will be described a meal. Meal will have certain amount of carbohydrate, amino acid, and lipids. Then you have to do the conversion. So please remember these values and make note that this is calorie per milligram. Later on, when you do the gram calculation, it will become kilocalorie per gram. Okay, please make sure to check the and match the correct unit. Check and match the correct unit. When you are talking about food, food will be in grams and the unit should be kilocalorie. Unit should be kilocalorie. Second aspect is thermic effect of food. This is the amount of energy required to digest or absorb the nutrition in the food. This is also known as specific dynamic action. For carbohydrate, it is the lowest, that is 10%. For the lipids and fats, it is about 10 to 15%. And for amino acid and protein, it is the highest. It is highest for the amino acid and proteins. So you should remember this point. And last part is about the balanced diet. What contribution should come from the different food components in terms of energy? So up to 55% of energy should come from carbohydrate, about another 15% from the amino acid and protein, and up to 30% is coming from the lipids. This means if we talk about the lipid rich meal, it should have more than 35% of the energy contribution. Only then we'll call it the lipid rich meal. And one more component is there. We talk about the respiratory quotient. We want to determine whether the person is having a balanced meal or the person is having the carbohydrate rich meal. You know, most of our food compositions in India are carbohydrate rich. So there the RQ value will be 1, whereas for a balanced meal the RQ value should be in the range of 0.85. Please note, for carbohydrate the RQ is 1. For proteins the RQ is 0.8 to 0.9. For fat the RQ is 0.7. The lowest RQ among the various substances you consume commonly is actually for alcohol. For alcohol the RQ value is 0.66. So please make note of these points. Right, very good. nectrophile, yes, invisible and visible fat together will make up the 30%. All right, moving on, the important organelles and their markers. Another very important simple question. The two which you must remember. One is for the endoplasmic reticulum, where the marker is glucose 6 phosphatase. The second is the Golgi body, for which the marker is galactosyl transferase. In addition to this, please make note of plasma membrane, for which the important marker should be sodium potassium ATPase, and for the mitochondria, where the marker should be the ATP synthase. ATP synthase, we have mentioned previously, is also known as the F0 F1 particle. Okay, so the markers for the organelles, very important. Please make note of the markers of the organelles. Moving on, the acid base homeostasis, you know, pH of the blood is 7.4, range is 7.35 to 7.45. The different types of chemical buffers are there in our blood to stabilize the pH. The buffering action depends on the Henderson-Hasselbalch equation, and as per this equation, the best buffering action will be when target pH is equal to the dissociation constant. The second component here is the buffering capacity. Buffering capacity depends on the concentration. Out of the different chemical buffers, the most important chemical buffer is the bicarbonate buffer system, where the pK is 6.1. The two components are the bicarbonate, which is the base component. It is regulated by the renal system. The acid component is the H2CO3, which is a function of partial pressure of CO2 and is regulated by the respiratory system. They can be easily adjusted, and therefore the bicarbonate buffer system has infinite buffering capacity. Phosphate buffer is the second chemical buffer. However, it is important in the intracellular compartment and renal tubules. It is not particularly important within the blood. Okay, very good. Okay, the pK for the phosphate buffer is 6.8. The another chemical buffer which is present is the ammonia buffer. For ammonia buffer, you have to remember it is another important buffer in the renal tubules. All right, it is not having main action in the blood, rather it is having the action in the renal tubules. And lastly, in the blood, the proteins hemoglobin and albumin are having important buffering action. These proteins are having large amount of histidine, which has the imidazole side chain, and therefore they are able to act as the good buffers. All of these are chemical buffers: the bicarbonate buffer system, the phosphate buffer system, the ammonia buffer system, the protein buffer system. These buffering systems are supported by the respiratory and the renal system, and that is why these are known as the physiological buffers. They support the chemical buffers, and therefore they are known as physiological buffers. In addition to the background about these components, we should know about the acid-base disorders. The diagnosis of acid-base disorder is based on the ABG analysis, for which I told you we draw the sample in the heparinized vial, which is the green top vial, right? Green top vial has the heparin within it. Here you should know the normal physiological values, the three components which you need to know. pH, we already said the normal value is 7.4. The pCO2, the normal value is 35 to 45 millimeter of Hg, average value 40. And bicarbonate, the average value is 24, range is 22 to 26 milli equivalent per liter. Sometimes you get the question on the anion gap. You should know the normal anion gap is 8 milli equivalent per liter. Talking about acidosis, when the pH value is less than 7.35, we label it as acidosis. Okay, when in acidosis, we expect either the pCO2 value will be high or the bicarbonate value will be low. On the other hand, if you talk about alkalosis, alkalosis is when the pH value is more than 7.45. Here we expect the pCO2 value to be less than normal or the bicarbonate value to be increased beyond the normal range. Okay, so these are the observations that we expect, based on which you can make the diagnosis. Now, the most important cause for respiratory acidosis, either there is damage at the CNS, that is the respiratory center, or there is damage at the respiratory apparatus. There can be mechanical obstruction, there can be neuromuscular damage, there can be loss of exchange area. So all of these can cause respiratory acidosis. Talking about the respiratory alkalosis, the most important cause is the hyperventilation, anxiety, panic attack. The mechanical ventilation due to strenuous exercise is another important reason. for the respiratory alkalosis. There are a lot of other important considerations, but these two are the most commonly observed and therefore the ones you should be knowing about. Talking about the metabolic causes, first we have the metabolic acidosis. In metabolic acidosis, we have two types. One is the normal anion gap metabolic acidosis. Under this heading, you have to remember two conditions. One is the diarrhea, and second is the renal tubular acidosis type 1, 2, and 4. These are the inherited types of renal tubular acidosis, and along with that, the diarrhea. These are the two important causes for normal anion gap metabolic acidosis. In addition to normal anion gap metabolic acidosis, we have what is known as high anion gap metabolic acidosis. For high anion gap metabolic acidosis, the ones you should remember are the mud piles: methanol, uremia, diabetic ketoacidosis, paracetamol, fenformin, paraldehyde, isoniazid, inborn errors of metabolism, lactic acidosis, ethanol, salicylates, and the ethylene glycol, polyethylene glycol, diethylene glycol. Please remember the ethylene glycols is cause for the high anion gap metabolic acidosis. Okay, here there is either ingestion or production of the acids. Coming to the last one, that is metabolic alkalosis, the two conditions you should remember: one is the vomiting, and second, there can be diuretic therapy. These are the important causes where you can have the metabolic alkalosis. Sometimes there can be consumption of alkalinizing agent. For example, a patient is having UTI, you give him or her the alkalizing agent, alkazole like substances, where you can have the metabolic alkalosis. Okay, so these are the important causes for the acid base disorders. Please keep in mind this flowchart, which is helpful in identifying the acid base disorder. You look at the pH, you make a determination, you do the prediction what is likely to happen, then compare with the values to make the primary diagnosis. You also try to find out whether there is a component of compensation or not. This Davenport diagram is helpful to identify the simple acid base disorders. So please remember this name, the Davenport diagram. Okay, this name is written here, the Davenport diagram, to identify the simple acid base disorders, Alright, moving to the next topic, that is the clearance. So for clearance, first you have to remember the formula. Formula is UV by B, where U stands for the urinary concentration, V stands for the flow rate, which we calculate by the urinary volume, and the B stands for the plasma concentration, which you obtain from the blood sample. Okay, please remember that the clearance denotes the glomerular filtration rate. It is a kidney function test. The ideal substance for estimation of the clearance is inulin. Because of the various factors, inulin is not absorbed from GI system, it is not metabolized in the body, it is freely filtered at the glomerulus, it is not reabsorbed by the renal tubules, and it is not secreted by the renal tubules. Because of these reasons, it is the ideal substance for measuring the clearance. However, what we use clinically is the creatinine clearance. About creatinine, you have to remember, because it is not the ideal substance for measuring clearance, it has a drawback. What is the drawback? It is secreted by the renal tubules. As a result, it overestimates the GFR. It is secreted by the renal tubules and therefore it overestimates the GFR. So please remember these points about clearance. Primarily, it is a tool to measure the glomerular filtration rate, that is the kidney function. We want to look at the kidney function. Coming to a very important section, that is the vitamins. So the highlights I'll talk about here. First, we are talking about the lipid soluble vitamins. Vitamin A is also having three functional subtypes: retinol, retinal, and retinoic acid. Please note, the beta carotene is the precursor form. It is not vitamin A, it is the pro form. The different functions of vitamin A: it is the visual pigment in retina, part of the Waltz visual cycle. It regulates the gene expression and tissue differentiation, and it is teratogenic in large doses. Please note, the precursor form, the beta carotene, is acting as the antioxidant, not the vitamin A. Vitamin A deficiency is quite rampant, and it is the most important preventable cause of blindness. Prolonged deficiency leads to xerophthalmia, keratinization of the cornea. Along with the cornea, there can also be the keratinization of the skin, which is known as phrinoderma. During the keratinization of the cornea, an intermediate observation is what is known as the Bitort's spot. This is a very common image based question in the exam. Please make note of the Bitort spot, a shaggy patch on the sclera of the eye, which is seen in the prodromal phase. When the puckering up of the mucosa is happening, you can have an image like this. So this is the vitamin A deficiency. For lipid soluble vitamins, you can also have the toxicity. So when we talk about vitamin A toxicity, the most important observation is the pseudo tumor cerebri. What do you mean by pseudo tumor cerebri? You have the features of headache, nausea, ataxia, anorexia, all similar to the intracranial space occupying lesion in the cerebrum. Intracerebral space occupying lesion will have the similar features, however there is no tumor, therefore this is known as the pseudo tumor cerebri. The findings can happen in the liver also, because deposition is happening in the liver. It can happen on the calcium homeostasis, and there can be excessive drying, desquamation and alopecia. These observations related to the skin, but the most classical presentation is the pseudo tumor cerebri for vitamin A toxicity. So this is the table that you have discussed multiple times, where the Bitort spot is seen quite early during the progression of the disease. When the corneal scar is there, then the visibility becomes 0. Moving to the second vitamin, that is the vitamin D. Vitamin D, the major source synthesis by skin. If there is adequate exposure to the sun, then the skin can synthesize adequate amount of the vitamin D. The vitamin D is sometimes called a hormone because of its mechanism of action. It localizes to the hormone receptors and goes inside. It interacts with the DNA. Then the function, mainly regulation of calcium absorption and homeostasis by interacting with the nuclear receptors. It has an additional role in regulating cell proliferation and differentiation, and it has been found that higher intake reduces risk of various non-infectious diseases, that is insulin resistance, the obesity and metabolic syndrome. Okay, the very important part is how it is being synthesized in the body. So first, from cholesterol it is converted to the vitamin D3 on exposure to the UV light. On exposure to UV light, it is converted to vitamin D3. Vitamin D3 is acted upon in the liver by the 25 hydroxylase and then in the kidney by 1 hydroxylase. Therefore, from skin it goes to liver and there it goes to kidney. Inactivation also happens within the kidney only. Inactivation also happens within the kidney only. So please remember the role of the different organs in the metabolism of the vitamin D. Now, vitamin D deficiency is very well known. I am sure all of you know deficiency causes the rickets in the children. At the same time, please note that in adults it is going to cause the osteomalacia, not osteoporosis. Sometimes you can see toxicity for vitamin D in the individuals where the genetic deficiency of the inactivating enzyme 24 hydroxylase is there. Clinical features will lead to excess calcium in the body, causing the contraction of blood vessels, the high blood pressure, and calcification of the soft tissues known as calcinosis. These are not very common. As long as the enzyme is functional, then the toxicity is very uncommon. These are the clinical features of rickets, which I'm sure all of you are familiar with. You have the delayed closure of fontanelles, wide sutures, frontal bossing, craniotabes, and very important, the dental hypoplasia. In the chest, you have the Harrison's sulcus, pectus carinatum, and the rachitic rosary, which is not painful. And lastly, swelling in the wrist and ankle joint and the bowing of legs. Bowing of legs is commonly shown in the image where you have to make the diagnosis. In addition to that, swelling at the wrist and ankle joint can be very prominent. Sometimes at the ankle joint it may be labeled as the third malleoli. So these are the points related to the clinical presentation of a patient of rickets. Coming to vitamin E, only one point which you have to keep in mind, it is the lipid soluble antioxidant in the cell membrane. So among the vitamins we have two antioxidants. One is the water soluble, that is vitamin C. Second is the lipid soluble, which is vitamin E. Vitamin E is the chain breaking antioxidant. Coming to vitamin K, please remember it is required for carboxylation of glutamate residues, gives rise to the gamma carboxyglutamate. It is particularly important for factors 2, 7, 9 and 10. Okay, particularly important for 2, 7, 9 and 10. If there is deficiency of vitamin K, there will be impaired blood clotting and the hemorrhagic disease will be there, because the clotting is not happening properly. So the hemorrhagic disease is going to be there. Coming to the water soluble vitamins, starting with vitamin B1, the thiamine level is monitored by the activative enzyme erythrocyte transketolase. The deficiency causes the beriberi and wernicke's encephalopathy. Within the beriberi, we have the dry beriberi where CNS is involved, the wet beriberi where the CVS is involved, with the specific presentation of high output cardiac failure. In addition to this, we have what is known as Wernicke's encephalopathy, where all of you have remembered the mnemonic of clinical presentation as GOA, where G stands for the global confusion, O stands for ophthalmoplegia, and A stands for ataxia. Alright, as the disease progress, along with these features, you can also have the psychosis component, which includes the memory loss and confabulation. So global confusion, ophthalmoplegia and ataxia, along with memory loss and the confabulation, this will be known as Wernicke-Korsakoff psychosis. Moving on to vitamin B2, riboflavin deficiency can be identified by the activity of erythrocyte glutathione reductase. Deficiency is presenting as A riboflavinosis. Important features are stomatitis, seborrheic dermatitis, and the normocytic normochromic anemia. Within the stomatitis, you have to make note of painful red tongue with sore throat, the chelosis, that is the chapped and fissured lips, and angulostomatitis, which is the inflammation of the corners of the mouth. Okay, so these three features are seen in the B2 deficiency. For vitamin B3, niacin, please note 60 mg tryptophan is converted from 1 mg of niacin within the body. 60 mg tryptophan will give rise to 1 mg of niacin within the body. So niacin can be synthesized in our body. Vitamin D and niacin can be synthesized by the pathway within our body. Additional point to note is, this is one of the few water soluble vitamins where the excess is toxic. Common presentation is the macular edema and macular cyst. Okay, deficiency will commonly present as the pellagra. In pellagra, we have the classical 3Ds. The 3Ds stand for the diarrhea, dementia, and the photosensitive dermatitis. This means only the sun exposed areas will show the feature of dermatitis. If untreated, all the 3Ds will fuse to form the fourth D, that is death. The Casal collar or the Casal necklace at the sun exposed part above the collar region is a very characteristic region presentation in the chronic conditions. 4 conditions where the pellagra will be precipitated, rather 5. Maize is the staple diet. The sorghum is present in large amount. Hartnuss disease is there in the patient, or carcinoid syndrome is there in the patient, or the vitamin B6 deficiency is there. In these 5 conditions, you are going to see the pellagra. Moving on to vitamin B5, it is a part of the cell carrier protein in fatty acid synthesis. It is required for the synthesis of coenzyme A. However, dietary deficiency is unknown. Moving to vitamin B6, the active form is pyridoxal phosphate, and deficiency status can be identified by measuring the erythrocyte transaminases. Large number of reactions where the pyridoxal phosphate is required for transamination, deamination, decarboxylation, synthesis of catecholamines, serotonin, GABA, and selenocysteine, metabolism of serine, methionine, cysteine, the conversion of tryptophan to niacin in glycogenolysis by the enzyme glycogen phosphorylase, and for sphingolipid and the heme synthesis. So large number of reactions where pyridoxine is required. That is why when there is a deficiency, we have widespread features. The decreased heme synthesis causes a sideroblastic anemia. The peripheral neuropathy is another feature, and multiple findings in the urine, homocystinuria, oxaluria, and xanthurenic aciduria. These are combination is characteristic for the B6 deficiency. Also note that toxicity can cause neuropathy. So vitamin B3 deficiency excess can cause toxicity. B6 excess can also cause toxicity features. Coming to B7, also known as biotin, the important role is as the coenzyme for carboxylases. It plays a role in regulation of cell cycle. Generally, the deficiency is not possible. However, it can occur with consumption of large amounts of uncooked egg white due to the presence of avidin. Avidin will block the biotin absorption. It combines with biotin and prevents the absorption. It combines with biotin and prevents the absorption. Is the chat stuck? I cannot see them moving. Is this the last message? Can you just scroll and check, please? Is the chat stuck? This message was sent quite long back. Please check the chat, online team. I cannot see any change in the messages for last 15 minutes. Okay, moving on to B9, folic acid B9. Its active form is the tetrahydrofolate required for the 1 carbon transport, and the figlu is the marker for intracellular level of folate. We measure the amount of figlu after giving a loading dose of histidine. Very important that deficiency during pregnancy will predispose to the neural tube defect, most commonly the meningomyelocele. So preconception supplementation with B9 is essential. Multiple inhibitors of folate metabolism have been used clinically. The methotrexate targets the folate metabolism in the humans. The trimethoprim targets the metabolism in bacteria, and pyrimethamine targets the metabolism in the malarial parasite. The B12 deficiency can also cause functional folate deficiency. This is known as the folate trap, and the folate deficiency will clinically present as the megaloblastic anemia. Megaloblastic anemia means the large RBC and the hypersegmented neutrophil. The large RBC and the hypersegmented neutrophil. This is what is known as the megaloblastic anemia, feature of the B9 deficiency. Moving on to B12, vitamin B12 is found only in foods of animal origin. It is found in foods of animal origin. B12 absorption requires cobalamin and intrinsic factor. The deficiency causes methylmalonic aciduria, and deficiency presents as pernicious anemia, which will have the megaloblastic anemia along with the subacute combined degeneration of the cord. Okay, so please remember this point. To differentiate between the two, we use these 4 features: megaloblastic anemia, homocystinuria, subacute combined degeneration of the cord, and methylmalonic aciduria. The first two are common in both B9 and B12 deficiency due to the folate trap. The second two are seen only in the B12 deficiency. Alright. Last vitamin is the vitamin C. It is a vitamin for human beings, primates, guinea pigs, and bat. Other animals are able to synthesize. These organisms cannot synthesize the vitamin C due to the deficiency of enzyme gulonolactone oxidase. Deficiency causes scurvy. The vitamin C acts as antioxidant, and it helps in the absorption of iron. It has a specific role in copper containing hydroxylases and iron containing hydroxylases, most important being the proline and lysine hydroxylase for the collagen. Okay, coming to the anemias due to different vitamin deficiency. B2 deficiency is going to cause the normocytic normochromic anemia. The B6 deficiency is going to cause the sideroblastic anemia. The B9 deficiency will cause megaloblastic anemia. The B12 deficiency is going to cause pernicious anemia, that is megaloblastic anemia plus subacute combined degeneration of the cord. And vitamin C deficiency is going to cause microcytic hypochromic anemia, which is the iron deficiency anemia. Okay, so please make note of these different types of the anemia, Okay, we are moving on to the carbohydrates. Among the carbohydrates, the important points which you have to keep in mind: first, Molish test, common for all carbohydrates. Carbohydrates can be classified as mono, oligo, and polysaccharides. All monosaccharides will give the positive Benedict test and the positive Barford test. Simplest aldose is the glyceraldehyde. Simplest ketose is the dihydroxyacetone. Among the disaccharides, the reducing disaccharides are lactose and maltose. The non-reducing disaccharides are sucrose and trehalose. The lactose is made up of glucose and galactose. The maltose is made up of glucose and glucose. Sucrose contains glucose and fructose, whereas trehalose is also made up of glucose and glucose. Okay, the composition of the different disaccharides. In some individuals, you are going to see the lactose intolerance due to the genetic deficiency of the enzyme lactase, which presents with the clinical symptoms related to the GI system. You also find reducing substance in the stool. And in these individuals, although they have lactose intolerance which is present in the milk, certain milk products are safe to consume, which are the curd and the yogurt. Talking about polysaccharides, they are subdivided as homopolysaccharides and the heteropolysaccharides. Among the homopolysaccharides, you can have the starch, glycogen, cellulose, dextrin, dextran, inulin, and chitin. Please note the substances which are not absorbed among the polysaccharides are known as dietary fibers. Cellulose is a dietary fiber, inulin is a dietary fiber. Please note cellulose is an insoluble dietary fiber, inulin is a soluble dietary fiber. Similarly, the hemicellulose, the lignin, the pectin, the gum, all of these. Okay, gum is uh, not to be labeled here. Okay, these are all dietary fibers. Out of these, pectin is soluble, the other two are insoluble. Pectin is soluble, the other two are insoluble. Dietary fibers means they are not getting absorbed from the diet. Among the heteropolysaccharides, you also have what is known as glycosaminoglycans. They are the repeating disaccharides containing amino sugars and the uronic acid. Distribution of glycosaminoglycan is sometimes asked, particularly for the different types of the glycosaminoglycan within the cornea and the connective tissue cartilage and in the bone. So please make note of these. Heparin sulfate is also found in the basement membranes. Heparin sulfate is also found in the basement membranes. Sometimes these glycosaminoglycans can accumulate in the body, giving rise to the condition known as mucopolysaccharidosis. This is a type of inborn error of metabolism. In these individuals, you will find the common presentation of cloudy cornea, mental retardation, stiff joint, cardiac abnormalities, hepatosplenomegaly, and short stature. The three conditions for which you have to remember the enzymes: MPS1 iduronidase, MPS2 iduronate sulfatase, and MPS6 where aryl sulfatase B is deficient. For all of these conditions, enzyme replacement therapy is available. Therefore, you must know the enzyme which has to be replaced. The property of isomerism, the different properties that you see is enantiomerism. In enantiomerism, all chiral carbon have opposite arrangement, whereas in diastereomerism, one or more chiral carbon have similar arrangement. Within diastereomerism, we have epimerism, where difference in orientation is only around a single chiral carbon. Glucose and mannose are epimers of each other. Glucose and galactose are epimers of each other. Please keep in mind, glucose and mannose are having the difference at carbon 2. Glucose and galactose are having the difference at carbon 4, GM2 and GG4. Anomerism is seen only in the ring structure. You can have the alpha and the beta anomers. They can be interchanged by a mechanism known as a mutarotation. Okay. We also have what is known as ring isomerism, where you have the pyranose and the furanose form, and the functional isomerism, where we have the aldose and the ketose forms. We have the aldose and the ketose forms. The Molish test, I already told you. The most important one which you have to note here is the Benedict test. This is commonly coming in the exam, so you should be able to visualize the Benedict test, how it appears in the image. So blue solution where there is no sugar, and bright brick red precipitate where there is large amount of sugar, and different colors in between. We have this table here showing the different tests and what are the results. Please don't confuse between Molish test and the Rothera's test. Molish test is for carbohydrates, Rothera's test is for the ketone bodies. Rothera's test is for the ketone bodies. Rothera's test is the one which is likely to land up in your exam because of the ketone bodies present in the urine. To identify them, we use the Rothera's test. Now moving on to metabolic pathways, starting with the glycolysis. Please remember, also known as the Embden-Merhoff-Parnas pathway, can be aerobic, can be anaerobic. It can have the preparatory phase, it can have the payoff phase. The sites where exclusively anaerobic glycolysis occurs include RBC, cornea, lens, epithelial layer of skin, and the GIT. Sites where you have both aerobic and anaerobic glycolysis are the CNS and the renal medulla, and the sites where you have exclusively aerobic glycolysis include all other locations, including the skeletal muscle. The glycolysis occurs exclusively in the cytoplasm and uses the hexoses and glycogen. For aerobic metabolism, the end product is 2-pyruvate along with 2-NADH. For anaerobic metabolism, the end product is simply 2-lactate. NADH is used up in this process. We also have the Rappaport Lubering shirt operating in the RBCs where 2,3-BPG is formed as an intermediate. The rate limiting enzyme for glycolysis is phosphofructokinase 1. The PFK2, PFK1, hexokinase, glucokinase, and pyruvate kinase, all of them can be targeted for regulation. In addition to that, the glyceride 3-phosphate dehydrogenase is inhibited by iodoacetate, enolase is inhibited by fluoride, and the phosphoglycerate kinase is bypassed by the arsenite. During anaerobic metabolism, the RBC can produce 0 or 1 ATP. Most tissues present 2 ATP, whereas skeletal muscle, when using the glycogen as fuel, present with the 3 ATP. Talking about aerobic metabolism, CNS and skeletal muscle make use of the glycerol 3-phosphate shuttle. They give 5 ATP, and liver, heart, kidney make use of the malate aspartate shuttle. They provide the 7 ATP. Talking about gluconeogenesis, please remember it occurs only in the liver and in the kidney. The compartment involved are both mitochondria and cytoplasm. The substrates, which is the most important question from the gluconeogenesis, include glucogenic amino acids, most important being the alanine. Lactate is most important after strenuous exercise. The pyruvate, glycerol, and the last 3 carbon of odd chain fatty acid. End product is obviously the free glucose. The rate limiting enzyme and target for regulation are the same, fructose 1,6-bisphosphatase. The most potent stimulator are the glucocorticoids along with glucagon and epinephrine. Inhibitor being the insulin. Insulin is the inhibitor. The enzymes which are specific for gluconeogenesis, these include the pyruvate carboxylase, pep carboxykinase, fructose 1,6-bisphosphatase, and glucose 6-phosphatase. These enzymes are bypassing the actions of the enzyme pyruvate kinase, PFK1, and hexokinase, which are specific enzymes for glycolysis. All other enzymes between the glycolytic pathway and gluconeogenesis are commonly shared. They are catalyzing the reversible reactions, but these enzymes which are mentioned here are the enzymes which are specific for the 2 different pathways. Talking about the different transporters, we have the facilitative transporters, which are the GLUT series. GLUT1 is commonly found in most of the tissues. GLUT2 is found in the liver, pancreatic cells, small intestine, and kidney. GLUT3 is found in the CNS, kidney, and placenta. GLUT4 is most commonly asked. It is found in the heart and skeletal muscle along with the adipose tissue, and this is the one which is insulin stimulated. GLUT5 is responsible for absorption of fructose from the intestine. The SGLT1 is present in the small intestine and kidney, whereas SGLT2 is present only in the kidney, and SGLT2 inhibitors are targeting the reabsorption of glucose in the kidney. Please note, GLUT4 can be mobilized by insulin, but also mobilized by calcium. They are also mobilized by calcium. That is why when you do the exercise, the absorption of glucose increases due to the mobilization of the GLUT4. Please note, SGLT1 is commonly present on the luminal surface. We just said it is present in the intestine, and it will take up the glucose and galactose, but not fructose. The SGLT does not take up the fructose. SGLT1 is also responsible for the success of oral rehydration therapy. Talking about the glycogen metabolism, please note that cyclic AMP is the central regulatory molecule acting on both glycogen synthase and the glycogen phosphorylase. In turn, the cyclic AMP is regulated by insulin and glucagon and epinephrine. in addition to hormonal regulation, the metabolism is also having the allosteric regulation focused on the glycogen phosphorylase, which is part of glycogen breakdown, where in liver and muscle ATP and glucose 6 phosphate are inhibitor. In liver but not in muscle, free glucose is inhibitor, and in muscle but not in liver, AMP and calcium both are activators. In this context, please remember that calcium is a dual activator. It is acting directly also, and it is acting indirectly via the calmodulin as well. This is a common question. Dual activator both directly and indirectly. It is the calcium which can activate the glycogen phosphorylase. Very commonly you get asked about the inborn errors of metabolism related to the glycogen storage disorders. Glycogen metabolism is not happening properly. Type 0, where there is no glycogen enzyme, is glycogen synthase. Type 1, also known as von Gerke's disease, enzyme deficiency is glucose 6 phosphatase. Type 2, also known as Pompe's disease, enzyme deficiency is the acid maltase, also known as lysosomal glucosidase. Type 3, commonly known as Cory's disease, deficient enzyme is the D branching enzyme, C followed by D. Type 4, known as Anderson's disease, where deficient enzyme is the branching enzyme, A followed by B. And another commonly asked question is type 5, McArdle's disease, where the deficient enzyme is the myophosphorylase. There is muscle damage here, so you can have myoglobinuria, you have decreased lactate after exercise in the McArdle's. Moving on to the fructose metabolism, the two enzymes fructokinase deficiency will cause essential fructosuria. Aldolase B deficiency is going to cause hereditary fructose intolerance, and if you don't treat even for essential fructosuria, the formation of sorbitol can cause development of a cataract. In hereditary fructose intolerance, there is a neurological presentation along with the poor feeding, lethargy, etc., and the dietary restriction of fructose has to be instituted. Age of presentation is after 6 months. Whereas in galactose metabolism, where again you have neurological signs and symptoms when there is a deficiency of one of the enzymes, you have similar features of neurological signs and symptoms, but age of presentation is within the first week of life. Age of presentation is within the first week of life, with the very characteristic feature of oil drop cataract. Very characteristic feature of the oil drop cataract. All right. Talking about the link reaction, it is linking the glycolysis with the Krebs cycle. That is why it is called the link reaction. This reaction uses the product of the glycolysis and makes the substrate for the Krebs cycle. Multiple coenzymes are involved here, requiring the different vitamins, and defect in the metabolism at this level can cause lactic acidosis. The different causes which can give rise to the deficiency and lactic acidosis, these are deficiency of vitamin B1 seen in chronic alcoholics, the arsenic and mercuric ions which can block the lipoic acid, and genetic deficiency of the pyruvate dehydrogenase which will cause the congenital lactic acidosis. The Krebs cycle or the TCA cycle, which is happening in all the tissues except the tissues with exclusive anaerobic metabolism, occurs exclusively in the mitochondria. Substrates are acetyl coenzyme and oxaloacetate. End products are oxaloacetate. It is being regenerated along with 1 FADH2, the 3 NADH and 2 steps of decarboxylation. Rate limiting enzyme for Krebs cycle is associated dehydrogenase, which is also a target for regulation. The feedback effect from ATP is the main regulatory mechanism. Okay. Fluoroacetate is inhibiting aconitase. These are part of non-physiological regulation. Arsenite inhibits alpha-ketoglutarate dehydrogenase, and malonate inhibits the succinate dehydrogenase. If you're talking about energetics of 1 acetyl coenzyme, 10 ATP are produced, but if you talk energetics of 1 pyruvate, then 12.5 ATP are getting produced in case of the Krebs cycle. Coming to electron transport chain, we have the different complexes, complex 1, 2, 3 and 4. These complexes have their own names, and sometimes the names are given in the question instead of the number. As you can see, each complex is transporting the protons. These protons will then travel through the F0 F1 particle, generating the ATP. If they travel through the uncoupler protein channel, they are generating only heat. Okay, so very frequently you get asked about the inhibitors of these complexes. So for complex 1, the amobarbitol, secobarbitol, phenobarbital, and the most important recently the rotenone has become the hot topic. For complex 3, the antimycin is the important hot topic, and for complex 4, you have to know all the 4 names: hydrogen sulfide, carbon monoxide, cyanide, and azide. The F0 F1 particle, also known as ATP synthase, inhibited by oligomycin and efrapeptin. The ATP ADP translocase is inhibited by atractyloside. You can expect questions on uncouplers, all phenolic compounds, the thermogenin, thyroxine. These are the important and relevant uncouplers you should know. They will contribute towards heat production and not ATP production. Coming to the enzyme section, certain very important points. What is the formula for catalytic efficiency? It is kcat by km. What do you mean by Vmax? Vmax is the velocity of a reaction under ideal conditions, which includes optimum temperature, optimum pH, and infinite substrate concentration. Km implies the substrate concentration at half the Vmax, and Km is inversely related to affinity between enzyme and the substrate. Factors which affect the reaction velocity include the substrate concentration, temperature, pH, and the enzyme concentration. Very frequently they'll come as single one liner. You can also be asked to identify the reactions involved in describing the enzyme kinetics. The first equation is the Michaelis-Menten equation. Please note Vi is equal to Vmax into substrate concentration upon Km plus substrate concentration. This is giving us the classical graph that you commonly draw, that is the hyperbolic graph, with the Michaelis-Menten equation. The Michaelis-Menten equation can be converted into the Lineweber plot, whereby 1 upon Vi is equal to Km upon Vmax into 1 upon substrate concentration plus 1 upon Vmax, giving us a graph like this, where you get the straight line graph. You get the straight line graph in the Lineweber plot, also known as the double reciprocal plot. Sometimes you might need to make the single reciprocal plot. The two examples are the Eddie-Hofstee plot and Hannes-Wolff plot. Talking about enzyme inhibition, in case of reversible inhibition, the 3 subtypes that you have to know about include the competitive, non-competitive, and uncompetitive inhibition. The changes in the Km and Vmax in each of them are listed here. In competitive, the Vmax does not change. In non-competitive, the Km does not change, whereas in uncompetitive, all the factors are decreased. Very commonly we get the Lineweber plot, where you have to identify the different types of inhibition. So you should be able to interpret these graphs and identify the different inhibition. Talking about irreversible enzyme inhibition, most important is the suicide inhibitor mechanism. The examples include the DMPA acting on monoamine oxidase, penicillin acting on glycopeptide transpeptidase, the 5-fluorouracil which is acting on thymidylate synthase, aspirin acting on the COX, and allopurinol acting on the xanthine oxidase. The alloxanthine or oxypurinol is the metabolite from allopurinol, which combines irreversibly with the enzymes. Please note that enzymes can be used for diagnosis, they can be used for treatment, they can be used in the laboratory for quantification as well. Please make sure that you know this table by heart. The most important rate limiting enzyme for the different metabolic pathways, always I am repeating, one question will be there from this table. All right, so please make note of the PFK1 as the rate limiting enzyme for glycolysis, the isositate dehydrogenase for TCA cycle, the G6PD for HMP shunt, the carmyl phosphate synthetase for urea cycle, the carnitine acyl transferase for fatty acid oxidation, and the acetyl coenzyme carboxylase for fatty acid synthesis. These are the ones which are most likely to land up in your exam. Talking about lipids, please note lipids do not have a chemical definition. They are described as molecules soluble in organic solvent. We have the classification of lipids, subcategorizing them into different groups. Some important molecules include the lecithin, which is acting as a surfactant. Deficiency can cause a respiratory distress syndrome. The phosphatidylserine, which is the marker for apoptosis. The phosphatidylinositol, which is the precursor for second messenger diacylglycerol anisotol triphosphate. The cardiolipin, where deficiency causes the Barth syndrome, and lysophospholipid, which are associated with atherosclerosis. The sphingolipids can get accumulated and give rise to condition known as sphingolipidosis. Within the sphingolipidosis, we have the autosomal recessive inheritance. The cherry red spot is seen in the individuals. Mental retardation is a common feature. Along with this, we have certain images. I'll come to that. But 4 enzymes you have to remember. Gauchers, most common. Therefore, you should remember the enzyme beta glucosidase. The Tay-Sachs, where there is no organomegaly, so you should remember hexosaminidase A. The Niemann-Pick disease, we should remember because this is the only condition where sphingomyelin will accumulate. In all others, it is a glycolipid which is accumulating. So sphingomyelinase in Niemann-Pick disease. In Niemann-Pick, you have 2 observations. One is the zebra body under electron microscope and the foamy histiocytes or the foam cells under the light microscope. These are the observations in the Niemann-Pick. These foam cells are being asked nowadays. The image is being given in the exam. You should be able to identify the foam cells, that is the foamy histiocytes under the light microscope. This zebra body inclusion is seen under the electron microscope, so unlikely to be there in the exam. Along with that, we commonly have the Gaucher cell, the crumpled or wrinkled tissue paper appearance in the Gaucher's disease. Gaucher's disease is the most common lysosomal storage disorder, where the beta glucosidase, also known as glucocerebrosidase, also known as glucosylceramidase, is deficient. Cherry red spot and mental retardation may not be seen and presents with abdominal pain. Sometimes it can present with the bone pain as well, and commonly elevated level of the chitotriosidase, ACE and TRAP are seen. So these are some of the features of the Gaucher's disease. Talking about fatty acid oxidation, the most common type is the beta oxidation, but we also have the alpha and the omega oxidation. Talking about the activation and transport as seen in beta oxidation, first we have the enzyme acyl coenzyme synthetase. This is common for all the different metabolisms, which converts the fatty acid into the acyl coenzyme. Acyl coenzyme is converted to acyl carnitine by the carnitine palmitoyl transferase 1, also known as carnitine acyl transferase 1, which is the rate limiting enzyme of beta oxidation. Acyl carnitine is brought inside by the action of carnitine acyl carnitine translocase, and this acyl carnitine is then converted back to acyl coenzyme, which can then proceed to the beta oxidation. I don't have an image of tiger eye. I'll send it in the messages on the telegram. You can check it there. In this current PDF, I don't have the image of the tiger eye. Okay, talking about beta oxidation, it involves multiple steps whereby the one FADH2 and one NADH is generated along with the release of one acetyl coenzyme. One acetyl coenzyme is released in every step. So sequential breakdown of 2 carbons is happening for the fatty acid. All this acetyl coenzyme will then go to the Krebs cycle for the further metabolism. If you have the odd chain fatty acid, the last 3 carbon cannot enter the Krebs cycle. So the last 3 carbon will come here, the propionyl coenzyme A. The last 3 carbon will come here, and the propionyl coenzyme is then getting converted to succinyl coenzyme, whereby it can enter the Krebs cycle. Once it enters the Krebs cycle, it can participate in the gluconeogenesis. The second metabolic pathway for fatty acid is the alpha oxidation. Alpha oxidation is for the branched fatty acid. Most commonly, the branched fatty acid in our diet is the phytanic acid. If there is defect in the metabolism, you are going to see the Refsum's disease. Alright. Sometimes there can be defect in the peroxisome as a whole. Either it is absent or it is empty, wherein we get the Zellweger syndrome. there is deposition of the very long chain fatty acid in the CNS, liver and kidney. That is why the Zellweger syndrome is also known as the cerebrohepatorenal syndrome. Very commonly Refsums and Zellweger is landing in your exam. Omega oxidation is a rare minor pathway, not much to note here. Okay, talking about lipogenesis, you should remember the locations where lipogenesis is prominent in the liver, kidney, brain, lung, mammary gland, and adipose tissue. Within the cytoplasm, utilizing the acetyl coenzyme coming from the carbohydrate, and the most common end product is the palmitic acid. However, please note, in the lactating mammary gland, the end product is the medium chain fatty acid. Rate limiting enzyme and target for regulation is the acetyl coenzyme carboxylase, both hormonal and the allosteric regulation is there. If it is phosphorylated by glucagon, it will become inactivated. However, under dephosphorylated state, it is activated. The citrate is the allosteric activator, whereas long chain acetyl coenzyme is the inhibitor of the acyl coenzyme A carboxylase, acetyl coenzyme carboxylase. The fatty acid synthase is the second enzyme involved in the fatty acid synthesis. It is a large molecule having huge number of catalytic domains and the transporter domain. Important point to note here, from where we are getting the NADPH for fatty acid synthesis, from HMP shunt, from isocitrate dehydrogenase, from malic enzyme. This question is asked very commonly. For fatty acid synthesis, you require the NADPH. The NADPH is mainly coming from the HMP shunt, but also from the cytosolic isocitrate dehydrogenase and malic enzyme. Yes, PDF you can get. I'll be posting it on the Telegram group, so you can take it from there, or ask the team to post in the common DAMS channel. Then we have the lipoprotein structure. You have a central structure and the peripheral structure, which is used for transporting the proteins. The important lipoproteins are chylomicron, VLDL, LDL, and the HDL. The function of apolipoprotein, most importantly, as ligand for interaction with the lipoprotein receptors in the tissues, and the chylomicron are transporting the dietary triacylglycerol. The VLDL is transporting the hepatic triacylglycerol, whereas the HDL is responsible for reverse cholesterol transport. It is responsible for reverse cholesterol transport. If there is any defect in these transport mechanisms due to some enzymatic or protein deficiency, you get the primary hyperlipoproteinemia. The ones you should remember is type 1 and type 2A. Type 1, where there is lipoprotein lipase deficiency, commonly presents with pancreatitis due to high triacylglycerol, and you can have associated cutaneous or subcutaneous eruptive xanthomas. Elevated chylomicron causing elevated triacylglycerol. Type 2A, which is the familial hypercholesterolemia due to the LDL receptor deficiency. LDL is elevated, therefore cholesterol is elevated, commonly presents with coronary artery disease, and tendinous xanthomas are the characteristic feature. Okay, for others you need not worry. Coming to ketone bodies, the ketone bodies are the acetoacetate, beta hydroxybutyrate, and acetone. The RBC and liver cannot make use of the ketone bodies. All others will use ketone bodies, including the CNS. The liver cannot use ketone bodies due to absence of the enzyme thiophorase, and ketone bodies are elevated in cases of diabetic ketoacidosis, the starvation, and alcohol intoxication. These are the three conditions where the ketone body level is found to be elevated. Coming to the amino acids, we have 20 amino acids about which we are discussing. These are the amino acids for which the genetic code is present. We can have D type amino acids in the free form. In humans, the D-serine and D-aspartate are found in the CNS. Amino acids can be toxic. Most well known is the BOA, which is causing the neuroletharism, but also make note of the homoarginine, the BAPN, the diamonobutyric acid. These are also causing the different types of the letharism. Different types of letharism are caused here. We also have what is known as 21st amino acid, that is the selenocysteine, coded by the UGA. It is present in the glutathione peroxidase, the deiodinase, thyrodoxine reductase, G6PD, and selenocysteine synthase. In some bacteria, we have what is known as 22nd amino acid by the name of pyrrolysine. Special products of amino acid, that is glucose from the glucogenic amino acids, the creatine from arginine, glycine and methionine. The glycine I told you involved in creatine synthesis along with purine ring, the heme synthesis and forming water soluble conjugates. The histidine gives rise to histamine. The involved reaction is decarboxylation. Similarly, methionine I already said involved in creatine synthesis. It also gives rise to the SAM acetylmethane, which is responsible for the 1 carbon transport. Tryptophan gives rise to the serotonin, melatonin and niacin. Tyrosine gives rise to the catecholamine, thyroxine hormones and melanin. Glutamate can be converted to GABA again by decarboxylation. Tyrosine is the precursor for the catecholamines, the dopamine, norepinephrine and epinephrine. Amino acid metabolism for the amino group occurs in the 4 stages: transamination, deamination of glutamate, ammonia transport and the reactions of urea cycle. Urea cycle you can see is occurring both in the mitochondria and in the cytoplasm. Sometimes when there is defect in the urea cycle metabolism, you get urea cycle disorders. The management of urea cycle disorders can utilize 2 very important molecules: sodium benzoate, which will be excreted in the form of hippuric acid, the phenylbutyrate, which will be excreted in the form of phenylacetylglutamine. 2 important commonly repeated questions in the urea cycle disorders. Other disorders include the PKU, the PKU, phenylketonuria, the tyrosinemia type 1, type 2 and type 3, and the alkaptonuria. In alkaptonuria, characteristically you have the blackening of urine on standing. If you keep the urine for some time, this blackening of urine. Later on, in later stages of life, you also have what is known as ochronosis, that is blackening of the mucosa and the cartilage. You can see the blackening of the sclera of the eye. Gradually as the age progresses, there is further blackening, and blackening can be seen in the cartilage of the ear pinna as well. This is ochronosis. In maple syrup urine disease, you have the burnt sugar odor of urine along with the mental retardation. Sometimes you can have defect in the amino acid transport. 2 important conditions are cystinuria, where amino acids lost in the urine are COLA, where C stands for cysteine and not cysteine, okay, and the others are ornithine, lysine and arginine. Hartnuss disease presents as the condition where there is loss of tryptophan. Tryptophan is required for formation of niacin, so the clinical presentation is that of pellagra. Talking about identifying the different amino acids, please make note of the new technique that absorption maxima at 280 nanometer for aromatic amino acids is commonly used for quantification of proteins only. And this biuret test, the biuret test sometimes might be there in the image form, so you should be able to identify the biuret test, which is for the proteins. At least 3 amino acids should be there before the biuret test will come out to be positive. Talking about the 4 orders of protein structure: primary, secondary, tertiary and quaternary structures are there. Please note, primary structure is the structure which will be intact even after denaturation. All other structures are lost after denaturation. In the tertiary structure, we have the additional disulfide bonds. In quaternary structure, we have the disulfide bonds along with covalent cross links as well. However, both the tertiary and quaternary structure will be disrupted on denaturation. Talking about the different types of collagen, you know there are 28 different types of collagen. The common ones are listed here. Type 1 is the most common. For type 4, you should remember that is present in the basement membrane. For type 3, you should remember it should present in the extensible connective tissue. And type 7 is present in the anchoring fibrils. We have already talked about scurvy, which is due to vitamin C deficiency resulting in weak collagen. In Menkes syndrome, ATP7A is the gene defect due to which there is decreased copper in the extracellular matrix, and as a result the enzyme lysyl oxidase is not able to perform the function of cross-linking the collagen. The collagen defect can be there in osteogenesis imperfecta, it can be there in the Ehlers-Danlos syndrome, but most importantly it is also seen in Alport syndrome, where there is defect in collagen 4. The gene defect is called 4A5, where you have the nephritic syndrome, you have the sensorineural hearing loss and the vision defect. In epidermolysis bullosa dystrophic type, collagen type 7, which is present in the anchoring fibrils, is deficient. The purines and the pyrimidines, purines have a single ring, pyrimidines have two ring, and they show the phenomena of tautomerism, interchange in the functional groups. This is known as tautomerism. The nucleotides perform various functions of energy transducer, second messenger, coenzyme, methyl donor, sulfate donor, monosaccharide, and the uronic acid donor. They are also used in treatment for chemotherapy, for treatment of gout, for immune suppression, and for antiretroviral therapy. And the absorption maximum of nucleotide is at 260 nanometer. This is a misprint here. It is 260 nanometer. Just like we had used the aromatic amino acids for quantification of proteins, similarly we can use here the absorption for the quantification. The covalent modification of histone and DNA methylation are very frequently asked. Please note, histone acetylation will cause increase in gene expression, whereas DNA methylation will cause decrease in gene expression. Methylation commonly occurs in the CPG islands. These CPG islands are a part of the enhancer elements. All of these are asked in the exam. Talking about the mitochondrial DNA, it is small and circular. It is small in size, having 16569 base pairs, has 37 genes, out of which only 13 code for electron transport chain proteins. In addition, when you compare the translation with the nuclear DNA, there are some differences which are listed here. There are some differences which are listed. Same differences you can see between eukaryotes and the prokaryotes. Inheritance is very simple. You have to remember the transmission is happening only from the mother. So only mother can transmit disease. Father cannot transmit the disease. You should be familiar with the names of the mitochondrial DNA disorders. Okay. Most common among the different mitochondrial DNA disorders is the MELAS. The most common to be identified is the MELAS. Talking about microRNA, very commonly coming up in the exam. Please note, initially what we get is the primary microRNA. It is acted upon by the enzymes. DROSHA and DGCR8 gives rise to the pre-microRNA. Pre-microRNA is then transported to the cytoplasm, where it is acted upon by the enzyme dicer. So please make note of these three enzymes: dicer, DROSHA, and DGCR8. DGCR8 is also sometimes known as PASHA. So maybe PASHA name is also there in the enzymes acting on the microRNA. So what happens? This microRNA gets incorporated into what is known as RISC, RNA induced silencing copy. It acts on 3' untranslated region of the messenger RNA. It acts on 3' untranslated region of messenger RNA, where it performs the function of regulation of gene expression via what is known as RNA interference. Okay, please note these points about the action of microRNA. Moving on to the genetic code. Genetic code is a triplet code. It is degenerate, it is unambiguous, non-overlapping, non-punctuated, also known as commaless, and it is universal. The exceptions that we had just mentioned for mitochondria versus nuclear DNA, the same points are listed here as well. Mutations can be seen. Two important mutations are base substitution, also known as the point mutation, wherein you see the transition and transversion. These can give rise to the silent mutation, the missense mutation, and the nonsense mutation. Within the missense mutation, the mutations may be acceptable, they may be partially acceptable, or they may be unacceptable. The most important example you have to remember is partially acceptable missense mutation, HBS, where glutamic acid is replaced by valine at position 6 in the beta chain. Okay, this is a very commonly repeated question from the point mutation. About the insertion deletion type of mutation, what you have to remember, if there is a single or double insertion deletion, there is shift in the reading frame. However, if insertion deletion is in multiples of 3, then there is no shift in the reading frame. This is what is commonly asked in the exam. About Leschnahan syndrome, you have to remember there is absence of the enzyme HGPRTase resulting in self-mutilation tendency. Along with self-mutilation tendency, you can have mental retardation and hyperuricemia. This hyperuricemia is due to the excess production of PRPP. This is PRPP in the CNS. About replication, you should be familiar with the different proteins which are involved in the DNA replication, and more importantly the two most common types of DNA damage and associated disorders. Mismatch repaired by the mismatch repair. When the defect is there, you get what is known as Lynch syndrome, also known as hereditary non-polyposis colonic carcinoma. Second is formation of thymidine dimers, also known as pyrimidine dimers, which is repaired by the nucleotide exchange repair. If this mechanism is not working, commonly you get to see what is known as xeroderma pigmentosum, where there is photosensitivity causing skin lesions which progress to the development of cancer. Talking about transcription, the common inhibitors of transcription in prokaryotes block the polymerase, RNA polymerase. Most important name you have to remember here is rifampicin. The eukaryotic transcription is commonly inhibited by alpha amanitin obtained from mushroom Amanita phyloides. Similarly, we can inhibit the translation process as well. The inhibition of protein synthesis can be done by the various toxins in the eukaryotes, and in prokaryotes the different antibiotics can cause the inhibition of the protein synthesis. Please make special note of diphtheria toxin and ricin, which can land up in your exam. The components of the ribosomal subunits in the prokaryotes and eukaryotes may be asked sometime. And about the Lac-Operon model, what you have to remember that Lac-Operon model will operate when lactose is present but glucose is absent, and once glucose is exhausted, immediately lactose metabolism does not start. There is a lag phase before the lactose metabolism can start. The last important and commonly asked question is the polymerase chain reaction. What exactly is polymerase chain reaction? Polymerase chain reaction is the amplification of a small segment of DNA where the sequence of nucleotides is known. The purpose why we perform polymerase chain reaction is for identifying infection, mutation, or for the polymorphism. Polymorphism is commonly identified in the cases where you want to look at the DNA fingerprinting. We are looking at the VNTRs, variable number of tandem repeats, and the STR, that is a short tandem repeat. The substrates which are required for polymerase chain reaction include the template DNA, the Taq polymerase, pair of primers, DNTPs, magnesium, and buffer. The steps in sequence which are part of the polymerase chain reaction are: number 1 denaturation, number 2 annealing, number 3 elongation, also known as extension step. And lastly, once the PCR is completed, the results are visualized with the help of DNA gel electrophoresis. Please keep in mind, multiplex PCR is nowadays commonly used in the syndromic diagnosis of meningitis. Previously, we had used this multiplex PCR for identifying the COVID infection. Nowadays, we are using it in the syndromic diagnosis of the meningitis. So this is where I'll stop for this 1 hour session that we have for quick revision of most of the important questions which are likely to land up in your exam on 28th. I hope this was a useful session for you. 1 hour with a very high yield. We'll share the PDF that we have generated in your group so that you can take it from there. And this will be all from my side. I'll sign out now. Thank you and best of luck.
Hi, good evening. Good evening. Am I visible? Yes, I'm seeing. Good evening. Starting little late, almost 20 minutes. Not an issue. Okay, it is a marathon. So we should have the stamina to face the whole day. I'm fine, my dears. I'm fine. Thank you. Thank you. So just 1 minute we can relax. Okay. How my kids will answer in the exam, not only in the exam. Now, how you are going to answer my questions? Like this. What our question? Fire. Mycology, parasitology, virology, general microbiology, immunology. Fire, fire, fire. Okay. Nice. Good evening. Good evening. This is called FMGE blast. Okay. Yes. Hope people got some energy to answer. Right. Shoot at sight. Just the answer. I will give everything in a PDF to you, not an issue. Don't worry, it is not military secret. It is just microbiology. I will give you the material. Now you consider in 1 week prepone your program. Today you are sitting in the exam hall. If the question comes, how you are going to answer? Learn. That is important. Okay? Come on. Gene transfer process, DNA transfer via pilus, plasmid transfer via pilus. Anything transfer via pilus, we call it as conjugation. Direct uptake of DNA from naked environment is transformation. Only one is pending. If it is the gene transfer happened via virus, that is called bacteriophage. We call it as transduction. We have two types, generalized and specialized. That's all. Next is microscopy and bacteria. Bamboo stick appearance, MCQ. You must know. Bioterrorism category A. Who is that fellow? Bacillus anthracis. No need to type also. You shout. Okay. Next is lanceolate shaped bacteria. If you try to hunt multiple, I'm showing some messages here. You DM me like that and all. Want simultaneously, if you want to hunt multiple sources or multiple rabbits, you have the feeling of hunting, you won't succeed. I'm really telling. Focus on one thing, whatever it may be. Focus, shoot it. That's all. If otherwise you collect lot of materials from various sources, you have the happiness. I had all materials. But what about the result? That is important. Result is important, my dears. Lanceolate shape, Streptococcus pneumoniae, flame shape. Bunch of grapes, everybody knows. Bunch of grapes, Staphylococcus aureus. Safety pin appearance, many people are there. Yersinia, Vibrio parahemolyticus, Pascherella, okay, Burgholderia, Sudamali, many are there. Important, Yersinia pestis. School of fish, one by one, school of fish, tram track appearance is Haemophilus ducreyi. Haemophilus ducreyi. Fish in stream, Vibrio cholera. School of fish, Haemophilus ducreyi. Fish in stream, Vibrio cholera. That's all. Next is Chinese letter pattern. No second thought. Palisade, Chinese letter pattern, Corynebacterium diphtheriae, pseudomembranous tonsillitis. Drumstick appearance, which causes opisthotonus, spastic paralysis. Who is that? Clostridium tetani. Great, great. People answering. Great, great. Kidney-shaped bacteria, kidney-shaped diplococci, Neisseria gonorrhoeae. Gulving appearance, which causes bloody diarrhea. Gulving appearance, microaerophilic, darting motility. Who is that fellow? Campylobacter jejuni. Thumbprint appearance, Bordetella pertussis. Lens-shaped bacteria, lens-shape, kidney-shaped Neisseria gonorrhoeae, lens-shaped Neisseria meningitidis. Neisseria meningitidis. Superb. Hey, beautifully answering. I'm so happy. Next is Chidia Higashi syndrome. Little tough. Not every ball is short pitch. You can get 6. Sometimes bouncer will come. Chidia Higashi syndrome. What is the defect? List gene defect. lysosomal trafficking regulatory gene, list gene. Chronic granulomatous disease, it is phagocytic disorder, NADPH oxidase defect. NADPH oxidase defect. Next is, everybody knows, Bruton's X-linked A gamma globulinemia. Bruton's X-linked A gamma globulinemia. What gene? BTK gene, Bruton tyrosine kinase gene. BTK gene defect. Very good. Friends, good. I'm seeing many names. Very good. Nictophile. Great. Ataxia telangiectasis. ATM gene. Dijat syndrome. You know the mnemonic catch 22. Which gene? The 22 stands for 22q11 deletion. 22q11 deletion. And paroxysmal nocturnal hemoglobinuria, complement deficiency. Okay, that is called DAF, decay accelerating factor, otherwise called CD55. CD55 deficiency, decay accelerating factor. We will get this beautiful printed matter. Don't worry about my handwriting, difficult to read also. Here, beautiful printed matter, colorful matter, you will get. Last minute revision. Go through this. Autoimmune disease associated with organism. Group A beta hemolytic streptococcus associated with mainly rheumatic fever, post streptococcal glomerulonephritis, but mainly rheumatic fever, acute rheumatic fever. Campylobacter jejuni, recently Pune, many places the outbreak happened. GBS, ascending paralysis, Guillain-Barré syndrome. Chlamydia trachomatis, Reiter's disease, HLA-B27, Reiter's disease. Hepatitis B virus, multiple sclerosis. Many people multiple sclerosis. One is hepatitis B virus. Cytomegalovirus, scleroderma. Many people scleroderma. One is cytomegalovirus. Coxsackie virus, always remember, myocarditis. Coxsackie virus, myocarditis. Made for each other. These and all shoot at sight. Question comes, you need to shoot. No second thought. Hypersensitivity type. Allergic rhinitis. Type. Allergy. Very good. Type 1. Contact dermatitis. Type 4. Type 4. Two things, my dear. There is a question, sir, where you can get. One thing, it will be uploaded in the app. Second, I will put it in Telegram. Telegram today not active, but it will be active by tomorrow. They said after NEET exam is going there. Okay, my son also there in the exam hall. After finishing this, I will go and pick him. Don't worry. And after that, Telegram will be normalized. I will put it in my Telegram group. Don't worry. In a downloadable printed format. Don't worry. Okay, right. Next is serum sickness. Orthus reaction comes under type 3. Graves disease. Once the name comes, you should say type 2. Low plus pneumonia. Ascariasis. Type 1. Lepra reaction 3. Type 3. Don't say type 2. Lepra reaction 3. Type 3. That's all. 46 slides, my dear. Not much. Just 45 slides. 45. Each will take 1 minute for you to read. 45 minutes. Can you spend next 1 week 45 minutes for this microbiology? You will get benefited. Next is antibiotic function. Opsonization. Opsonizing antibody IgG. Agglutination IgM. Precipitation IgG. Anaphylaxis. Always remember, allergy means IgE. Mucosal paint. IgA. Mother to child, one and only antibody which crosses mother to child is IgG. Alternate pathway, A for A, IgA. Mainly IgG for after that. First is IgA. Remember this, make it easy. 4 to 5 my time. I'll finish 5:05 or 5:10 like that, because I don't want to take, somebody should adjust the whole timing. Don't worry. I will adjust my time. Next is toxin mechanism of action, 100% question prone area. Next Sunday, you people tell any question come from this slide or not. Tetanus plasmin. Inhibit the release of GABA and glycine. Cleaves the snare protein. Inhibit the release of GABA glycine. Botulinum toxin. Same. Cleave the snare protein. Inhibit the release of acetylcholine. So flaccid paralysis. Tetanus, spastic paralysis. Diphtheria. ADP ribosylation of elongation factor 2 inhibits protein synthesis. Same function seen in Pseudomonas toxin also. Pseudomonas toxin also. Yes, Dr. Pranav. PDF and WhatsApp group link. I'll put it in WhatsApp group also. Don't worry. E. coli, stable toxin. Mechanism of action, cyclic GMP. Labile toxin, AMP. Shiga toxin and enterohemorrhagic E. coli toxin acting on 60S or 28S ribosome inhibits protein synthesis. Inhibits protein synthesis. Next is DAMS phenomenon. Old phenomenon. Sometimes if they want to irritate you, they will ask in Proteus. They want to check the Proteus strains are same or different. Okay. Now it is a little bit not in use. But DAMS method, we are using mycoplasma. M for M, easy to remember. How I used to teach? DAMS phenomenon, P for Proteus. Method, M for mycoplasma. Staining of colony. Staining of colony. Very good. Honeymoon cystitis caused by Staph saprophyticus. Any UTI common is E. coli. Staph saprophyticus as well as E. coli. Honeycomb crust, that is called in the honeycomb crust, this area's crusted lesion. Impetigo caused by Streptococcus pyogenes, Staphylococcus, many people. Cat bite abscess, Pasteurella multocida. Cat bite, cellulitis. Cat scratch disease, see the tongue twister. This is our tongue twister. Honeymoon, honeycomb. Cat bite abscess, cat scratch disease. Bottonella Hensley. This is you must know. In the exam, last small twist will confuse you. So now itself you practice. Rat fever, leptospira. Rat bite fever, spirilla minus, those kind of people. Next is inclusion body. HP body, Henderson-Peterson, molluscum. Negri body, no second thought. Everybody will answer Negri body is, you can get it from rabies. Lipschultz bodies, herpes simplex virus 1 and 2. Very good, very good. Beautifully answering. Who is that? Vishal, some official. Taurus bodies, yellow fever. Bollinger bodies, foul pox. Guarneri body, little tough. Vaccinia, many are there. Passion bodies, variola. Passion, variola, Guarneri, vaccinia, Negri, rabies. Taurus bodies, yellow fever. Remember, Negri body, Taurus body, Henderson-Peterson, these three are very important. Next is, yes, always we have a question on hepatitis B serology, no second thought. Hepatitis B serology, surface antigen present, infection present, core antibody IgG, it is chronic hepatitis B. Chronic. Only core antibody IgM present, window period. Only core antibody IgG, past infection. only surface antibody present. No disease, no infection, protection, vaccination. Surface antibody, core antibody. When no antigen, only antibodies are present means recent recovery, recent infection or convalescent period. Only surface antigen present for long time, simple carrier, along with the DNA, many other super carrier. And if it is more than 6 months present, chronic carrier. Got it? These are all some virological markers you must to know. You must know the medium, you must know the markers, you must know the vectors. Okay, like that. 5 to 6 topics you must to know, must to know, must to know. Next is source agent. School sore, common name, impetigo, Streptococcus pyogenes. Oriental sore, otherwise called Delhi boil, leishmaniasis, cutaneous leishmaniasis, Leishmania tropica. Cold sore, especially lips, many other places. Herpes. These are all common clinical names. I'm doing a little bit surgical strike in dermatology. Next is soft sore is chancroid, Haemophilus ducrei. Hot sore, Treponema pallidum. Hot chancre. Rodent sore, not our this thing, not microbial, but just remember, rodent sore is basal cell carcinoma. Basal cell carcinoma. Next is swimmer's itch, cercarial dermatitis, cystosoma. Swimming pool granuloma, atypical mycobacterium marinum. Very good. Beautifully answering, I'm checking. BCC, pallidum, great. Swimmer's ear, Pseudomonas aeruginosa, diffuse otitis externa or benign otitis externa. Swimming pool conjunctivitis, adenovirus or chlamydia, anything, adenovirus or chlamydia. Swimming pool meningoencephalitis, after swimming, meningoencephalitis. Free living amoeba, Acanthamoeba neglaria mainly. Acanthamoeba neglaria. Superb. Next is rose is the rose is the rose is the rose. Micro and rose, romance. Huh? Rose gardeners disease, thorn prick, nodules along lymphatic drainage, sporotrichosis, sporothrix. Rose spot, that is the clinical picture for stepladder fever, rose spot, where you can get coated tongue, typhoid, enteric fever, typhoid fever. Rose water test not in use, old complement fixation test for rheumatoid arthritis, old one not in use. Rose Bengal card test to check the quality of milk, pasteurization. Okay, brucellosis to identify the brucella in the milk. Roseola infantum, a clinical condition. We call it as sixth disease caused by human herpes virus 6. It is otherwise called exanthum subitum. Exanthum subitum. Rose fever, otherwise called hay fever. Other name for rose fever. These are all some important rose. Romance means I want when I'm making the slide, I remember, put all honey together. Honeymoon cystitis, honeycomb lesion, kissing disease, darling's disease, kissing bug, like romance and micro. Okay, like that. If people are aware of that, I put everything somewhere, not as a, but everything is there. Don't worry. Yes, holy color. Yes, color in micro. Black disease. What is called black disease? Be careful, not black death. Black disease is Kala Azar. Kala means black. White plague is tuberculosis. And now black death, Now only what you expect. Okay, Black Death is plague. Pink eye, adenovirus. Blue pus, anything blue green, always remember Pseudomonas. Red disease is porotrichosis. The name is called red disease, porotrichosis. One more I can add, yellow fever virus. Yellow fever virus. So it is very easy to remember. So I didn't add. I don't want to overburden you. Next is smell. Fishy smell, where you can get. Proteus. Sweet, fruity or grape smell. Pseudomonas aeruginosa. Great. Green apple smell. Little tough question. Alkaligens fecalis. Don't worry. If you read something new, if you think the topic is not important, just leave it. Don't be panic. Mouse cage, echinella. Rotten fish smell, important. Rotten fish are amine order. Bacterial vaginosis. Gardnerella vaginalis, like that. Rotten fish smell are amine order. Caramel smell is Bottonella Hensley. So you must know fishy smell, sweet fruity smell, rotten fish smell. Remember these three, sufficient. Other just to go through this. Next is water can perineum. It's a complication of multiple abscess with discharge. Gonococci. Gonorrhea. Water can perineum. Waterhouse friction syndrome. Meningococci. It is fulminant meningococcemia. Fulminant meningococcemia. Banwarth syndrome. Neuroborreliosis, Bell's palsy. Borrelia burgdorferi. Banwarth syndrome. Hemolytic uremic syndrome caused by enterohemorrhagic E. coli O157H7. Hemolytic uremic syndrome. Hepatorenal syndrome, I used to tell in the class, liver and kidney become chutney. What is it? Leptospirosis. Leptospira. Toxic shock syndrome, TSST. Toxic shock syndrome, toxin mainly by Staphylococcus aureus. Staphylococcus aureus. Bullet should not be exhausted. We have a lot of bullets. Shoot. Tuck, tuck, tuck. Next is clue word, target rash, round rash, bullseye rash, Borrelia burgdorferi, Lyme disease. Target hemolysis, double zone hemolysis, first beta followed by alpha. Clostridium perfringens. Erythema arthriticum. Haverhill fever. Streptobacillus moniliformis. Erythema multiforme, target-like lesion caused by herpes as well as mycoplasma. Mainly herpes, human herpes virus 1 and 2 and mycoplasma. North American blastomycosis. Blastomyces dermatitis. South American, Brazil. Paracoccidioides brasiliensis. Football matches are there. Everybody aware of Brazil. South American country. Paracoccidioides brasiliensis. European blastomycosis. Can anyone type European blastomycosis? I'm waiting for you, my dears. Your reply. European blastomycosis caused by, great. European blastomycosis caused by Cryptococcus neoformans. Nice. Cryptococcus neoformans. Fantastic. Next is clue word, nurse cell. Trichinella spiralis. That is the final stage in human being. Nurse cell. Permanently settled. Flame cell, see in the excretory gland of, schistosoma. Dust cell, it is a macrophage name. Kupfer cell, dust cell, Langerhans cell. Okay, these are all a microglial cell, mesangial cell. These are all what name? Other name for macrophage. Dust cell is lung, alveolar macrophage. Alveolar macrophage. Very good. Foamy cell in leprosy, Mycobacterium leprae. Medusa head colony, colony morphology, Bacillus anthracis. Daisy head colony, diphtheria, especially gravis. Daisy head colony, diphtheria, gravis. Medusa head colony, anthracis. These are all tongue twisters. Everything looking similar. Nurse cell, flame cell, dust cell, foamy cell. Medusa head colony, daisy head colony. It will confuse you in the exam. For that reason, I posted here. Next is cold abscess. All chill. Cold abscess. What is cold abscess? Tuberculosis. Mycobacterium tuberculosis, we call it as cold abscess. Cold enrichment. Listeria will grow in the refrigerator. Listeria grows in the refrigerator. Cold enrichment. Cold antibody is IgM. Cold sterilization, gamma rays, ethylene oxide, gamma rays, filters, everything comes under cold sterilization. Gamma rays, filters. Cold agglutinin test, mycoplasma, cat, CAT, cat. Cold agglutinin test, mycoplasma. Cold sore, already told. Herpes. Cold sore, herpes. Repeat. Previously we made cold sore, oriental sore, school sore, like that. Soft sore, hard sore, like that. Cold sore, herpes. Great. Next is rapid fire. So now we completed shoot at sight. Rapid fire means you need to tell 2 points each one. One dimension, single diffusion. What is it called? One dimension, single diffusion. It is called odd-in procedure. Immunology. One dimension, double diffusion. Up and down. We call it as Ocular-Fulthorpe. Two dimension, single diffusion. Two dimension, single diffusion. Manzini procedure. Two dimension, double diffusion is Achorloni. You must know Achorloni. Odd-in, Ocular-Fulthorpe, Manzini, Achorloni. Rare piece. If you want, you can read. Otherwise, you can leave. It is little rare. Rarely they will ask. Sometimes they will ask. Okay. The person want to be the topper can read. Next is, yes, trio. Disease, agent and vector. Chagas disease. You need to tell 2 points. That is called rapid fire. Okay. Chagas disease caused by Trypanosoma cruzi. Vector is Redweed bug or Triatome bug or kissing bug. Epidemic typhus caused by Rickettsia prowazekii. Rickettsia prowazekii. Vector is louse. Sauda, leopard skin. Onchocerca valvulus. Vector is black fly or Similium fly. Kala azar, everybody knows leishmania. It's caused by leishmania donovani. Vector is sandfly, phlebotomus. Sandfly, phlebotomus. Plague, aware of that. Yersinia pestis. And rat flea is the vector. Xenopsilla chiopsis. Xenopsilla chiopsis. And easy question, malaria caused by Plasmodium species and female Anopheles mosquito. All vectors females. Don't worry. Anopheles mosquito. That's all. See, one slide, your vectors over. One slide, your vectors over. Got it? Right. Next is Rapid fire. Same. Scrub typhus. What is the vector? Agent. Orientia Susugamushi. Vector is mite. Because vector question is important, you must. African sleeping sickness caused by trypanosoma brucei. Vector is CC fly. Calabar swelling. Loa. Vector is Chrysops fly, otherwise called mango fly or deer fly. Mango fly or deer fly. Endemic typhus. Endemic typhus caused by Rickettsia typhi. Vector is again rat flea. You must know, my dear. Must know. Lyme disease. Borrelia burgdorferi. Vector is Optic. Optic is vector for many people. Babesia, Ehrlichia, Lyme disease, Indian tick typhus, Rocky Mountain spotted fever, like many people. Vector is Optic. Dengue, caused by dengue virus. Vector is Aedes aegypti mosquito. Aedes is vector for 4 people. Dengue, yellow fever, chikungunya, Zika. Chikungunya, Zika. All 4 people vector is Aedes mosquito. This Aedes mosquito. Next is rapid fire. Bordetella pertussis. What is the selective medium? BG medium or Regan-Low medium. Colony morphology. Mercury drop. Bisected pearl. Aluminum paint. Remember anyone. Mercury drop. Legionella. BCYE agar. Buffered charcoal yeast extract agar. Cut glass colony. Must know. Pseudomonas aeruginosa. Cetrimide agar. Blue color colony. Iridescent colony. If you see under ultraviolet rays, iridescent. Actinomyces. Even blood agar. Molar tooth colony. Spidery molar tooth colony. These are all rapid. Streptococcus pneumoniae. Chocolate agar or blood agar. Round colony. What is it called? Carom coin or Draughtsman colony. Carom coin or Draughtsman colony. Haemophilus influenzae. Fildes agar. Again it produces iridescent colony. Fildes agar. Iridescent colonies. Especially Leventhal agar. Beautiful iridescence you can see. Leventhal is the best answer, but Fildes is there, you can go for it. Sapphorius ludlam, black color colony. Oil paint. Vibrio cholera. TCBS, oil drop colony. Oil drop colony. Cornybacterium diphtheriae, mitis, Tinsdale agar, poached egg colonies. Poached egg. Rarely the question may come. But this is common question. Mycoplasma, we are using PPLO agar. It produces fried egg colony. This is important. This fried egg is important. Rather than poached egg. Poached egg is rare entity. This is common entity. Fried egg colony, Mycoplasma. Cornybacterium diphtheria intermedius, Tinsdale agar again, but now it produces frog egg colonies. These are all rare. Frog egg, poached egg, rare. But common fried egg colony, Mycoplasma, you must know. Next is real rapid fire started. Food. Chinese fried rice. Bacillus cereus. It causes emetic type or diarrheal type. Hamburger. Enterohemorrhagic E. coli. Hemolytic uremic syndrome, bloody diarrhea, hemorrhagic colitis. Canned food. What comes to your mind immediately? Canned food. Clostridium botulinum. It causes wound botulism, infant botulism, gastrointestinal botulism, many things it causes. Flaccid paralysis, floppy baby syndrome, many things. If identify Clostridium botulinum, then any question may come. Nice. I'm enjoying you people how nicely answering. Enthusiasm. Good. Seafood. Vibrio cholera, Vibrio parahemolyticus, Vibrio parahemolyticus, astrovirus. Salads. Staph aureus, Clostridium perfringens. Oyster. Vibrio parahemolyticus, calcivirus, like that. Cheese. Always remember listeria. Cheese. Always remember listeria. Next is strawberry tongue. Which organism? Group A beta hemolytic streptococcus, scarlet fever. Scarlet fever. Group A beta hemolytic streptococcus. Same. Strawberry cervix. Where you can get strawberry cervix? Trichomonas vaginalis. These and all shoot. Calci oyster, my dear. Prince, calcivirus is oyster. Oyster. Seafood. Kawasaki also strawberry tongue. I will accept because this is not biochemistry. This is microbiology. So I give importance to gas. You are right. Next is, this is what tongue? Coated tongue, typhoid. And these lines are called pastia lines. Group A streptococcus. Scarlet fever. Scarlet fever, remember, SAS. One is strawberry tongue, SPS, pastia lines, and sandpaper rash. Sandpaper rash. Vaginal tampon, toxic shock syndrome toxin, over. Staphylococcus aureus. Antibiotic usage, enterocolitis, pseudomembranous enterocolitis, Clostridium difficile. And prosthetic valve, infective endocarditis. Prosthetic valve infective endocarditis caused by early staph epidermidis, late viridans. Early epidermidis, late viridans. Yeah. Mickey Mouse appearance, pilot wheel appearance, Paracoccylitis brasilensis. Owl eye, you can see in cytomegalovirus. That's all. BB, figure of 8. Broad base, budding cell, snowman, blastomyces dermatitis. India ink, you can get capsule. India ink encapsulated yeast. Cryptococcus neoformans, no second thought. These are all the questions. Spaghetti meatball appearance, Malassezia, Furfur or Malassezia globosa. Barrel shaped arthroconidia, Coccidioides immitis, pre with endospore, or barrel shaped arthroconidia, Coccidioides immitis. Spindle shaped macroconidia, Microsporum. And aseptate typhae with nodal rhizoid, Rhizopus. Easily you can answer. Rhizopus. Broken pink ball appearance, Nemosis girovasi, GMS stain. These and all, just like that. 6 are asteroid bodies. Asteroid bodies, where you can get Sporothric shenki, Sporotrichosis, Sporotrichosis. Exactly 40 minutes over. Next is, yes, see the thing here? Are you able to see? See here, hairy appearance, ciliated protozoa, Balantidium coli. And if you see anything small size uniformly stained cryptosporidium, if you are able to see some ghost cyst which is not taking stain, is cyclospora. And oval shape cystoisospora, not cystiospora, cystoisospora. O missing. Spelling mistake, I'm sorry. Cystoisospora. I will correct it in forthcoming. Cystoisospora. Leaf shape. Falling leaf motility. Jadia. Leaf shape. Falling leaf motility. Jadia. Mask shape appearance. Vaginal discharge. Twitching motility. Trichomonas vaginalis. Trichomonas vaginalis. Inside the RBC ring. Plasmodium. Multiple rings. Plasmodium falciparum. Cross. What cross? Don't say hard cross bun. Okay. This is called Maltese cross appearance. Maltese cross appearance. Where you can see Maltese cross. Babesia. Maltese cross. Sorry, don't want to hide. This is Babesia. Maltese cross Babesia. Trypanosoma cruzi or any trypanosoma. It is called trypomastigote. Trypomastigote. Hemoflagellate. Trypanosoma cruzi. Here, quadrinucleate cyst. See carefully. 1, 2, 3, 4. Quadrinucleate cyst. Entamoeba histolytica. Quadrinucleate cyst. Entamoeba histolytica. Trophocyte may ingest RBC. Trophocyte may ingested RBC. Yes, egg with lateral spine. Schistosoma manzoni. Terminal spine, hematobium. Knob-like structure, japonicum. So lateral spine, manzoni. Always remember. And terminal spine, hematobium. Knob-like structure is japonicum. Make it easy. Knob-like structure, japonicum. Barrel shape egg. Mucous egg morphology 100% question. Egg morphology again 100% question. Barrel shape egg with mucous plugs. Trichuris. Operculated egg. All trematodes except cystosoma. Diphyllobothrium latum also. Diphyllobothrium latum. All trematodes except cystosoma. Because cystosoma spined egg. See, it is hexacanth egg with, see the gap is big. You can see one polar filament. It is H-nana. If there is no polar filament, tinea egg. Make it easy. In human stool, hexacanth egg is present. The gap is big. You can see polar filament. That is H-nana. There is no polar filament. That is tinea. That's all. But both are hexacanth egg. 6 hook-like structure present. Plano-convex. Kidney-shaped egg. Entrobius. Clear shell. Hookworm. Mammillated edge. Anywhere you can see the serrated edges. Ascaris. Make it easy. Ascaris. What is it? Blueberry muffin rash. Where you can get? PCR. Blueberry muffin rash is PCR. What is PCR? Parvovirus, cytomegalovirus, rubella. Mainly rubella. PCR. Blueberry muffin rash. What is it, my dears? Unilateral periorbital edema with ptosis. Unilateral periorbital edema with ptosis. What we call it as? It is called Romanas sign. Caused by Trypanosoma cruzi. Trypanosoma cruzi. What is it? Bifurcated tail. Forked tail. Cercariae. Forked tail, cercariae. Infective stage of schistosoma. It penetrates the skin, causes swimmer's itch. We have seen just now. Cercarial dermatitis, swimmer's itch. What bodies? Brown color. Copper penny bodies, chromoblastomycosis. Any other name? Medlar bodies, muriform bodies, medlar bodies, muriform bodies, sclerotic bodies, copper penny bodies, medlar, muriform, sclerotic, copper penny bodies. Make it easy. It's a chromoblastomycosis. Chromoblastomycosis. Okay. I told I'm going to finish by 5:10. Now the time is 5:07. Okay. Time to say thanks to you. Thank you very much. God bless you. Hope you all enjoy the session. It's a rapid fire session. I will give the PDF to you. I'll post it in almost whatever group I'm available in the what is called WhatsApp or Telegram. WhatsApp today you will get. Telegram you may get tomorrow, not an issue because it should be activated. Thank you very much. Very active, enthusiastic batch. Okay. With this, I am signing off because I need to give time to other faculty. Now the time is 5:07. At least they can start by 5:10. Okay. Right. Thank you. God bless you.
All right. So, hi everyone. Hi everyone. Hi everyone. Am I audible? Hello, 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 hello. Hello everyone. Let's start with PSM. Let us start with PSM. Can we start? Yes. Can we start with PSM? बंद कर दो ना. All right. Good evening. Good evening, everyone. Good evening, everyone. Can we start? All right. Hello, 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 everyone. बहुत जल्दी, very quickly, we are going to revise because this is, FMG marathon. I welcome you all without wasting time. बिना time waste किए फटाफट से शुरू करते हैं और पूरी PSM अगले 1 घंटे में फास्ट फॉरवर्ड मोड पे रिवाइज करते हैं. सबसे पहले हमें पता है बहुत इंपॉर्टेंट टॉपिक जो ब्रेड एंड बटर है PSM का, आप ये छोड़ के नहीं जा सकते. HDI निमोनिक हमने क्या बताया था? निमोनिक हमने बहुत बार पढ़ चुके हैं हम. हे डोंट किल एट बर्थ. Hey, don't kill at birth. K stands for knowledge, income, life expectancy at birth. आगे चलते हैं. Knowledge, income, life expectancy at birth. उसके बाद हमारे पास है PQLI. निमोनिक क्या है? Ill at the age of 1 year. And global hunger index निमोनिक क्या है? MMM. ये बहुत बेसिक स्लाइड है. बार बार इस पे क्वेश्चन आ चुका है FMG में, नीट PG में. हर साल इन पे क्वेश्चन आता रहा है. राइट. लास्ट ईयर नहीं आया, सो डोंट गेट डिसहार्टन कि नहीं आएगा, बट हाँ ये ब्रेड एंड बटर है, ये हम नहीं छोड़ के जा सकते. उसके बाद है मल्टी डायमेंशनल पॉवर्टी इंडेक्स. इस पे कभी क्वेश्चन नहीं आया, बट द निमोनिक इज हेल्थ. सो पॉवर्टी इज रिलेटेड टू हेल्थ, nutrition, child mortality. In education we have years of schooling, school attendance, and all of these parameters are related to standard of living. अब चलते हैं आगे. क्वारंटाइन आइसोलेशन. फॉर क्वारंटाइन, इफ आई टॉक अबाउट क्वारंटाइन इज डन फॉर कॉन्टैक्ट्स and isolation is done for cases. Till what time we do quarantine? We do for maximum incubation period, and isolation is done for period of communicability. ये वाला पार्ट बहुत इंपॉर्टेंट है. सुनो मेरी बात, डायरेक्टली नहीं पूछेंगे क्वारंटाइन इज डन फॉर. एक सिनेरियो देगा आपको. मैं जितना भी पढ़ा रहा हूं उसमें वो डायरेक्टली नहीं पूछेगा. डू नॉट एक्सपेक्ट कि वो आपसे डायरेक्टली पूछेगा. एक्सपेक्ट कि वो आपसे इनडायरेक्टली पूछेगा, एक बच्चा है उसको खांसी जुकाम हुआ, उसके एक फ्रेंड को, द फ्रेंड ऑफ दैट किड developed fever also. Now who will go into isolation, who will go into quarantine, right? So always expect these kind of questions. आगे चलते हैं. Now coming to surveillance, active surveillance when we are going house to house, passive surveillance when cases are coming to us, sentinel surveillance is done for missed cases, sentinel surveillance is done for missed cases. यहां भी अभी रिसेंटली नीट पीजी में आया है और ये मेरी बहुत गट फीलिंग है एफएमजी के लिए भी. Scenario. Now they will not ask you direct questions. Scenario. There is a boy who is having fever. He came to the OPD and there he was diagnosed as COVID-19. This is passive surveillance because the case was reported to health facility. अब चलते हैं आगे. ब्रेड एंड बटर क्वेश्चन, ब्रेड एंड बटर टॉपिक, लेवल ऑफ प्रिवेंशन. लेवल ऑफ प्रिवेंशन एक ब्रेड एंड बटर टॉपिक है, इसके बिना पेपर बनना अधूरा है. नाउ प्राइमोडियल risk factor before risk factor, primordial before risk factor, right? Primordial before risk factor. Now coming to okay, yes, I will be talking in English, right? Okay, comfortable now. So primordial before risk factor, primary after risk factor, right? In both the scenario, disease is not developed yet. In both the scenario, disease is not present, right? Now coming to secondary, the disease is in early stage. The disease is in early stage in case of secondary, and in case of tertiary, the disease is beyond early stage. The disease is beyond early stage. FMGE January 26, the question was, there is a boy who was screened for diabetes and he was found to be positive and the treatment was started. So what is the correct answer here? The answer was secondary prevention. Again, I repeat, they will not ask you direct questions. They will give you a scenario. In our class, we have already discussed. They are not asking nowadays, what is the name of XYZ. They're asking about what is the name of the son of XYZ and the father, something like that. They are not asking you directly. Let's go now. Incidence. What do we mean by incidence? Incidence is number of new cases divided by population at risk. Prevalence is number of new plus old cases divided by total population. Here it is given by cohort study and this is given by cross-sectional study. What is the relationship between incidence and prevalence? The relationship is prevalence is equal to incidence into duration. Prevalence is equal to incidence into duration. Now, longer the duration, more is the prevalence. अब आगे चलते हैं. Let us go ahead now. If there is a good cure available, then the prevalence will decrease. Highly virulent disease, the prevalence will decrease. If there is a treatment which prolongs life but does not cure, this scenario, prevalence will increase. And if there is a good immunization coverage, pre-exposure prophylaxis, the incidence will decrease. Eventually, the prevalence will also decrease. Coming to case report and case series. When we publish rare clinical findings of a single case, it is case report. When we publish rare clinical findings of a group of cases, this is known as case series. Coming to ecological study, this is also known as correlational study. This is the weakest study design. Here unit of study is population and ecological fallacy is a drawback. What is ecological fallacy? Ecological fallacy means, what is ecological fallacy? It is a drawback. What is ecological fallacy? Characters ascribed to a group may not be possessed by an individual. So this is ecological study. Coming to cross-sectional study. This is also known as snapshot study because there is no follow-up. In cross-sectional study, follow-up is not done. It is only based on single examination of cross-section of population. This was your FMGE 26 question. What was the question? The question was, You are calling someone and asking about whether the disease is present or not, and also you are asking about whether the risk factor is present or not. What is the type of study? This type of study is cross-sectional study. This type of study is cross-sectional study, right? This is also known as prevalence study because this study gives us prevalence. It gives distribution of study. There is no information about natural history of disease, and we cannot comment on temporal association. What is temporal association? Yes. What is temporal association? Temporal association means the risk factor came earlier, then came the disease. The risk factor came earlier, then came the disease. This is known as cross-sectional study. This is known as cross-sectional study. Now, coming to case control and cohort. In case control study, we have cases, those who are diseased, we check their exposure status, and we have controls who are healthy people, we check their exposure. In cohort study, we are in present and we follow the exposed people and see whether the disease developed or not. One more time. In case control study, I have a group of person who are sick. They are known as cases. And I have a group of people who are healthy. They are known as control. I take history of exposure. This is case control. In cohort, today I have exposed people and I will follow them for some years and I will look whether they develop disease in future or not. This is known as cohort study. This is known as cohort study. Now, here we are going from effect to cause. Here we are going from cause to effect. The problem here is, suppose I am doing a study where I have a lung cancer patient, and here I am asking them whether they are smoking or not, whether they are smoking or not. They might not remember exact smoking history. This is recall bias. But in case of cohort study, I am following them for 20 years. The person may die, the person may not be the part of group, the person is not interested in talking to us, the person may leave the group. This is known as attrition bias. In other words, attrition bias means loss to follow up. Loss to follow up. In cohort study, more money, more time is given. More money, more time. But the good thing here is it tells us about temporal association. It also tells us about natural history of disease. Okay, so case control study, this is best for rare disease. Cohort study, this is best for rare exposure. Coming to retrospective cohort study. In okay, what is the drawback here? What is the drawback in case control? Recall bias. What is the drawback in cohort? Attrition bias. Let us make a study design where we do not have these two biases. Let us blend a study where we are getting benefit of both of them and the disadvantages are not there. Now, for example, I am taking history of exposure from the records, right? I am taking history of exposure from the records. Now, many records say history of exposure liya. I have taken the people exposure history from the records. Guys, listen. If I have taken the records, written records, you people lived in that hostel for 5 years. I have the written record from your hostel warden. There is no chance of recall bias. Also, I'm not going to follow you up. I'm not going to follow up. That is why I don't have chance of attrition bias. So both the benefit are here in this. Both the benefit are there in this, right? This retrospective cohort is FMGE 25 question. Guys, if you ask me, tell us one topic which is ultra important for your exam, no matter what. This topic questions were there when they used to make easy PSM paper. These type of questions were there when from the past 1-2 paper they are making PSM tough in FMG exam. More of updates, more of the clinical application was seen in the last paper. But one thing was constant, and that was study design. It will always be there. You have to just recognize the disease. You have to recognize the study design. Right? Now, odds ratio AD by BC, this is a cross product ratio. Relative risk, incidence among exposed divided by incidence among non-exposed. And here we have positive association. If relative risk is equal to 1, it means there is no association. If relative risk is less than 1, it means there is a negative association. Now suppose if I say relative risk is 4, that means 4 times risk among exposed group. That means 4 times risk among the exposed group. Now coming to attributable risk. Attributable risk is incidence exposed minus incidence non-exposed divided by incidence exposed, and this tells us about risk difference. Calculations are very important, right? You have to learn it, they are important. Coming to RCT, what is single blinding? When suppose we are doing an experiment and this is our, suppose right, this is your patient, you are doing an experiment, this is the doctor, you, and this is a statistician. He is not aware, the patient is not aware which drug he is getting, single blinding. And you and your patient, you are not aware which drug your patient is getting, double blinding. And you, your patient, and the statistical analysis person, data analyst, is also unaware. This is known as triple blinding. This is known as triple blinding. Now, coming to external validity. So, guys, this is a total population. We choose a small sample from the total population and we do the study. Now, listen. If I can apply the result to the total population, this is known as external validity. What is external validity? The results of study are valid on the total population. What is internal validity? When these two groups are comparable, this is internal validity. Right? This is internal validity. Now, what is quasi-experimental? In quasi-experimental, randomization is not done. In quasi-experimental, randomization is not done. Factorial RCT, this is similar to RCT, but here 2 or more drugs are tested simultaneously. Cluster RCT, what is cluster RCT, guys? Okay, listen, what is cluster RCT? What is cluster RCT? In cluster RCT, we are not randomizing one individual, we are randomizing whole groups. Let us learn the keyword. When I randomize, when I don't do randomization, quasi. When I use 2 or more drugs to test, factorial. When we are not randomizing individual, but we are randomizing a group, this is known as cluster. This is known as cluster. Now, what is confounding? Confounding is mixing of effect. Now, alcohol is causing lung cancer, but reality, alcohol cannot cause lung cancer. It is the smoking which is causing lung cancer. Alcohol is the only third effect. This is confounding. Effect modifier, they both are causing lung cancer. This is effect modifier. Now, there is only one MCQ possible from this side. After study is done, how can you control confounding? The best answer is stratification. Coming to level of evidence, best level is meta-analysis. This is also a FMGE PYQ. This is also FMGE PYQ. Confounding is also a FMGE PYQ. This is also very important, confounding. Now, coming to screen time. From point B to C, it is screen time. From point B to D, it is lead time. Now, coming to lead time bias. Just imagine, guys. Okay, look at here. Look here. Here a lady developed cancer and she was diagnosed in 2015 and she died in 2020. Another case, The lady was screened in 2012 and she died in 2020. This is known as lead time bias. What is lead time bias? Now people think that she lived more. She lived 8 years after diagnosing cancer, but she lived only 5 years. So if we diagnose early, if we do screening, people get more life. This is false. This is known as false perception of prolonged survival because of screening. Now here we have formulas, sensitivity. Okay, एक बात हमेशा याद रखना, always remember one thing. Sensitivity, this is the numerator. Specificity, this is the numerator. Positive predictive value, this is the numerator, and negative predictive value, this is the numerator. The only difference is denominator. In sensitivity, this is the denominator. In positive predictive value, this is the denominator, right? So this is important. You have to learn it. Coming to cutoff value. So the people, this is the cutoff value. People above cutoff value, they have disease, they are true positive. People below cutoff value, they are healthy, they are true negative. Now, who are they? By mistake, they were positive. By mistake, they were negative, right? So this is false negative and this is false positive. If I decrease the cutoff, what will happen? False positive, increase, false negative, decrease. If I increase the cutoff, what will happen? False positive, decrease, and false negative, increase. Coming to ROC curve. What is ROC curve? Receiver operator curve. This curve is used to determine the cutoff. This curve is used to determine cutoff. Point number 2, this is drawn between sensitivity and 1 minus specificity. Here A is the excellent cutoff, because here we have maximum true positive rate and minimum false positive rate. ROC curve, let's revise quickly. This is drawn between sensitivity and 1 minus specificity, and here A is the best cutoff. Why A is the best cutoff? Because here we have maximum true positive rate and minimum false positive rate. Coming to scales of measurement. Guys, these two, nominal and ordinal, are for qualitative data. They are for qualitative data. They are for qualitative data. Now, next is they are for qualitative data. Now, if there is a category, for example, low socioeconomic status, mild disease, all of them, they are ordinal. 90% questions they are asked from ordinal from this topic, right? Then interval, there is no true zero. Ratio, there is true zero present. There was a question in FMGE 24, bilirubin is which type of data? Bilirubin is a continuous type because here we have decimals. The data where we have decimals is known as continuous data. Now, coming to the next one, mean, median, mode. The average of all is mean. Median is the middle value and mode is most frequent or common value. Mode is most frequent or common value. Right. Now, this we know. Age group of, this is the age group given. You have to find the median. For median, we have to arrange them in ascending order. And then we have to take, so now this, there are the even values are there. When the even values are there, we take average of middle two. So this is 4.5. What is the correct answer? 4.5. Right? So mean, median, and mode, ultra important for your exam. Next is, coming to the next one, data distribution. What is normal distribution? This is normal distribution. In normal distribution, mean is equal to median is equal to mode. What is left skew? When we have a negative outlier. So here, this is mode and this is mean. Here, this is mean, this is median, this is mode. In positive skew, this is mode, this is mean. So if you see here, mean is less than, median is less than mode. But here mean is more than, median is more than mode. Right? This is also very important. Coming to sampling, from last 3 years, every NEET PG, every FMG question has one, every FMG NEET PG paper has one question on this sampling method. Simple random, every individual has a chance. Systematic, whenever you find kth unit, every 5th, every 10th, every 15th, right? This is systematic random. In stratified, we divide population into strata and then we select randomly. For example, a researcher was studying some drugs. He divided them based on their origin in 3 groups: plant, animal, mineral. Then he chose from each group. This type of sampling is stratified. Again, this topic is also ultra important. Test of significance. Parametric test. When we compare mean of 2 group, then unpaired t-test. When we compare mean before, after, it is paired t-test. When we compare mean of more than 2 group, it is ANOVA. Now, when we compare proportion of 2 or more group, it is chi-square. When we compare proportion of same group before, after, it is McNemar. Now, let us practice the question. A researcher was studying effect on veg and non-veg diet on serum cholesterol. So, what they are measuring? Mean. How many groups are there? Veg and non-veg. So, mean of 2 groups. What is the correct answer here? Unpaired t-test. Right? Guys, this table is ultra important. I don't know. You will remember it, you will learn it, you will understand it, or you will mug it up. But I don't want you to make any mistake here. Right? This is ultra important. These 2 topics are ultra important. Sampling method, test of significance, NEET PG, FMG, they have one question definitely. Coming to WHO steps approach, this is step number 1, questionnaire, diet, habit, family history, then height, weight, blood pressure, BMI, and next step is lipid, HbA1c, blood sugar. You check past NEET PG, FMG papers. WHO steps approach is very, very, very important. Then comes tracking of blood pressure. If we track blood pressure from childhood to adulthood, if anyone is having low blood pressure in childhood, will have low blood pressure in adulthood. This is tracking of blood pressure. Then rule of half. Rule of half means total population, 50% is having hypertension, 50% of them they are diagnosed, 50% of them they are taking treatment, and 50% are able to control. Most common cancer in males, lip, oral cavity as per Globocan. Female and overall it is breast cancer. And if nothing is mentioned, you have to mark Globocan. Now comes 90, 70, 90. This is for cervical cancer. 90% should be vaccinated. 90% should be vaccinated. 70% should be screened. And 90% they get treatment. They should get the treatment. Now, coming to food adulterants, this table is very, very important. Lathyrism. The toxin here is BOA, and there is a kesari dal. This dal contains a toxin which is known as BOA. How do we prevent it? By banning the crop, by vitamin C prophylaxis, removal of toxin, and genetic modifications. So in exam, they will give you a history, a poor farmer. These are the keywords you will get in your exam. Consuming pulses, and most likely they will mention Madhya Pradesh. Right? Most likely they will mention Madhya Pradesh. Epidemic dropsy. Here in epidemic dropsy, they will mention you someone buying groceries from the local shop, especially the mustard oil. Right? So epidemic dropsy happens when we contaminate mustard oil with Argemone mexicana oil. Then they ask you most sensitive test. Most sensitive is paper chromatography. Most sensitive is paper chromatography. Next is endemic ascites. Toxin is pyrrolizidin. Ergotism, it is a fungal infection of the crops. So here the toxin is ergot fungus, and Claviceps purpura is the name of the fungus. Here, how do we prevent it? We soak. Okay, guys, listen. The bajra crop, it gets infested because of fungus. And now, to prevent people eating from the fungal bajra, we do 20%, we soak it in 20% salt solution. What happens? The good bajra separates from the fungal bajra. Right? This is a FMG 2022 question. This is a very important question. This already has been asked in your exam. Next is aflatoxicosis. Hepatocellular carcinoma. Name a food toxin which is associated with hepatocellular carcinoma. It is aflatoxicosis. It is aflatoxicosis. Now, vitamin A deficiency causes night blindness, white hot spot. Under National Immunization Schedule, we are giving 1 ml. Then vitamin B1, we have the disease beriberi because of vitamin B1 deficiency. But in alcoholics, it is wernicke's encephalopathy, and we discussed mnemonic Goa. Global confusion of thalmoplegia and ataxia. Vitamin B3, pellagra. Vitamin B3 causes pellagra. There are 4 Ds: diarrhea, dermatitis, dementia, and death. Bilaterally, sun-exposed Cazals necklace. Then we have vitamin D, rickets, vitamin C, scurvy, and scurvy. Then we have iron. If I talk about minerals, iron, most sensitive indicator iron deficiency, serum ferritin. Most sensitive indicator for iodine, prevalence of neonatal hypothyroidism. If I talk about fluorine, it is a double-edged sword. The deficiency causes caries, and the excess causes fluorosis. Then we have Nalgonda technique for prevention of fluorosis, and it is the mnemonic for Nalgonda technique is lab, lime, alum, and bleaching powder. For zinc, the mnemonic is DAD. Diarrhea, alopecia, and dermatitis. I'm not saying this mnemonic because today is Father's Day, but this is the mnemonic we have already discussed. DAD, diarrhea, alopecia, dermatitis. Now, very, very important demographic cycle. Very, very, very important demographic cycle. Can anyone tell me the level of crippling fluorosis? Okay, fluorine levels. Let us talk about fluorine level. Less than 0.5, it causes caries. More than 1.5, it causes fluorosis. And more than 10, it causes crippling fluorosis. And this is your FMG PYQ. Now, guys, there are 3 cycles in your exam. Ultra important: demographic cycle, family cycle. These 2 cycles are very, very, very important. Stage 1, both high. Stage 2, death rate decreases. Stage 3, both decreases. Stage 4, both low. Stage 5, birth rate decreases more than death rate. Now, birth rate high, death rate high, but the gap is narrow, so population is stable. Birth rate high, death rate starts decreasing, demographic gap expand, population increases. Right? Population increases. Quickly, stage where the population will decrease. So it is stage 5. Stage where the population remains stable, stage 1 and stage 4. Where the population will increase, stage 2 and stage 3. Now, coming to crude birth rate, total live birth per 1000 population. General fertility rate, total live birth per 1000 women in reproductive age. Total fertility rate, average number of children born to a woman in her lifetime. Gross reproduction rate, average number of girls born to a woman in her lifetime. See, total fertility rate, total children, boy, girl, any children. Gross reproduction rate, only girls born to a woman in her life. And net reproduction rate is number of girls born to a newborn girl. Number of girls born to a newborn girl. Then comes demographic processes. There are 5 demographic processes: fertility, mortality, migration, marriage, and social mobility. What is sex ratio? Number of females per 1000 males. What is the current sex ratio? It is 1020. Dependency ratio, people less than 15 year plus people more than 65 year divided by 15 to 65 year. This is dependency ratio. Now, can you answer this question? If old people die, then dependency ratio will. If old people, so that means this part will be gone. If old people will die, what will happen to the dependency ratio? Decrease. Dependency ratio will decrease. Coming to the contraceptives, Antara, it is a DAMPA. What is DAMPA? Depot medroxy progesterone acetate. What is the dose? 150 mg intramuscular. 150 mg intramuscular. Chaya or meloxifene, dose 30 mg twice a week. So we ask the women to take it on Monday and Wednesday. 30 mg tablet on Monday, 30 mg tablet on Wednesday for 3 months. After 3 months, remove the Wednesday dose and only take the Monday dose. So that is how we say 30 mg twice a week for first 3 months, and after 30 mg once a week after 3 months. Then comes OCP, oral contraceptive pills. Ethinyl estradiol 0.03 mg, levonorgestrel 0.15. Dr. Prince, Chaya, yes, Chaya is the new name. Saheli was the old name. Dr. Prince, new name is Chaya, Saheli is the old name, right? Is that fine, Dr. Prince? Maternal mortality rate, maternal mortality ratio. Guys, before last 2 FMG exam, there was no FMG paper without this topic. I used to teach in my class and I used to tell students that every line was once in your exam. One line was in FMG 24, FMG 23, FMG 22, FMG 21, back to back. This topic is still very important. Maternal mortality rate. What is the denominator? Women in reproductive age. Maternal mortality ratio. What is the denominator? Live birth. What is a maternal death? Death of any women during pregnancy, during childbirth, or after childbirth up to how many days? 42 days. Irrespective of duration or site. Irrespective of duration or site. Now, this is the question which they ask in FMG 24. So you have to calculate it, and 2 deaths from electrocution, it is not counted. Right? So how many deaths occurred? 2 plus 2 plus 2 plus 4. How many deaths? 10. What is the live birth? 4,000. What is the multiplier? 1 lakh. When you do, it comes out to be 250. Now, the same is for the child deaths. Right? Now, you have to learn these formulas. Perinatal mortality, neonatal mortality, they are very important. So, we have a SDG target for them. If you remember my class mnemonic, 70, 12, 25, 70, 12, 25. Let us decrease MMR by 70, neonatal mortality rate by 12, and under 5 mortality rate by 25. Now, from this very slide, one question, only MMR likha ho to ratio lena hai. Yes, Dr. Prince, if MMR is mentioned, we have to take a ratio. Now coming to MCH. Right. Minimum ANC visits according to Government of India 4, according to WHO 8, ideal 13 to 14. We have to give 2 doses to the pregnant women 1 month apart. If previous pregnancy within 3 years, then only one booster. IFA tablet 180 days before and 180 days after. What is the dose? 60 mg elemental iron and 500 microgram folic acid. To measure mid upper arm circumference, we use Shakir's tape. Less than 11.5 is SAM. What is SAM? Severe acute malnutrition. Then we go to growth of the baby. Weight for age, acute on chronic. Height for age, chronic. Weight for height, acute malnutrition. Then healthful school environment, we have again mnemonic 10, 25, 40, 60, 100. What is the mnemonic? 10, 25, 40, 60, 100. The desk should be minus type and the light should come from left. Because mainly students are righty, so the light should come from left. After that, the health programs. In Janani Suraksha Yojana, we have given cash incentive. In Pradhan Mantri Matru Vandana Yojana, we also give cash incentive, but this is under Ministry of Women and Child Development. JSSK, we give free transport, free diagnosis, free delivery, free drugs. NSSK, we do the training of healthcare workers for newborn care. Now, if it is the first baby, any gender, boy or girl, we give 5,000 in 2 installments. If it is a second baby and if it is a boy, we do not give anything. And if it is a girl child, then we give 6,000 in single installment. If you are a student who has never touched PSM, guys, please listen to me very carefully. I'm telling you the PSM strategy right now. If you have read PSM 2-3 times, if you have attended your class, your main class, if you have all the notes, you belong to any, you are doing it for the first time or past, previously you have given, you belong to any student. You have to read those notes. They are still the gold mine for you, but yes, quickly. If you have not read the main notes and if you have read the defects 2-3 times, stick to defects. And if you have not read the main notes, if you have not read defects, then this 1 hour session will definitely give you maximum questions, right? So I recommend you, if you have never touched PSM and you are going to attempt exam on 28th June, do read by heart 2, 3, 5 times, learn today's PDF, and it will give you a confidence in your exam, right? Now, okay, one student is asking, what about twins? So no matter. So if suppose second child is a twin, both boy, no amount. One boy, one girl, 6,000. Both girls, again 6,000. It is not like that 2 girls are there, twins are there, and both are girls, then the amount will be 12,000. That is wrong. It will be still 6,000. Then Suman, assured, dignified, respectful care. Lakshya, improve labor room quality. PMSMA, free antenatal care to all the women on 19th of every month. Next is HBPNC, home-based postnatal care, home visits by Asha, home delivery, 7 visits. And if it is a normal vaginal delivery at the hospital, 6 visits. If it is LSCS, 5 visits. Then comes HBYCC, home-based young child care, home visits by Asha, 5 visits, 3, 6, 9, 12 and 15 month. RBSK, Rashtriya Bal Swasthya Karyakram, in this program, we do the screening of 4 Ds. 0 to 8 year, what are 4 Ds? Disease, deficiency, birth defect, developmental delay. Then comes RKSK. This program is for adolescents. And in this program, we mainly focus on mental health, sexual and reproductive health, life skill. Then comes ICDS. This is under Ministry of Women and Child Development. Beneficiary, 0 to 6 year, pregnant and lactating women. We give free supplementary nutrition here, non-formal preschool education, growth monitoring, immunization, health checkup. Now come to school health under Ayushman Bharat. We have school health and wellness ambassador. And if you have attended my class, do write in the chat box what do I mean by health and wellness ambassador. And please do comment in the chat box if you have attended my class, who is the health and wellness ambassador, and was he in your school as well, and was he and she, they were in your school as well. We also do screening, and the services we give: tetanus, albendazole, weekly IFA, and sanitary napkin. Then Anemia Mukt Bharat 6x6x6 strategy. Then National Deworming Day, we give biannual albendazole. Mission Indradhanush, this is for 12 vaccines. This is for 12 vaccines. Abhiyan Indradhanush, changing bedsheet according to the Vibgyor. Changing bedsheet according to the Vibgyor. Then we have Ujala. Ujala is for LED bulbs. Ujwala, LPG cylinder, and Ujawala, child trafficking. Guys, also I want to tell you, these doses are very, very important. Do learn them, right? Nikshay for TB, Nikusht for leprosy, and then we have Talimanas. This is for psychiatric support. We have M diabetes for diabetes, M cessation to quit tobacco. Anmol is an app for ANM to register and track maternal and child services. Mukul, science wali madam, बहुत याद है मेरे भाई तुझे, है Mukul? Good. Okay. Kata thermometer measures cooling power of air. Sling psychrometer, it measures relative humidity. भाई ये दो questions भयंकर important है, दो बार आ चुका है. This is very important. Sling psychrometer and Kata thermometer. Anemometer for wind velocity. Globe thermometer, it measures radiant heat. Biomedical waste, everything which cannot be recycled, human anatomical waste, soil waste, expired medicine, right? They all go in yellow bag. Red is contaminated recyclable waste. The mnemonic is TRP. Tubings, rubber, and plastic. Everything goes in red except blood bag. Except blood bag. Urine bag. Every bag goes there. Then needles, scalpel, syringes, they go in this box. This is white box, translucent box, and this box is puncture proof. Then we have blue, broken glass, ampoules. This is glassware and metallic body implants. Then one cycle I told you which is very important for you, demographic cycle. Next cycle is disaster cycle. Very, very, very important. First, after disaster, we have response, then rehabilitation, then reconstruction, and mitigation and preparedness. So in disaster cycle, what is there? First, we have response, then rehabilitation, then reconstruction. After disaster, there is a response. We reach there. Yes, Prince, syringe goes in red. Syringe goes in red. Fixed needle syringe. Fixed needle syringe. It goes in white. Fixed needle. I have written here. Syringes with fixed needle. Then this is disaster cycle is very, very, very important, right? Triage is very, very important. So if a person who is wounded but can walk, it is green. If a person who needs immediate surgery is a red category. If a person is dead, it is black. It is black. Coming to this family cycle, if I talk about family cycle, family starts when you get married. Marriage to first child, formation. First to last child, extension. Last child, when the first child leaves home, complete extension. Then contraction, and when the both spouse, then when both the partners they die, the family dissolution. Three cycles are ultra important for your exam: demographic cycle, disaster cycle, family cycle. Then immunization schedule, you know the mnemonic: Bob, Porep, Por, Porep. MJVIP, MJDO, and at 5 years we give DPT, and then 10 years, 15 years TD, and pregnancy TD. Coming to vaccine vial monitor, when the inner square is light, then the circle we can use it. If it is same or darker, we do not use it. This is vaccine vial monitor. It tells us about the heat exposure to the vaccine, the heat damage on the vaccine. Open vial policy, the open vial policy. When the vaccine vial is opened, it can be used up to 28 days. This is open vial policy. It is not applicable on 3 vaccines, BCG, MR, and COVID, JE live also. But all of these vaccines, it is applicable. Then comes shake test. This is for freeze damaged vaccines. Now, coming to chickenpox, measles, and rubella. Guys, the very, very important point here for your exam is Koplik spot. I don't know why they love this topic. You see, every FMG exam, we have this question, Koplik spot. And also rubella. Congenital rubella triad is cataract, sensorineural hearing loss, heart defects. Which heart defect? PDA, patent ductus arteriosus. If I talk about diphtheria, here, how to manage the case of diphtheria? We give antitoxin and antibiotics. For the contact of diphtheria, antibiotics for every contact, right? So this is the pseudomembrane. This is the pseudomembrane. This is seen in diphtheria. Name a vaccine where the strain is changed every year. It is influenza vaccine. Every year we change the strain. Now coming to HIV, when to start ART? As soon as possible. What is the preferred regime? TLD. For pregnant as well, it is TLD. And TB and HIV, we start ATT first. Then post-exposure prophylaxis, we start TLD ASAP for 28 days. Now coming to ARV prophylaxis. If the mother is HIV positive, then we give the baby ARV prophylaxis. And if the mother is low risk mother is viral load is less than 1000, we give nevirapine. High risk mother, where the viral load is more than 1000, we give nevirapine plus cotrimoxazole. Now we start cotrimoxazole from 6 weeks and all vaccines to be given. So there is one question from Dr. Anushri. Dr. Anushri, the difference between these two is, please understand Dr. Anushri, TD means tetanus and diphtheria. TT means only tetanus. Nowadays, this is given and this is not given to pregnant women. Right? Now, diseases under National Vector-Borne Disease Control Program, malaria, dengue, chikungunya, and out of them, Kala Azar is by sandfly, rest all 5 are by mosquito. Then we have treatment for Vivax, chloroquine, and primaquine. For falciparum in Northeast, we give ACT-AL, and in other than Northeast, we give ACT-SP. Then we have these malaria indicators. Out of them, which is the index of operational efficacy, this is FMGPYQ, that is ABER, annual blood examination rate. For chemoprophylaxis short term, we have doxy. For long term, we have meflo. Then, if I talk about filariasis, what is the drug of choice? DEC. What is the MDA given? MDA means mass drug administration. And MDA is ivermectin, DEC, and albendazole. And what is a DEC provocation test? In DEC provocation test, we give one single 100 mg dose of DEC, and within 15-minute microfilaria are there. Name one test for Kala Azar, RK plus 39. And what is the drug of choice? LAMB. What is LAMB? Liposomal amphotericin B. What is category 1 animal bite? Only lick on intact skin. Here we do only wound washing. What is category 2? Abrasions are there. We give vaccine also. What is category 3? Lick on broken skin, lick on mucosa, or any bite where the blood is oozing out. Here we give vaccine plus immunoglobulin. Pre-exposure prophylaxis, three doses are given, 0, 7, and another is a booster. Re-exposure, we give 2 doses, 0 and 3. Only 2 doses are given. Now, post-exposure prophylaxis, we give vaccine either intradermal or intramuscular. If intradermal, 4 days, and if intramuscular, 5 days. Immunoglobulins are given to all category 3, and if immunocompromised, category 2. What is the dose? Human 20 international unit, equine 40 international unit per kg. How do we administer it? See, this is a small wound. This is a small wound. We give the dose immunoglobulin here in the wound, and if rest of the dose is given intramuscularly, rest of the dose is given intramuscularly. This is a large wound. We can give maximum dose over here. We can give maximum dose over here. Very, very important, rabies management. With this, thank you so much, guys. Thank you so much. This 1 hour marathon non-stop, we are learning here in this marathon session with all my heart, and with on the behalf of whole team DAMS. I wish you all very, very, very good luck for your exam, and my best wishes are there, my blessings are there, right? Keep studying, keep studying. So 1 hour session, I have finished it within 1 hour, exactly at 1 hour, right? With this, thank you so much. I wish you all a very good luck from my end. God bless you all, right? Now it is time for the next session. Without wasting, let us welcome Dr. Sachin Arora. Next session for FMG Marathon is subject psychiatry. Bye-bye. Take care. God bless you.
Convert your audio.
My hello and good evening to all of you. I hope you can hear me loud and clear. Just confirm whether my voice is audible, visible to all of you. Am I audible? How are you? The people who are listening to me on YouTube Live, how are you? I've been listening to FMG Marathon since a long time. I just saw in the YouTube chat you people enjoying Dr. Kash's sessions. Is my voice okay? Shall we begin? Shall we begin? Okay, so my session is not as bulky as PSM, but yes, worthy of MCQs. My weightage is not as much as the bigger subjects, but yes, anxiety is picking up. Expected. Anxiety is an expected phenomenon at this stage. If you will not have anxiety now, when else will you have it? All right, good to go. Subjects. Shall we begin? Good to go? Okay, so today's session is clinical differential diagnosis in psychiatry, an MCQ based approach where we shall be discussing how to solve a clinical question in psychiatry. How to solve a clinical question in psychiatry. So, clinical questions in psychiatry will be a history will be given and you're supposed to mark a diagnosis. Before we actually mark a diagnosis, you are supposed to know that first of all, psychiatric disorder can be organic and can be functional. Can anyone in the chat tell me how will you figure out whether the question it is organic or functional? This has been asked in FMG also and in NEET PG also. What is the difference between organic and functional? If a specific cause is given, like infection, head injury, any reason of a symptom is given, then we call it as organic. Like if there's a specific reason given in the clinical question, all what we are discussing today is only for the purpose of solving a clinical MCQ in psychiatry. So if there's a specific cause given, we call it organic. And if there's no cause given, we call it as a functional. Okay. Second point of differentiating between organic and functional. Anybody knows which hallucination in organic and which hallucination in functional? Come on. Which hallucination in organic and which hallucination in functional? Yes. Visual hallucination organic, auditory hallucination functional. Yes, visual hallucination organic and auditory hallucination functional. Organic, we have delirium, we have dementia, we have amnestic syndrome. Delirium is altered sensorium, dementia and amnestic syndrome are clear sensorium. Which of these three is disoriented? Delirium, dementia, or amnestic syndrome? Which of these three is disoriented? Come on. Disorientation to time, place, person is a feature of delirium, dementia, or amnestic syndrome. Come on. It is a feature of delirium, dementia, or amnestic syndrome. Delirium, correct. Correct. Dementia and amnestic syndrome. Dementia is memory loss plus many things, and amnestic syndrome is only memory loss. I'm just telling gross points so that you can keep them in mind while solving a question. So, when will you mark organic? When the cause is given. Old age organic is more common. When the visual hallucinations are given. Functional. Functional again are of two types. One is a primary psychiatric illness and one is a personality. I'll keep personality separate as the primary psychiatric illness. Primary psychiatric illness, mania, schizophrenia, depression, OCD, anxiety, all this come under primary psychiatric illness. Personality disorder are separate diagnosis, access to diagnosis in DSM-4. Personality disorder may or may not coexist with an existing psychiatric primary disorder. So you may have OCD with OCPD, obsessive compulsive disorder with obsessive compulsive personality disorder. You may have dependent personality disorder with depressive symptom. So personality is a different and primary psychiatric illness is a different. Is the first slide clear to all of you? Is the first slide clear to all of you? Yes. Now, what is the difference between organic and functional? Already asked in psychiatry, FMG exam. Organic means is due to disease in the brain. Functional means no such basis. Organic is more common in old age. Functional is more common in young age. Consciousness is impaired in organic and preserved in functional. Predominant visual hallucination. This is an important point. Visual hallucination, organic, and auditory hallucination, functional. If there's a focal neurological deficit present, it is more likely to be organic. Are we all clear with this slide? Are we all clear with this slide? So I mentioned you delirium versus dementia. Delirium is altered sensorium. Dementia is clear sensorium. Delirium is disoriented to time, place, person, and dementia is oriented to time, place, person. Remote memory is normal in delirium and impaired in dementia. Remote memory is normal in delirium and impaired in dementia. Delirium is acute and fluctuating. Dementia is chronic and progressive. Are all of you aware about this slide? Today, I have collected only 14 slides to be delivered to you in approximately 40 minutes, approximately 40 to 50 minutes, so that you can have an idea about how to mark a clinical differential diagnosis. In a psychiatric MCQ exam, there are two choices that always coexist. If you have an question on organic, if one option is delirium, other has to be dementia. If one option is dementia, other has to be amnestic syndrome. Are we clear? Are we clear that we are here to learn how to differentiate options from each other? We are here to learn how to differentiate options from each other. Are we clear? So first thing first, organic, functional, organic, delirium, dementia, amnesia, functional, primary psychiatry, personality. Are we clear with this slide? Are we clear with this slide? Are we clear with this? Organic versus functional. I want something from today's exam teaching to come in the upcoming FMG and NEET exam. I have messaged on my groups that today's session is also important for NEET. So I expect some students here who are attending this session for NEET also. But it is a common thing. Okay, which is best to differentiate delirium from dementia? Come on, come on. I have taught this in DFX, I've taught this in main class. Which is best to differentiate delirium from dementia? Best to differentiate delirium from dementia. Best to differentiate. Come on, if you cannot type everything, just type in the chat. It's a YouTube live session going on. 1, 2, 3, or 4. Out of the 4 choices, 1, 2, 3, or 4. 1. That's the hallmark feature of delirium. Technically, 1 and 2 are very similar. Disoriented to time place person is similar to altered sensorium. Very similar, not same. Disorientation is a hallmark feature of delirium. Hallmark feature. NEET PG, they asked which is best to differentiate delirium from dementia, and they did not give sensorium in the option. What is the second best? Second best. 1, 2, 3, or 4. Okay, I remove 1 and 2. I just ask you between 3 and 4. Come on. People who are attending it live, come on, please answer. Delirium versus dementia, best to differentiate altered sensorium. Second best. NEET PG 2018, second best. Fluctuating in delirium. Dementia is chronic and progressive. If we talk about personality disorder, there are 3 clusters: cluster A, cluster B, cluster C. A means odd and eccentric, different. B means dramatic and emotional, borderline histrionic, antisocial, narcissistic. C means anxious and fearful. Come on, are you enjoying the session? People who are attending live, are you able to enjoy the session? Are you able to understand something? Are you able to grasp something? If I go fast, let me know. If I go slow, let me know. It's a live class going on. And if you're satisfied, give the thumbs up. Give a thumbs up, say okay, say yes, whatever you feel like, so that I get the positive boost that I am teaching and you are liking it. Okay, heart is good. Heart is good. YouTube live, we have hearts. Thank you for the hearts. Cluster A, cluster B, cluster C. A means odd and eccentric. B means dramatic and emotional. C means anxious and fearful. Do you know each personality has one key trait? A schizoid means emotional, cold, does not interact in his own world. Schizotypal means magical thinking, odd beliefs. My words have power. Paranoid means generalized mistrust. No one is trustworthy. Everyone is a cheat. Everyone is a liar. I don't want to discuss anything with anyone. What if they take advantage of me? Have you ever felt like this in the last 7 days of the exam? Did you notice yourself getting more paranoid in the last 7 days of the exam? Hey, don't eat that food. What if somebody has mixed something in that food? Hey, don't eat outside food. What if I get sick? One of my friend is taking me to eat outside food because he wants me to get sick. Come on, yaar. Come on. He does not want you to fail. He wants himself to pass. If you talk about FMG exam now, the one thing I like about FMG exam is students are not competing with each other. They don't want them to pass and other to fail. They want both of them to pass. But if you talk about NEET PG exam, people become more competitive. They want them to score better rank than others. Have you noticed this? F for FMG, F for good friends. N for NEET, I will not elaborate. Okay, this was just to lighten the moment. Don't take it seriously. But I've seen that people do wish that I pass, he pass, both friend pass. Antisocial, love to break the rules. They say rules are for the fools. Legal, criminal. In NEET PG, they asked a boy does not attend classes, bunk school, does not go to and involved in police matter, and the age of the boy was given 30 years. You tell me who attends classes at 30 years of age? Are they making MCQ on our student only? Maybe, maybe, whatever. Histrionic means attention seeking. Okay, I love to be the center of attraction. Everyone should look at me only. I'm the only beautiful woman. Narcissistic means self-love. I said so I said. मेरा वचन है शासन. Shivagami. You know, once I made a commitment, after that I don't listen to anyone. See, you laugh in FMG marathon also in psychiatry. Imagine, even a marathon class can make you smile a little. This is my, last teaching to FMG students. Regular batch, DFX, marathon. Borderline, emotionally dysregulation, can't manage their emotions, can't manage their relation. Suicide attempt is very common. Avoidant are the people who avoid socially demanding situations. They are shy and introvert, they never come in front. Dependent are the people who lack assertiveness skills, decision making skill. I can't make my point with confidence. I do what the others tell me to do. Have you seen one student who is still asking people, you tell me now what should I read in the last few days? Do you have a friend who still does not know what he's supposed to do in the last few days? Come on, tell me. Do you know a friend who is still asking other people, hey sir, tell me now what to study in the last 7 days? Can't take their own decisions. Anarchistic. OCPD, preoccupied with rules, regulation, perfection, symmetry, and orderliness and cleanliness. 9 a.m. means 9 a.m., 11 a.m., 11 a.m. is 11 a.m. Very particular. Okay. Personality disorder was just to lighten the mood. Let's come to the primary psychiatric illness. In primary psychiatric illness, technically we have divided into psychosis and neurosis. Psychosis and neurosis. Now somebody asked me, sir, where is mood disorder? Mood disorder is neither a neurosis nor a psychosis. It is an emotional disorder. It's an affective disorder. Bipolar, affective disorder. Bipolar, mood disorder. Mania and depression. Mania, depression, bipolar come under mood disorder. Now depression can be psychosis when it is severe, can be neurosis when it is mild. So depression can be with psychosis, depression can be without psychosis. So please understand, one is psychosis, one is neurosis, and one is mood disorder. Mood disorder lies in between. It has nothing to do with psychosis or neurosis. It's an independent entity. What is the difference between psychosis and neurosis? Psychosis means inside absent, neurosis means inside present. Those who come are called neurosis. Those who are brought are called psychosis. But the more important thing is, delusion hallucination present means psychosis, delusion hallucination absent means neurosis. Do you understand this? Delusion hallucination present means psychosis, delusion hallucination absent means neurosis. Are you aware about this? Whenever in a clinical question you see delusion hallucination are given, then it is psychosis, and not given, then it is neurosis. Now, psychosis is of two types: schizophrenia like illness, that is brief psychosis, acute psychosis, schizophreniform disorder, and schizophrenia. Less than 1 month, acute psychosis, brief psychosis. 1 month to 6 months, schizophreniform disorder, and more than 6 months, schizophrenia. As per DSM, more than 6 months is schizophrenia. As per ICD, more than 1 month is schizophrenia. Were you aware about this? What is the difference between schizophrenia and delusional disorder? If delusion plus hallucination plus socio-occupational impairment is present, then it is schizophrenia. If only delusion, then it is delusional disorder. Only delusion, then it is delusional disorder. If only delusion, then it is delusional disorder. Let's discuss them one by one. Schizophrenia, delusion, hallucination, disorganized speech, disorganized behavior, and negative symptom. Delusional disorder means only delusion. Everything else is okay. And socio-occupational impairment is less. Socio means society function, occupation means job. When the society function and job are more affected, we call it schizophrenia. Less affected, we call it delusional disorder. Delusional disorder. Mood disorder. Mood disorder can be mania, can be depression, can be bipolar. Khushi, gum, kabhi khushi, kabhi gum. Mania can be euphoric mania, happy mania, dysphoric mania, irritable mania. This question was asked in FMGE. What is a key symptom of depression? Low mood. Low mood, low energy, low interest. EMI. Low energy, low mood, low interest are the three cardinal or core symptom of depression. Also asked in INICET. EMI. Low energy, low mood, low interest. Key symptom is low mood, and most common symptom is low energy. Most common symptom is low energy. Do you think these slides are useful? I have made these slides for the last minute revision. Do you want to have this PDF? Do you want to have this PDF with you for the last minute revision? Yes. Do you know that I have a Google Drive where I have shared this PDF? I mean, PDF of FMG PYQs. You might be knowing I have a WhatsApp group also for FMG. I have WhatsApp group for NEET also. So I'll share it there and you can see it from there. I think these slides are important for the last minute revision. You can do these slides in 15 minutes. 15 slides, 15 minutes. That's all. And whatever video I'm speaking these points you can watch again in this video by playing it in 2x or 3x or whatever way, or you can tell AI to interpret the notes whatever way you wish. Like, euphoric mania, dysphoric mania. Anxiety disorder are of three types: GAD, panic, and phobia. Phobia is of agora social specific. This is neurosis we are talking about. GAD means continuous free floating anxiety. Panic means sudden anxiety, feeling of impending doom. And phobia means morbid and irrational fear with acute anxiety and panic like symptoms. If it is a continuous anxiety, we call it GAD. If it is acute anxiety with a feeling of impending doom, we call it panic. And if it is acute anxiety with a stimulus, we call it phobia. Phobia has to have a phobic stimulus. Were you aware about this? Were you aware about these three disorders? I am only telling you key feature. This today's lecture, today's presentation is not for clinical diagnosis in OPD. It is only to mark MCQ answers. This is not the way I diagnose people in my OPD. Hey, free floating anxiety, GAD. Hey, feeling of impending doom, panic. Psychiatry clinical practice is not one line or one word disorders. Clinical practice has a lot of other parameters. So if anyone who is watching this video and planning to, start psychiatry OPD tomorrow and diagnose yourself, your friends, family, that this is not the intent of this video. This video is just for the purpose of MCQ solving, not for the patient diagnosis and treating. Panic, no stimulus, phobia, stimulus. If you get exam panic, it is not a disorder. It is a normal situational thing. Many students panic before exam. OCD and related disorder. It includes OCD, obsessive compulsive disorder. Obsessions are thoughts that are repetitive, distressing thought that comes again and again, produce anxiety. And compulsion is a motor action that you do to counter that thought. Obsession is a thought, compulsion is an act. Most common obsession, dirt contamination, but most common compulsion, not washing, it is checking. Most common compulsion, it is not washing, it is checking. Most common obsession is dirt contamination, but most common compulsion is checking. Body dysmorphic disorder. In this, the person feel a part of my body is disfigured. Hair, nose, skin. My nose is ugly, pugly, fugly. I don't like my nose. I don't like my hairs. I don't like my skin. And thanks to the awareness spread by media, Bollywood, etc., they also know that the doctor who is supposed to change the nose is known as a plastic surgeon. So they first go to the plastic surgeon who later on refers them to a psychiatrist. This is the case of body dysmorphic disorder. Do you remember that body dysmorphic disorder? Do you know any of your friend who is very bothered about his or her appearance? Come on, comment yes. कमेंट यस जस्ट टू लाइटन द मूड वंस अगेन. आपका कोई ऐसा दोस्त है जो आईने में बार बार अपना चेहरा देखता है? डू यू हैव अ फ्रेंड हु चेक्स हिज फेस इन फ्रंट ऑफ द मिरर टू चेक आउट अ न्यू एक्ने, न्यू पिंपल, अ डार्कनेस ऑन माय स्किन, white head, black head, purple head, magenta head, acne, pimple, pustule, papule? I don't know what else they call it. Do you have a friend who is very bothered about it? Is not at all related to gender. Previously, female had this. I nowadays more and more boys, body dysmorphic. I got a boy who had beard dysmorphophobia. Beard. My beard is not in this shape. I said you should not go to psychiatrist. You should not go to plastic surgeon. Go to a good barber. He came to me, sir, my beard is not in shape. I said, what else? No problem, sir. Just make my beard shape normal. I said, do you want me to shave it? Body dysmorphic disorder. Other, hoarding disorder. Hoarding. Hoarding means collecting. इकट्ठा करना, जमा, collecting. Like you people collect. Studying from other places, doing marathon at DAMS. Good for you. Keep on collecting information. Trichotillomania, hair pulling disorder, excoriation, skin picking disorder. I can see from the comments that you're enjoying, and that's what I wanted today. Good. Keep it up. I think this session has made you more lively. I'm happy. PTSD, what a favorite topic of your examiners. In FMG, they ask acute stress. In NEET PG, they ask PTSD. Next year in NEET PG, also they ask acute stress. Acute stress PTSD happens after a major trauma or a minor trauma. Major trauma. PTSD is more than 1 month. Acute stress is less than 1 month. Symptom triad is HIA. Hyperarousal, intrusiveness, avoidance. Hyperarousal, intrusiveness, avoidance. Hyperarousal means startle. Hyperarousal. Major trauma, intrusiveness. Trauma comes in front of the eyes again. Avoidance. Not going to that place, not talking about that place. Acute stress, less than 1 month. PTSD, more than 1 month. Will you remember this? Acute stress, less than 1 month. PTSD, more than 1 month. Will you remember this? Mild to moderate depressive symptom after a stressful life event is called adjustment disorder. Whenever there'll be a question on adjustment disorder after stress, the other option is going to be depression. If there are severe symptoms, we call it depression. If there are mild moderate symptoms, we call it adjustment disorder. Mild to moderate depressive symptom after stress, adjustment disorder. Severe symptom after stress, depression. What are we discussing? We are discussing neurosis. We are discussing anxiety. We have discussed OCD. We have discussed trauma. We have discussed schizophrenia versus delusional. We have discussed mood disorder. One slide, one topic. And we have discussed anxiety, OCD, and trauma. Now we are into the last three slides: somatic symptoms and related disorder, somatization disorder, multiple pain, multiple symptoms, pain, GI symptom, sexual paining, burning, GI, multiple symptoms, somatization, only pain, somatoform pain, and presents with a diagnosis, hypochondriasis. Can you differentiate these three? Multiple symptoms, somatization, only pain, somatoform pain, presents with a preset diagnosis. Today's session has 20 to 30 most important psychiatric diagnoses, starting from personality disorders, 10, going to schizophrenia, delusional disorder, 12, going to delirium dementia, 14, going to anxiety disorder, 17, mood disorder, 20, OCD and related disorder, 25, somatic symptom and related disorder, 28, trauma and stress related disorder, 31, dissociative, 35, and conversion, 36. Today idea was to give you one line about each of the 36 disorders in psychiatry, one line each. If I ask you any disorder in psychiatry out of these 36, you should be able to say one line. What will you say about that particular disorder? That will decide whether you can solve a clinical question on this or not. If I can teach you 36 disorder in 30 minutes, why can't you read it? You are just scared, but you can still do it. Within half an hour, we will do 36 disorder, out of which these three we have just discussed: multiple symptom somatization, only pain, somatoform pain, and presents with a diagnosis, hypochondriasis. Conversion disorder, also known as hysteria, a very, very famous psychiatric disorder asked in the recent FMG exam after a stress, loss of voice, aphonia, loss of vision, blindness, pseudo seizure, pseudo paralysis, loss of vision, loss of voice, pseudo seizure, pseudo paralysis. La belle indifference, lack of emotional reactivity to the suffering. Lack of emotional reactivity to the suffering. The patient has a symptom, but the face fails to show the distress. Lack of concern about the symptom. Suppose you come with abdominal pain, you will come like this. Sir, I have pain in abdomen. This patient come. Sir, I have paralysis. Facial reaction not matching with the symptoms. Conversion disorder treatment is behavioral therapy asked in NEET PG previously. Last slide, but not the least. Dissociative disorder. It is of four types: dissociative amnesia, dissociative fugue, dissociative depersonalization, derealization, dissociative identity disorder. If there's only memory loss, we call it amnesia. If there's a memory loss plus travel plus reaches a new place, assumes a new identity, we call it fugue. Do you know in last FMG exam they asked about fugue? A patient came wandering from another city 100 kilometers away, something like that. Have you seen FMG PYQs? Only memory loss, amnesia. Memory loss plus travel plus new place plus new identity. Trauma, memory loss, travels. New place, new identity, new life, new wife. Dissociative depersonalization is related to self and derealization is related to environment. If I'm detached from self, we call it depersonalization. If I'm detached from environment, it is called derealization. Detached from self, depersonalization; detached from environment, derealization. The patient will say, as if I am observing myself from outside me. As if I am observing myself from outside me. I am detached from myself. And identity disorder is presence of two or more than two identities in one person at a time. Presence of two or more than two identities in one person at a time. So I wanted to discuss the most important psychiatric disorders. 1, 2, 3, 4 dissociative. Clear? The four types of dissociative are clear. Now let's go backwards. Four disorders on this page. Can you differentiate only memory loss, amnesia? Memory loss, travel, new place, new idea. You are not supposed to revise psychiatry again after today. You just have to finish it off. Are you clear with all these four types of disorder? Depersonalization degeneration is only diagnosed when there is as if phenomenon. I feel as if I am detached from self, so that I am observing myself from outside me. Detached from environment. Change in self, depersonalization. Change in environment, derealization. Multiple personality disorder, also called dissociative identity disorder. Dissociative identity disorder. Change in identity. Are these four clear? Conversion disorder, number 5. Sensory motor neurological symptom after a stressful life event. 5. Somatization, somatoform pain, hypochondriasis. 5 plus 3, 8. Are these three clear? Multiple symptom somatization. Only pain, somatoform pain. Presents with a diagnosis hypochondriasis. I have lung cancer. The patient thinks he has cough and therefore he has lung cancer. I have tumor in the brain. Then I told him, if you have tumor in the brain, why did you come to psychiatry? Because just to take diagnosis confirmation, not to get a treatment, not to get a treatment. 4 plus 1, 5 plus 3, 8 plus 3. Acute stress, PTSD adjustment. Are we clear with this? 8 plus 3, 11. 11 plus 5. 16. OCD, body dysmorphic, hoarding, trichotillomania, exfoliation. Clear? 16 plus 3, 19. GAD, panic, and phobia. Then we have three more in mood disorder: mania, depression, bipolar. Anything that you haven't understood, anything that you didn't get, please ask me now. Today's session was supposed to be very crisp, very simple. Four, 5, 8, 11, 14, 17, plus 3, 20, plus 2, 22. Schizophrenia versus delusional disorder. Okay? Plus 10 types of personality disorder. 22 plus 10, 32. Plus delirium and dementia. 34. Depersonalization and nihilism. Depersonalization is detached from self as if I am observing. Nihilism is I am dead. Depersonalization is an anxiety symptom. Nihilism is a delusion. Nihilism is seen in severe depression with Cotard. Depersonalization is seen in anxiety. Organic versus functional. Any slide of today's class which is not clear to you that you want me to repeat, please ask. This is the last time for psychiatry for you. Anything that you did not understand, please ask. Next subject is, I think, pharmacology. Anything that is not clear, please ask. Fregoli capgras. If outside person wants to harm, it is capgras, and if family member gives you goli, it is fregoli. If outside person comes in the disguise of family member, we call it capgras. And if family member gives you goli, we call it fregoli. Prince. Could you at least mark these 20, 30 disorders in psychiatry correctly? Could you at least mark? Can I expect from you that you will mark these 30 disorders which we have just revised in psychiatry correctly? Yes, no. Yes. So my final best of luck to all of you for FMG exam and the students who are attending today's session for NEET PG to them as well. Although we will conduct one NEET PG marathon separately. But for today, that's all we have in psychiatry for you. If no questions, we'll call off for now and you will have the next subject rolling up very soon. Thank you. Bye bye. Have a nice day.
Yeah, hello all dear students, my dear doctors. So welcome you all for this DAMS FMG marathon. I hope I'm audible, visible. Please confirm so that we can start. Hanji. Okay. So okay ji, okay. So we are going to discuss pharmacology in this 1 hour. I'm going to revise some important topics. Please listen carefully and try to revise simultaneously. Okay, chaliye, let's start. So let's start with the basic topic. This is bioavailability. In bioavailability, the important question they are asking. What is the important question in the bioavailability? This is about the area under the curve, extent of absorption. So Tmax will decide the time will decide the rate, and AUC will decide the extent of absorption. So the fraction or bioavailability, extent of absorption, and in IV route it is the 100% bioavailability. Okay. Next question, next topic which is very important, very frequently asked topic, iron. In the iron, the best absorbed in empty stomach with ascorbic acid, or decreased by phytates like food, calcium like milk, and tannic acid like chai. Remember to avoid mucosal block. Nowadays, the recent data are saying to give alternate day iron therapy. Give the alternate day. So don't forget this. Give alternate day. If they ask you which iron is better, alternate day iron therapy will be better. So alternate day iron therapy beta, don't forget it. Alternate iron day. Okay? Alternate day. Now comes to in the volume of distribution, the very important point ki acidic drugs are bind to albumin and basic drugs are binding to alpha-1 acidic glycoprotein, and the drug which is having highest VD, I think every bacha knows highest VD is in with the chloroquine. That is the drug used for malaria, that is the drug used for rheumatoid arthritis, and there is risk of this bull's eye maculopathy. Don't forget bull's eye maculopathy. Very important topic. Bull's eye maculopathy. But antidote, frequently asked topic. Antidote. So in the antidote, you can see these questions from the antidote. In antidote, remember aspirin, barbiturates are the acidic drugs. Soda bicarb is the antidote. In amphetamine, what is the antidote? Ammonium chloride or cranberry juice. Don't forget this cranberry juice. In organophosphate, atropine, in atropine it is physostigmine. Beta they will try to confuse you. After exam, don't say me कि सर गलती से ऐसा हो गया कि सर atropine dhatura poisoning पूछा and you give the atropine. No, in dhatura poisoning it is the physostigmine. For diazepam it is flumazenil, and for morphine it is the naloxone. And in the methanol or ethylene glycol we use the fomepizole. So these are very important antidote. This slide is very important, beta, very important slide. Out of the drug interaction for you guys, these 2-3 drug interactions are very important. First is estrogen. In estrogen, remember rifampicin can cause the estrogen effect decrease because of the CYP inducer property. And in the CAT group of drug, these are if given with the CYP inhibitor, there is risk of arrhythmias. Clopidogrel is inactive drug. It is activated via CYP2C19, and tamoxifen activated via CYP2D6. So they will not be able to activate if you give the clopidogrel with omeprazole and if you give the tamoxifen with the SSRI fluoxetine. So these drug interaction, don't forget this drug interaction. Out of these, first, second, very frequently asked. But nowadays, third and fourth also important because they have been asked in the NEET PG exam as well. So beta, these are some important drug interaction. Then comes to about the kinetics of elimination. Two important point. In the first order kinetics, remember the elimination is directly proportional to plasma concentration. Elimination is directly proportional to plasma concentration, but in zero order kinetic elimination rate is constant. So if they ask you in which order of kinetic elimination rate is constant, that is zero order. In first order, it is the fraction which is constant. In first order, half-life is constant, clearance is constant, but elimination is depending on the plasma concentration. And that's why like alcohol, phenytoin, they can follow some zero order kinetic. So very important point. Don't forget these formulas. Loading dose depends on volume of distribution. Maintenance dose depends on the clearance. And target concentration you can achieve after 4 to 5 half-lives. Half-life is depending on the volume of distribution and clearance rate. So 0.693 multiplied by VD and divided by the CL. Right? Beta, inducers increase the effect of other drugs unless until they are the if they are the prodrugs. If they are prodrug, then they will be activated. That is inducer effect. Inducer of enzymes. They are not the drug inducers. They are the inducers for enzymes. So obviously the drug will get metabolized due to enzyme induction property. And if metabolism, they will become the inactive form. But in prodrug, they becomes the active. Beta, redistribution in which drug? That is thiopentone, and drug metabolized in the plasma. That's why they are short acting, and the name of the enzyme is esterase enzyme. So nowadays, very important beta blocker, landiolol, esmolol, these are the short acting beta blocker. Hormones elimination occurs in the lungs, and that's why these drugs are safe in the liver and kidney disease patient, and the name of the drug is atracurium, cis atracurium. Can you tell me which class of drug is atracurium? What is the purpose of atracurium? For which purpose we are using the atracurium? So thiopentone, everybody knows it is the drug which is very short acting, ultra short acting because of redistribution phenomena. It is reaching from brain to fat, and that's why the effect in the brain will be decreased within few minutes. It is only used for induction, not for maintenance. But can you tell me about the drug atracurium, cis atracurium? And then about this, whenever, remember, if the graph is shifted to right, if the graph is shifted to right, it is competitive. The height is same. The graph shifted to down, it is non-competitive. If the graph is right as well as down, then you can say it is the uncompetitive. Uncompetitive means the graph is shifted to down as well as efficacy is low as well as the right side. Yes, very good. So atracurium, cis atracurium are the drugs which are used for which purpose? These drugs are muscle relaxant, curium, curonium, muscle relaxant. So always remember the mnemonic HELP, H-E-L-P. H-E-L-P. Height tell us the efficacy and left side of the graph will tell us the potency. So that's why in the first one you can see the height is same, the efficacy is same. But if the graph shifted to right, the potency decreased. But in the second you can see the graph is down, that means the efficacy is decreased. So that is the difference between non-competitive and competitive graph. The question can be asked in the enzymes as well. Competitive enzyme inhibition and non-competitive enzyme inhibition. Beta, some important teratogenicity, thalidomide, you know, phocomelia, limb sailing defect. In lithium, it is abstin anomaly, and in the carbimazole, it is the cutis aplysia. That's why we don't prefer carbimazole. What is the drug we prefer in the pregnancy? It is the PTU, propyl thiouracil, in the first trimester. And we don't use lithium, we use the atypical antipsychotics in the pregnancy. We don't use thalidomide, we use the simple antihistaminic doxylamine for the morning sickness. In the definition, essential drugs are satisfying the priority healthcare need of the population. National List of Essential Medicine 2022 we are following. Placebo means what? Placebo are the dummy drugs. Dummy drugs without any active ingredients. These are also called as sham. Sham or dummy. Orphan drugs are used for rare disease, and Schedule H drugs are called as prescription drugs. G is not prescription, they are given under medical supervision but not available against prescription. They can be available without prescription also. And X drug is narcotics and psychotropics like ketamine, morphine. So these are some important small definition we need to know. And this is again important. Spurious drug means these are the imitations or fake, counterfeit drugs. These are dangerous drugs. Misbranded means only the inaccurate label information is there. Suppose 500 mg written on the label, inside you got the 250 mg. And adulterated means there is impurities. But this spurious is most dangerous. Poor quality, fake, imitation. Instead of antifungal, you got the sucrose. That is spurious. And the last important point in general pharmacology is about the clinical trial. The phase 1 is first time you will check the safety and you will get the tolerability. And you will get the dose first time. This is the tolerable dose. In phase 2, it is in the patients and you will get the efficacy and proof of concept. You will get the effective dose. But in the phase 3, you will get the best data, or you will confirm all the doses, you will confirm the safety, you will confirm the tolerability, you will confirm the efficacy. So phase 3 is best data. So you will get the best data as well as you will get the exact dose of the drug. And then you get the market approval, and then you can do the post-marketing study, and that is called as phase 4. To know the rare side effects, we do the phase 4 studies. Beta, phase 0 is called as microdosing, but that is not mandatory. Phase 5 is post-marketing. After phase 4, you can do phase 5 also. For pharmacovigilance, the purpose is to monitor the ADR. In India, you know where is the PVPI center? Can you tell me where is the PVPI center of India? And don't forget this therapeutic index. I am waiting for your reply. PVPI in India. Where is the national center? This therapeutic index will decide the safety margin. Safety margin. Median toxic dose divided by median effective dose. This is median toxic dose. And this is median effective dose. And the ratio is called as therapeutic index. Then beta FMG favorite question. Myasthenia gravis. In the myasthenia gravis, adrophonium used for diagnosis and neostigmine, pyridostigmine used for the treatment. Pyridostigmine is best. Very good, bachcho. Ghaziabad. Very good. So in the diagnosis, adrophonium, short-acting drug. In the acute condition, we use the neostigmine, and the condition will improvement. When the improvement is seen, that means it's a case of myasthenia gravis. In the smokers, varnicellin is the best and most effective drug. It is the partial agonist. It is the partial agonist. Alpha 4 beta 2 receptor of nicotine. It is the partial nicotine receptor agonist. But there is risk of suicide. So we have the bupropion as antidepressants. DNRI. Dopamine, norepinephrine, reuptake inhibitor. Out of the anti-epileptic, it is topiramate, and you can use the nicotine replacement therapy. It is available in the patch, it is available as a spray, it is available as the gums. All they are the anti-smoking. Combi therapy is more effective, but single varnicellin is the overall most effective drug out of these. But commonly used is NRT also, nicotine replacement therapy. Then beta, which drug we use for cardiac stress test? Dobutamine. Which drug is used for hypertension in pregnancy? We use the levetolol. Which drug we use for anaphylactic shock? We use the adrenaline, intramuscular. And the drug for cardiogenic shock with oliguria, if the oliguria, what is there? It is dopamine. But otherwise, the best vasopressor in shock patient, like septic shock, so vasopressor in shock, then it is the NORCET. The best is NORCET. The best vasopressor in septic shock. And the best inotrope in cardiogenic shock is dobutamine. So this is the inotropic. This is the best inotrope in CHF, acute heart failure. Acute heart failure. So this is very important. Yes. Now comes to some important question related to CVS integration. In the patient of atrial fibrillation, you can control the rate by using the beta blockers. Beta blockers are best. DC cardioversion is best if the patient is having unstable BP, unstable heart rate. Then cardioversion. But for normal sinus rhythm, we use the ibutylide, dofetilide. These are potassium channel blockers. And simultaneously, we need some anticoagulants as well. But best drug for rate control is beta blocker, and for normal sinus rhythm, ibutylide. DC shock. We can use cardioversion DC shock. SVT attack beta, SVT. In SVT attack, what is the drug of choice for acute SVT? Adenosine or verapamil. Adenosine is best, but in asthmatic patients, we use the verapamil. In asthmatics, we use the verapamil. We also have one nowadays, atripamil nasal spray. Atripamil nasal spray. That is also calcium channel blocker. And to prevent the recurrence, or you can say the prophylaxis, the best drug will be calcium channel blockers. So the best for acute attack is adenosine, best for prophylaxis is calcium channel blocker. If the patient is having VFib, ventricular fibrillation, start the CPR. During CPR, we inject adrenaline. In CPR, we use the adrenaline. But what is the drug to control the arrhythmia? Then amiodarone is best. But in post-MI patient, we use in the acute MI patient, we use the lignocaine. In digoxin toxicity, we use the lignocaine. In acute MI and digoxin toxicity, we use the lignocaine. Otherwise, no amiodarone. In the VFib patient. But you can see CPR, shock. So during CPR, we use the adrenaline. If the patient is having sinus bradycardia or first degree heart block or Mobitz 1 heart block, atropine is the drug of choice. Sinus bradycardia, first degree and Mobitz 1. But if the patient is having Mobitz 2 and complete heart block, then pacemaker, not atropine. So in Mobitz 2 and complete heart block, pacemaker. In the heart failure, CHF. In the heart failure, for rapid relief of symptom, the best drug is furosemide. Loop diuretics are the best option. But they cannot control the disease, they cannot decrease the mortality risk, they cannot decrease the remodeling. So these drugs decrease the remodeling. BAP group of drugs. RAS pathway inhibitors. So we have the BAP, beta blockers, ACE, ARBs and potassium sparing diuretics. But nowadays the overall best is ARNI. Angiotensin receptor plus neprilysin inhibitor, sacubitril, valsartan. This combination, this is best overall. This is best. But which diuretic is for this purpose? Spironolactone. In acute condition, we use the drug loop diuretics. Then, out of the diuretic which is indicated in cirrhosis of liver, so that is spironolactone. That is best. Which is contraindicated, that is acetazolamide. And in the pulmonary edema, which is best? Furosemide. But mannitol is not safe because increase the plasma volume, increase the load over the heart. Which diuretic increase the risk of calcium stone? So that is loop diuretics. And which decrease the risk of calcium stone? Thiazides. Because thiazides are causing hypercalcemia. They take the calcium back from the nephrons. And loop causing loss of calcium through the nephrons. Beta, this is important. Renin inhibitor. This is important. Renin inhibitor, that is aliskiren. But the drug which decreases the renin secretion is beta blocker. Decrease renin secretion, that is beta blocker. The drug which inhibits the angiotensin 1 to 2 is ACE inhibitors, and the drug which inhibits the angiotensin 2 action is angiotensin antagonist. So this is important question. Aliskiren in the RAS pathway inhibitors. In the selection of antihypertensive drugs, in diabetic patients, dyslipidemia patients and heart failure patients, ARBs or ACE inhibitors are best. Always prefer the ARBs over the ACE inhibitors because no bradycarditis side effects. But in asthmatic CCBs, calcium channel blockers, bronchodilator. In the MI or angina, beta blockers. In the BPH patients, alpha blockers. In the pregnancy, labetalol is best. We can use the methyl dopa, we can use the nifedipine, we can use the hydralazine, but labetalol is best. So don't forget the selection of antihypertensive drugs. And these are the drugs for hypertensive emergencies. In emergencies, the best is nicardipine. That is one of the calcium channel blocker. But out of the beta blocker, it is the labetalol. In eclampsia patients, in ICH, intracranial hemorrhage, in the neurology patients, labetalol is wonderful drug. And out of the ACE inhibitor, it is the enalaprilat. That is the active form of enalapril. So we can use that. So which calcium channel blocker used in subarachnoid hemorrhage patient? So that is the nimodipine. Nimodipine. Because nimodipine is high lipid solubility reaching to brain, having relaxation of the ischemic blood vessels. In the arrhythmia, they are asking the mechanism. Sodium channel blockers are acting on which pathway? Sodium channel blockers are acting on phase 0. Phase 0. And calcium channel blockers are acting in the calcium. And this is class 3, that is potassium channel. Remember the class 3 potassium channel, amiodarone, that is acting on 3. And class 1 is acting on phase 0. So especially they are asking the amiodarone, that is the drug class 3 inhibitor, and target the repolarization third phase. Then in the angina, 2-3 important question. Which drug is potassium channel opener used for angina? That is nicorandil. Nicorandil. See the angina of Dil. Nicorandil is a potassium channel blocker for angina. Which drug is funny current inhibitor? Funny sodium channel inhibitor. Funny sodium channel inhibitor, that is ivabradine, causing bradycardia. Ivabradine, funny sodium channel inhibitor. Trimetazidine and ranolazine, they are inhibiting the partial fatty acid oxidase enzyme, PFOX. Trimetazidine, ranolazine, PFOX inhibitor. So these are important drugs where the direct questions are coming based on the mechanism. This ranolazine is also sodium channel blocker, late sodium channel blocker. Then beta, short question, that is anticoagulants, newer anticoagulants. These are newer oral anticoagulants. These are directly acting drugs. These are directly acting drugs. Directly second A inhibitor is dabigatran and directly 10th A inhibitor is XA-ben. You can see the name, 10th A-ben. So apixaban, rivaroxaban, out of these best is apixaban. It is safe in the kidney patients as well. And dabigatran is also wonderful drug, but that is not safe in kidney patients. And also don't forget the antidote, dabi-daru, and this 10th inhibitor is antidote is andexanet alpha. So these are antidotes. Vitamin K is antidote for warfarin. Protamine sulfate is the antidote for heparin. Which anticoagulant safe in pregnancy? The anticoagulant which is safe in pregnancy is heparin, enoxaparin, fondaparinux. These are safe. Enoxaparin is commonly used in the DVT, in the pregnancy. And the antidote will be same, protamine sulfate. Because these are acidic drug, protamine is the opposite, alkaline. Beta, in warfarin, heparin, if they ask about the bleeding, if anticoagulants causing bleeding, nowadays the best is PCC, don't forget it. If anticoagulant causing bleeding, the best is PCC, prothrombin complex concentrate. So in bleeding, PCC is best. Antidote is different, but to control the bleeding we use this. This is very important, beta. Out of the antiplatelet, 2 questions are important. In the low dose aspirin is COX inhibitor. Low dose aspirin is COX inhibitor. That is COX-1. So decrease the thromboxane synthesis. And P2Y12 inhibitor in the irreversible and reversible. So remember, these grill is irreversible and grill or. So if the R is there, that is reversible. Ticagrelor, cangrelor, these are reversible. But ticlopidine, clopidogrel, prasugrel, these are irreversible. Don't forget these. P2Y12 inhibitor. Out of the dyslipidemia drug, LDL is for LDL statins are best, but they are not the most effective drug. The most effective drug is azitimib. that is inhibiting the absorption of cholesterol from the intestine, and PCSK9 inhibitor, that is like alirocumab, evolocumab. These are PCSK9 inhibitors. Or inclisiran, that is also PCSK9. Inclisiran. So these are the drugs. But for triglycerides, the best drugs will be fibrates, and these are PPAR, peroxisomes proliferation activated receptor, PPAR alpha agonist. And beta, if you want to increase the HDL, then niacin and omega fatty acid. But niacin is having risk of flashing reactions. Release the prostaglandins. There will be vasodilation. These PCSK9 inhibitors are important, beta. These are the most effective drug for LDL reduction. Drug of choice is statin, but the most effective drug is these. HMG coreductase inhibitor, that is competitive inhibition. Competitive inhibition of HMG coreductase enzyme, that is the rate limiting. And the main side effect is muscular side effect. Ezetimibe, I told you, inhibit the cholesterol absorption in the intestine. Out of the new drug, these are important, and this is very important. Bempedoic acid. Bempedoic acid inhibiting this enzyme, it is competitive inhibition. Bempedoic acid. The competitive inhibitor of ATP citrate lyase decrease the synthesis of cholesterol. Then vomiting, very frequently asked question, chemotherapy vomiting. So in the chemotherapy vomiting, chemotherapy induced nausea and vomiting, best is ondansetron. Simultaneously we use the steroids, the effect of these drugs will be better. For late onset we use the neurokinin, pitants, and then we add the cannabinoids also in the regimen, that is cannabinoids acting on the cannabinoid receptor like nabilone, dronabilone. Overall drug of choice is ondansetron, granisetron, but in the late onset these are the drug of choice, but we use all these 3-4. And olanzapine is also approved. Olanzapine, that is one of the antipsychotic drug. Olanzapine, that is also approved. In the severe cases where you use the olanzapine. Then beta, the important DOC. What is the drug of choice for seasickness? Maclizine, that is H1 antihistaminic. Maclizine, cinnarizine. For mountain sickness, acetazolamide, but don't forget rapid descent. That is the first option. In morning sickness, doxylamine, and in the motion sickness, either scopolamine or promethazine patch. Scopolamine is anti-muscarinic and promethazine is antihistaminic. Then beta, one important question is anti-H. pylori drugs. So out of the H. pylori drugs, the most effective is PPIs with amoxicillin with clarithromycin. So omeprazole with amoxicillin with clarithromycin, OAC. That is the most effective. Bismuth comes in the quadruple therapy, which includes the tetracyclines also. And that's why this is more toxic. Remember the PPI, omeprazole with amoxicillin with clarithromycin. Drug of choice or first line drugs in seizures. In GTCS, valproate is the first line drug. Drug of choice in absent seizure, ethosuxivant. This is very important question, beta. T type of calcium channel blocker. T type of calcium channel blocker. In the voltage gated calcium channel blocker, gabapentin. In focal seizures, we use the carbamazepine or lamotrigine. In pregnancy, safest is this one, levetiracetam. But if already pregnant, then you can continue the old drug. If already pregnant, then you can continue. But otherwise, you can change to the safest one, that is levetiracetam. Febrile seizure, diazepam is available rectal, IV, intranasal. So nowadays, intranasal is commonly used. In infantile spasm, ACTH is the drug of choice, and in tuberous sclerosis, it is vigabatrin. Otherwise, it's a visual side effects. And you know, status epilepticus, lorazepam. So, one important question is drug-induced Parkinson, rabbit syndrome. So, if rabbit syndrome, drug-induced Parkinson, what is the best treatment? Benz Hexol is the best treatment. benhexol. These are centrally acting anticholinergic drug. Benhexol. Drug-induced Parkinson due to antipsychotic drugs. If there is extrapyramidal symptoms, other extrapyramidal symptoms, it could be dystonia, it could be akathisia, it could be neuroleptic malignant syndrome. With the dystonia, we use the THP same, benhexol. But in the akathisia, we use the propranolol. And akathisia is most common. And that is restlessness, moving here and there. But the most serious is neuroleptic malignant syndrome, where the severe muscle rigidity. And the drug of choice is dantrolene sodium. With dantrolene, you can add the bromocriptine. If there is buccolingual masticatory repeated movements, this is called as tardive dyskinesia. The continuous use of these drugs, antipsychotic drugs, there will be tardive dyskinesia. And in this case, we use the VMAT2 inhibitor valbenazine. That is the drug of choice, but simultaneously change the drug. Out of the antidepressants, SSRIs are the drug of choice for all OCD, depression, PTSD, panic, sub. Not for acute attack. In panic attack, we use the benzodiazepines. But in the panic disorder, we use the SSRIs. Dapagliflozin is approved for premature ejaculation because all these drugs are decreasing the libido, sexual desires. And that's why dapagliflozin is specially approved. Bilal, can you elaborate your question? What do you want to ask? In the SNRI, we have the duloxetine, wonderful drug. Duloxetine. In the SNRI, it is the duloxetine. For the severe depression, for neuropathic pain, for stress incontinence, we use the duloxetine. That is the SNRI. And for postpartum depression, especially approved drug is brexanolone and zuranolone. These are allopregnanolone neurosteroids and they are approved for postpartum depression. So remember these drugs, direct questions could be asked. And in the CNS, one very important topic is lithium monitoring. Take the morning sample after 12 hours of night dose. Take the sample on the 5th day or 4th day and then check the level. If it is more than 1.5, if it is more than 1.5, it is toxic. If it is more than 2, tremors can be seen. If it is more than 4, dialysis start till the level comes less than 1. Start the dialysis. And the best sample will be on the 5th day, 4th to 5th. The Z group of drugs approved for insomnia are zolpidem, zaleplone, azopiclone. These are good because they have less dependence, less tolerance, less hangover. But nowadays in chronic insomnia, best is melatonin receptor drugs like ramelteon, tasimelteon, agamelotine. This tasimelteon is specially approved for blind people. For blind. Agomelatine is used for mood elevator. These are melatonin receptor acting drugs. In pregnant women, if there is depression, then definitely we can use the SSRI sertraline. For opioid de-addiction, first give the replacement. In replacement, the best is methadone. The alternative is buprenorphine. To treat the acute withdrawal symptom, we can use the lofexidine, that is alpha-2 agonist like clonidine. For alcohol de-addiction, we use the disulfiram as best aversion therapy. But to treat the alcohol withdrawal symptoms, the best is benzodiazepines like lorazepam. Why not diazepam? Because diazepam is not safe in the liver disease patients. But in both these, to prevent the risk of relapse, we use the naltrexone, longer acting drug, more potent drug. It is orally acting drug. More potent orally but longer. The best is methadone as replacement and naltrexone for add-on. In the alcohol, disulfiram is best but risky. Disulfiram like reactions, aldehyde dehydrogenase enzyme. So to control the withdrawal, we use the benzodiazepines, and to prevent the relapse or craving, we use the naltrexone. Out of the antihistaminic, QT prolongation seen with the terfenadine, that's why it is banned from the market. And the drug which is having least insomnia is fexofenadine bilastine. And remember this fexofenadine, levocetirizine, these are third generation. Fexofenadine, levocetirizine, these are third generation antihistaminic. They are the least sedation, but overall least sedation is in with the fexofenadine bilastine. Out of the NSAIDs, aspirin is the only drug which is irreversible COX inhibitor. It is not safe in children because of risk of Ray's syndrome. It is having semter-striate, aspirin sensitivity and asthma and polyps. Overdose is salicylism. One important use of NSAID is PDA closure, and the overall best for PDA closure is ibuprofen, but the most effective drug is indomethacin. So we got the selective COX-2 inhibitor which are having no gastric side effect, but they can have the heart attacks. All these drugs are COXIBs. In the gout, remember for acute gout NSAIDs or colchicine, but colchicine which is the inhibition of chemotaxis. It inhibits the chemotaxis, but the problem with this colchicine is it is having the risk of bone marrow suppression. That's why NSAIDs are more preferred. But in the chronic, to decrease the xanthine oxidase enzyme, we use the allopurinol febuxostat. Probenecid is a uricose-uric drug, and RAS uricase, pegloticase are the uricase, or you can say these are the oxidase, uric acid oxidase. Like bud uricase is RAS uricase and mammals uricase is pegloticase. Sorry, prostate value surgery, women come in the third trimester, then we shift to low molecular Beta, if prosthetic valve and third trimester, then obviously LMW heparin. Then comes to beta paracetamol. Paracetamol, one important question is centrilobular necrosis of liver. Due to NAPQI, centrilobular necrosis of liver. And N-acetylcysteine is the antidote which will replenish the glutathione peroxidation pathway, decrease the liver injuries. Otherwise, PCM is safe, but liver disease risk is there. More than 10 gram is hepatotoxic. In the migraine, for acute migraine, we use the, other than NSAIDs, we use the vasoconstrictor. That's why they are risky in the heart, angina patients, hypertension patients, MI patients. So we have the three groups: ergots, triptans and meditans. Ergot, triptans and meditans. Ergots are more risky, you can see risk of gangrene. Triptans are safer, which are selective 5-HT 1B 1D. But nowadays we have one best, and that is meditan, last meditan, that is 5-HT 1F, and that is the least toxic out of these. The maximum risk of gangrene with the ergots, then triptans, then meditans. But triptans are overall drug of choice. In the prophylaxis of migraine, beta blockers are best. But we can use the flunarizine calcium channel blocker. We can use the valproate gabapentin and anticonvulsants, amitriptyline as antidepressants, and GPENTs, CGRP antagonist GPENTs, also GPENT, or monoclonal antibodies like arenumab, fremanizumab. So these are the drugs we are using for prophylaxis. So that we discussed in the gout. Then in the rheumatoid arthritis. Important question is, there are three important questions. What is the enzyme inhibited by methotrexate dihydrofolate reductase? What is the enzyme inhibited by leflunomide, that is dihydroorotate dehydrogenase? So the both drugs are inhibiting the different enzyme, methotrexate for purine synthesis and leflunomide for pyrimidine synthesis. And one important question is targets in the biological therapies. The anti-TNF alpha, remember the alphabet A, then C, then E, then G, and then I. One alphabet is there, one is not there. So Adali, Sertoli, Goli, Etanercept and Infliximab. Interleukin 6 is Tocilizumab. Interleukin 1 is Anakinra. And CD20 marker inhibitor is Rituximab. These are JAK inhibitor. You can see JAK, genus kinase, C-tinib. All these C-tinib or Letinib are the genus kinase inhibitor used in inflammatory bowel disease, used in the rheumatoid arthritis, and they have the risk of thromboembolism. They have the risk of thromboembolism and they have the risk of herpes zoster. Thromboembolism and herpes zoster. C-tinibs. Out of the respiratory, the most common side effect of salbutamol is tremors, but there will be tachycardia, there will be tolerance, tachyphylaxis, and electrolyte imbalance. There will be hypokalemia. That's why arrhythmia due to salbutamol, or you can say beta-2 agonist. One of the common side effect of Montelukast nowadays, FDA warning for cognitive dysfunction. Some important monoclonal antibodies in bronchial asthma. Out of these, very important is IgE, that is Omali. So for IgE, target is Omali. For interleukin 4, remember the 4 number dupilumab, and interleukin 5. So these two are very important, IgE and this Mepoli, Resli and Benralizumab. So EEE, Mepoli, Resli, Benrali, and Omalizumab is IgE. Drugs for acromegaly. In the acromegaly, we use the octreotide lanreotide. This is for acromegaly. This is for acromegaly. And pasireotide for Cushing syndrome. Pasireotide approved for Cushing syndrome. Octreotide lanreotide for acromegaly. Lanreotide. And pasireotide is approved for, other than acromegaly, it is approved for Cushing syndrome. This is important. Pasireotide for Cushing's. Bromocriptine, cabergoline. So cabergoline best for prolactin secretion. Best for prolactin secretion, cabergoline. That is more preferred over the bromocriptine. In the prolactinoma, we use the cabergoline. The ultra short acting insulins are lag. But in DKA, we prefer the regular because it is given IV. Glargine, Detamir, Degludec, Itodac, these are longer acting drug, peakless basal insulin. Glargine is commonly used. But Lispro, Aspart, Glycine, lag, these are ultra short acting insulin. Some very important question from the anti-diabetic drugs. Anti-diabetic drugs which are used for weight loss. Liraglutide, semaglutide, tirzepatide, obesity. And which is used for short bowel syndrome, that is teduglutide. Out of these, semaglutide is available now oral as well. All are subcutaneously, but we have the oral drug also. Tirzepatide is dual. It is dual. It is GLP-1, glucagon-like peptide, as well as GIP, glucose-dependent insulin-tropic peptide. Which anti-diabetic drug causing UTI? So these are gliflozins, SGLT2 inhibitors, which are used for heart failure. CHF. Which gliptins safe in the renal failure? Linagliptin, completely through the bile, safe. Remember, out of the gliptins, why saxagliptin is not used? So saxagliptin is not commonly used because of CYP drug interactions. CYP drug interactions. Then, out of the anti-thyroid, the important question is Lugol's iodine, that is 5% iodine in 10% Ki, and that is given pre-operatively because it will cause the shrinkage, decrease vascularity, but risk of sialadenitis. Carbimazole is best option, but it is not for first trimester. PTU is the drug then we use in the first trimester. but P2 is short acting drug. Out of the iodine, we use the iodine 131 beta rays for distraction. So in pregnancy first trimester we use the PTU. In the osteoporosis, the best drug will be bisphosphonates, but the immediate effects in with the calcitonin, immediate. So acute condition, immediate calcitonin. Out of the SCRM, it is raloxifene for postmenopausal HRT. Teriparatide is the recombinant PTH. But when we use the bisphosphonates, there is risk of reflux esophagitis. Risk of reflux esophagitis, osteonecrosis of mandible, as well as the femur neck. Femur neck. So which drug have a risk of osteosarcoma? Teriparatide. And which drug have a risk of femur fracture is bisphosphonates. Don't forget one important drug, calcimimetic agent, calcimimetic. And the name of the drug is Senacalcet. Senacalcet. And this drug is approved for hyperparathyroidism. It will decrease the PTH secretion. Calcimimetic agent is Senacalcet. Breast cancer is very hit topic. Out of the SERM we use the tamoxifen, and out of the aromatase inhibitors we use the letrozole commonly. Letrozole increase the risk of osteoporosis, tamoxifen decrease the risk of osteoporosis, but there is risk of endometrial cancer due to tamoxifen. That's why raloxifene used in HRT, because with raloxifene there is no risk of endometrial cancer. In the induction of ovulation, nowadays we prefer the letrozole in the PCOS patients. The last is antibiotics and anti-cancer. So penicillins are crystalline penicillin like penicillin G, which is used for gram-positive bacteria mainly. But the main problem is allergy. Then macrolides are the alternative drug. In Pseudomonas, penicillin G was not very effective. So we got specific for Pseudomonas is piperacillin. So which penicillin we use for Pseudomonas? That is piperacillin. Out of the long-acting penicillins, Procan and benzathrin is commonly used like rheumatic fever prophylaxis as well as syphilis. But not for neurosyphilis. In neurosyphilis, we still use the crystalline penicillin. Out of the cephalosporin, the drug of choice for surgical prophylaxis is first generation cefazolin. For Pseudomonas, we use the ceftazidime. For MRSA, we can use the 5th generation. But most commonly used is ceftriaxone, and you can see ceftriaxone for meningitis, for typhoid fever, for pneumonia patient. It's a wonderful drug, ceftriaxone. When the typhoid fever, gonorrhea, it is the drug of choice. Meningitis, it is the drug of choice. One alternate drug of ceftriaxone is cefotaxime. These are some specific drug of choice they are asking. For chlamydia, azithro. For mycoplasma, azithro. For cholera, it is doxy. For listeria, it is ampicillin. And for B vaginosis, very important, is metronidazole. So for atypical pneumonia, azithromycin. If there is Clostridium difficile diarrhea, that is a super infection, the best treatment will be nowadays most effective is fidaxomicin. But we can use the vancomycin orally or metronidazole. But fidaxomicin is most effective. One resistant bacteria is MRSA, and in the MRSA, vancomycin is the drug of choice. The other option we have is the linezolid. Linezolid. Even rifampicin is effective. Macrolides, beta-lactams, they are not effective. Topically, we use the fugidic acid, topical. But systemically, vancomycin, tigecycline, linezolid, these drugs are used. The drug causing grey baby syndrome is chloramphenicol. The drug causing red man syndrome is vancomycin. The drug causing tooth discoloration is tetracyclines. That's why not safe in children. And linezolid causing bone marrow suppression and MAO inhibitor. Linezolid. It is the drug for resistant TB as well. So neuritis, bone marrow suppression, MAO inhibitors. the cheese reactions, rotuline syndrome due to linezolid. Which antibiotics causing seizures? That is ciprofloxacin. It is causing seizures, it is causing tendinitis, it is causing QT prolongation. The ciprofloxacin, ofloxacin like drugs. The seizures very important. Epilepsy. Out of the TB drug, if they ask the neurological toxicity, to remember the Niacid. If they ask the eyes related, to remember the ethambutol. If they ask the joint related, to remember the pyrazinamide. If they ask the orange red discoloration, then rifampicin. So R for red orange, Niacid for neurons, ethambutol for eyes, and joint for JAD. That is pyrazinamide. Out of these, the drug which is going in the SHIP group is acetylation is isoniazid. And most hepatotoxic drug out of this is pyrazinamide. Very important, B-PAL. So bedaquiline ATP synthase inhibitor, QT prolongation risk. Delaminid mycolic acid inhibitor, QT prolongation risk. Pretomanid is important. It is inhibiting the mycolic acid cell wall as well as respiratory poison because increase the nitric oxide. But it is not causing QT prolongation. It is also inhibiting the mycolic acid. Linezolid is a protein synthesis inhibitor, inhibiting the initiation of protein synthesis. But these drugs are important. If they give a TB with HIV, so remember first start the ATT and then start the ART to avoid the risk of immune reconstitution, inflammatory syndrome risk. To avoid this risk, it should be given within 2 weeks. The ART should be started within 2 weeks. But in meningitis patient, it should be wait for 4 weeks and then at least within 8 weeks you should start. But in the resistant TB, we should know what is the treatment for MDR or XDR TB patients. So this is B-PAL and B-PAM regimen. B-PAM is approved in National Tuberculosis Elimination Program, India. B-PAM is approved. 6 months, but you can extend up to 9 months. So B-PAL and B-PAM. So in MDR or RR-TB with fluoroquine sensitivity, we can use. Out of the antiretroviral drug beta, post-exposure prophylaxis, we use the TLD. For the treatment, we use the TLD. So all the patients as well as prophylaxis in the post-exposure, we use the TLD. In the post-exposure prophylaxis start within 72 hours. Within 72 hours and given up to 4 weeks. In mother to child transmission, nevirapine, if the viral load is less than 1000 for 6 weeks, and this is for 6 weeks if more than 10,000 viral load. But in the breastfeed, then we use the 12 weeks treatment. In the breastfeeding, we give the 12 week, the treatment will be same, only duration will be changed in the breastfeeding, exclusive breastfeeding. But a drug of choice for mucormycosis is LAMB. Out of the azoles, it is posaconazole, but LAMB is drug of choice. The drug of choice for this candidiasis is fluconazole. The safest amphotericin B is liposomal amphotericin B. In cryptococcal meningitis, we use the LAMB, then flucytosine, both, and then followed by fluconazole. Fluconazole for maintenance therapy. In the aspergillosis, we prefer the voriconazole. Then for the malaria, the drug for exerythrocytic stage radical cure is Primaquine. Radical cure. For severe malaria, we use the artesunate. For prophylaxis, we use the mefloquine or doxycycline. Mefloquine if more than 6 weeks, doxylin less than 6 week journey. But in chloroquine resistant falciparum malaria, we use the artemisinin based combination therapies. So in prophylaxis, mefloquine and doxy you can see. And artesunate plus sulfadoxime pyrimethamine for most of the India except northeast. In northeast we use the artemether plus lumefantrine, that is for uncomplicated. In complicated, always artesunate is the drug of choice, that is IV. The alternate drug is quinine. In falciparum we use the chloroquine with primafin. For neurocystic sarcosis, what is the drug of choice? Albendazole. For hydatid cyst, what is the drug of choice? Albendazole. For nematodes, what is the drug of choice? Albendazole. But for river blindness, we use the ivermectin. For most of the trematodes and cestodes, we use the praziquantel. But for liver fluke, we use the triclavendazole. In the scabies, we use the topical permethrin and oral ivermectin. And the last is about the anti-cancer. So, sir, bone marrow suppression due to anti-cancer drug. So, for treatment of anemia, we use the darbepoetin, erythropoietin. For treatment of leukopenia, we use the filgrastim. So, this is darbepoetin injection, filgrastim, and for thrombocytopenia, we use the interleukin 11, that is oprelvecin. So, darbepoetin, filgrastim, oprelvecin, anemia, neutropenia, and thrombocytopenia. Some important toxicity. One is cerebellar. The drug causing cerebellar toxicity is cytarabine. Most hematogenic cisplatin. Cardiotoxicity due to anthracyclines. Remember ruby is in ruby red color, that is iron toxicity. Hemorrhagic cystitis due to cyclophosphamide. So we use the mesna. These are important. But remember the hematogenicity, nausea vomiting, ototoxicity, and nephrotoxicity. These all are due to cisplatin. Hand and foot syndrome. Remember the full capacity hand and foot syndrome. Full capacity hand and foot syndrome. So that is full means 5-fluorouracil and capacity is capacitabine. Pulmonary fibrosis and flagellate dermatitis due to bleomycin. Some targeted therapies, out of these 2-3 important. One for non-small cell lung cancer, which is nowadays common. Osimertinib for EGFR inhibitor. Osimertinib. In the CML, remember the first generation IND, imatinib, nilotinib, dasatinib. The osimertinib lung cancer, IND for CML, and lapatinib for breast cancer. Only remember these three. The osimertinib, IND, and lapatinib. These are the TKIs used in cancer. Out of the small molecule inhibitor, remember one BRAF inhibitor, RAF. So that is RAF. In name you will see RAF. Proteasomes inhibitor for multiple myeloma. So these are important drug for multiple myeloma. Proteasomes inhibitor, these are Zomib. Multiple myeloma. And cyclin dependent kinase inhibitor is Ciclib. So by suffix you can remember these names. JAK inhibitor I told you Citinib. So RAF is BRAF, Zomib is proteasomes, and Ciclib is CDK. These are for breast cancer. This is for multiple myeloma. And beta these monoclonal antibodies. For breast cancer we use the HER2 gene, and for HER2 gene we use these drugs. Trastuzumab, pertuzumab. For colorectal cancer C2, PANI2. Also for head and neck cancer. For Alzheimer's we use the NEEMAP. These are targeting the beta amyloid. But rivastigmine patch is best. Rivastigmine patch. that is best. For HIV we use the Ibalizumab. So these are some important monoclonal antibodies, but breast cancer is most important out of these. And beta, the last is this chelators. Remember Balma. So Balma, mercury and arsenic. Best drug for mercury and arsenic is Bal. In iron and cadmium it is not used. For copper we use the zinc or tritane, penicillamine. In the iron these are injection, desferrioxamine, dexrazoxane, this is oral, deferiprone, defracirox. And beta defracirox is best because less gastritis, defracirox. So deferiprone, defracirox are oral. So these are the chelating agents. So that's all bachcho about this class. I wish you all good luck. If you have any doubt, any query, you can ask. Please revise these marathons in this quick way so that at least in the end, there will be some topics in your mind. You will feel like you have revised almost everything. Now definitely we cannot explain each and everything in these classes, but just to revise the topic. No test now beta. अब देखिए last 1 week strategy. In last week simply revise the short, means the topics which you have decided to revise in the last 1 week. So simply revise the topics. Which topics? The last week topics, marathon topics, the PYQ topics, right? No test, no GT, no CBT, no assessment. Okay. So this is about the class. If you have any doubt, you can connect to me on this number 8920190076. This is my WhatsApp number. If you have any doubt, you can connect to me. But please, no distraction now, no new thing, no assessment. Simply revise the topics which have been asked frequently in the recent 5-year exams. Revise your short notes. Revise those topics only. Okay, but just go through like this. Okay, that's all. Not PYQs, PYTs beta, PYTs, right? Okay, चलिए, thank you, bye bye. I wish you all good luck. बहुत अच्छा करके आओगे आप, अच्छा करोगे. 28 तारीख को हम देखेंगे रिकॉल में कि आप कितना अच्छा करके आओगे. That's all. Thank you, good night.